Hey. Are you okay?
Good
Magandang
morning.
araw and welcome to the WePump Basic Life Support Program. Recently, there was I think it's still up right now. In Clark, there is this emergency medicine conferences. And one of those is the consensus on, doing CPR here and there, attended by doctors, nurses, paramedics across Asia, and even from the US. There's a good friend of mine, David Page, who was there also. Um, Unfortunately, I was not able to attend because we have a training on urban search and rescue. And my boss, yung the patriarch of the Lopez group of companies, no, ay namatay. And he's a good friend of mine kasi siya nag-finance ng akyat namin sa Mount Everest. And I'm his doctor also until he was brought to ICU. After I arrived to Turkey, he was brought to ICU. Tapos, I visited him birthday niya, April 19. It was 2020, April 22, he passed away. So, it's not really, it's so sad kasi he's one of the best persons I met. Ano siya, kahit mayaman sila, napaka-humble ng tao na yun. And he's a very staunch environmentalist. As in, cum laude sa Harvard. Wow, wala ka masabi. And pag nag-duty ako sa bahay niya, meron kaming ginawang parang ICU doon. Ako yung doktor. Tuwang-tuwa ako doon sa library kasi yung library niya, 2 stories. Tapos meron pa siyang library sa likod. Guy reads a lot of books. Although 93 siya nang when he passed away. But it's just so sad na beautiful people, kahit matanda na siya, sila pa yung sila yung nauuna. So pag umakyat yun ng mga mountains, ako yung doktor. Kaya kaibigan ko siya. Yung tipong pagkausap mo isang corporate tycoon, yung mga tao para kasi naiilang kahit maging friendly siya, you just don't go directly sa kanya kahit very accommodating. Sa akin yung relationship niya iba kasi being his doctor and his friend, parang diretso lang ako pumapasok sa kanila. So it's not a good time, really, na you lose a good person. Anyway, hindi ko alam anong nangyari doon sa College of Emergency Medicine. But we are still updated kasi yung ituturo ko sa inyo, ito yung mga revised na American Heart Association, saka yung CPR for persons with disability, PWD. Or others call it differently abled person. Yun yung na-accept ng UNISDR, United Nations International Strategy for Disaster Risk Reduction. Paano mag-CPR ang walang braso, paano mag-CPR ang walang binti. So na-perform ko po yun, tuwang-tuwa yung UNISDR. Kaya right now, although hindi kasama sa inyong program kasi you are all in hospital, nagtuturo ko paano mag-CPR sa tricycle, mga ganun. Anyway, we thank God for this new day, despite the fact that tomorrows are not promised to anyone. And may you bless us and enlighten our minds that we will learn things today in order we can save lives and ease the pain of humanity. Always lead us to the straight path. Take care of our families and protect us from the surge of COVID again. And may you also protect other people who are now working in the front lines, facing COVID and other hazards in life. Lead us always to the straight path, the path you have shown to those who have left us. Thank you very much, Almighty God, the Lord of all the worlds. Amen. So I'll share my slides now. The basic life support is 2020, pero nag-a-adjust tayo. Meron akong i-include lang ng mga few adjustments of 2022. 2022, yeah. This BLS program is actually kahit ASHI tayo, pero ang pinagkukunan natin ay yung pinag-agrihan ng ILCOR sa kanang AHA kasi sila yung researching body. Now, basic life support has, by the way, I'm sorry, I'm Dr. Ted Esguera. I was trained on operational medicine. So when I say operational medicine, ito yung field, no? So wala siya dito sa Pilipinas. I worked before as a flight doctor sa Second Air Medevac sa Middle East, and then flight doctor sa South America, and then lately I'm a aeromedical director of Binaik Air Care. Isang work ko is very contradicting. Manager ako ng crisis, no? Because I'm trained on disaster medicine. So any ugly things, pag ugly na siya, sa akin napupunta. So I work in Energy Development Corporation, and there's a Lopez group of companies yan, even Binaik Air Care. Kaya yung may-ari niyan, sumakabilang buhay na. Balang araw, pag mamatay ako, akyat ulit kami ng bundok wherever that mountain is. So, I'm also the doctor, if you have heard of the Filipinos that climbed Mount Everest and sailed the ancient boat, the Balangay. We sailed it for almost 20 months, 15 plus 5 months, around 21 months. So we sailed it, no, as in sail across Southeast Asia hanggang China. Now, what are the objectives? First is, let's define what basic life support is all about. Kasi medyo abuse word siya. Pati ambulansya, ginagamit natin na BLS ambulance. Hindi pwede basic. Hindi pwede basic life support ambulance ang pag-term sa ambulance. So nalilito lang mga tao. Naging one size fits all siya. And let's look at the chain of survival and how do we do BLS under COVID. And then the batteries of basic life support program, yung mga stations niya. And in case you want to take ACLS or advanced cardiovascular life support, so how do we bridge it? And we term it as BLS primary and ACLS secondary. So basic life support is a basic intervention wherein we address to any unconscious individual because of perhaps of a massive stroke or an MI, no? Or a cardiac arrest, no, with no pulse. For a person with ACS, no, acute coronary syndrome, although hindi niya halos na-tackle doon. Kasi pag ACS kasi meron kailangan ibigay na gamot. Sa BLS, wala kang binigay na gamot except 3. No? Medyo may pagbabago ngayon. Yung 3 na yun ay oxygen. Kung ikaw ay healthcare provider. Tapos pag nasuspect mong hypoglycemia, you can give a oral glucose, and then yung tinatawag na naloxone atomizer. So dahil maraming batteries ang basic life support program, kasama doon how do we treat if some sort of a respiratory problem lang. May pulse ako, pero agonal breathing siya or can't breathe properly. We also deal with foreign body airway obstruction and other things wherein you don't perform any invasive procedures. Ito lang yung kailangan. Sa patakaran ngayon, hindi ka pwede mag-perform ng BLS hanggat hindi ka trained na meron kang certification. You receive a certificate certifying that you were trained under the program, and yun. Pag ikaw naman ay layman, you can perform BLS. Of course, kasi under first aid program, BLS is under that. Sa Pilipinas, nahiwalay si BLS saka sa first aid. Yung trauma management, ginawa nilang first aid. Ang first aid po is the basic of all trauma and then the basic life support. May problema talaga tayo sa understanding terminology. Gumagawa tayo ng sarili nating program na hindi natin naintindihan. Kaya, yun yung isang problema na kahit bakit ang ibang bansa, minsan ay nakakaloko sa Pilipino. Kasi minsan tayo, hindi natin naintindihan, gawa-gawa tayo ng programa na hindi natin naintindihan. Ano talaga yung what was the main mission or objective of the program? So, ang Pilipino, nag-perform siya dito, o ginawa niya na hindi niya nakuha. So, ang scope natin, siyempre, tingnan natin yung protocol, yung pag-compress, AED operation, basic life support in COVID situations, yung foreign body airway obstruction management, how do we do rescue breathing and naloxone. Pag-pronounce niyan, naloxone. Ako dati kasi naloxone. Ay, tama, naloxone. Naloxone. Hindi naloxone. Naloxone. Yung dati ko, naloxone. So ngayon, pag-pronounce, naloxone. So magugulat kayo na ang naloxone ay hindi na siya IV. Although may IV drugs pa rin siya. IV prep pala. Pero makikita nyo paano binibigay niya. Pag hindi ito tinuro, meron kayo na undergo na siya mandatory na requirement siya, prerequisite. Pero kailangan marunong ka bago ka lumukso sa advanced programs. Okay? So, katulad ng ATLS, Advanced Trauma Life Support, although pang doctors to. Pre-hospital trauma life support, ang ITLS, pwede ang EMTs and nurses. Tapos pediatric advanced life support for pedia, of course. Neonatal resuscitation program, management of obstetric emergency and trauma, advanced disaster life support, advanced medical life support, and wilderness advanced life support. Yan po yung mga advanced program. No? Magugulat kayo. Marami palang advanced program. Yeah. So, kaya ko nalaman to kasi nakuha ko po yan lahat nung nasa abroad ako. Ang meron ang Pilipinas is, of course, ACLS. Meron tayong ATLS kasi ang may-ari nito is American College of Surgeons. Tapos ang ang PCS, Philippine College of Surgeons, meron na silang ATLS program. In fact, a month ago, nag-conduct sa Jose Bilingad Hospital ng ATLS. Ang PHTLS ay kinakonduct sa atin ng National Association of Emergency Medical Technicians sa US. So may mga ilang program na pumapasok dito sa Aerof Cebu, sa, I don't know kung meron sa East Avenue. ITLS is meron din dito. Kinakonduct. So, modesty aside, nung nag-take ako ng ITLS so many years ago, nag-top notcher ako dyan. But it's Japan. Mga Japan templates. PALS, NRP, I think meron ang Philippine Heart. MOWET, dati meron kinakonduct ang MOWET, Management of Obstetric Emergency and Trauma, yung Fabella. Hindi ko alam kung tuloy-tuloy. ADLS, wala pa dito sa Pilipinas. AMLS, wala pa dito sa Pilipinas. Ang WALS ay kinakonduct ng Disaster Tech Lab dito under sa wilderness. Kinagkakonduct ako ng ganyan. So, kailan bang huli kong WALS? Kung makita niyo sa video, parang saan ba yung video? Yan. Wilderness Advanced Life Support po yan. Kinanda ko sa Mindanao. Attended by EMTs and nurses. 2022 last year. Last year lang pala yan. Now, what are the batteries what we have to learn in basic life support? So, meron na tayong 6. Kung 5 lang yung tinuturo sa inyo, huli pa yon. Hindi pa kayo updated. So, 6. Magiging 7 na to eh. Chain of survival, maintindihan nyo? Kasi in no way na Hindi nyo naiintindihan ng chain of survival tapos lukso kayo sa BLS program. Yung chain of survival, dalawa po yun. Pang in-hospital saka out-of-hospital cardiac arrest. Tapos compression, foreign body airway obstruction, rescue breathing, AED operation. Hindi ko nga maintindihan bakit AED tayong mga health professionals, AED ng AED. Health professional tayo, hindi na tayo mag-AED. Kung meron tayong AED, automated external defibrillator na fully automated, kasi dati nung panahon ko may semi-automated. Kailangan naka-override sa manual. Tayo pong mga health professionals, manual po tayo. Kasi merong hindi na perform ang AED katulad ng cardioversion, wala siyang gano'n, transcutaneous pacing, wala siyang gano'n. So sige lang, para ma-comply, sige AED. Ang AED ay ginawa para po sa mga non-health professionals. Mga sabihin ko, sorry with the word kung ikaw ay nasa military, yung civilian, pang-civilian yan. Tapos the Narcan or naloxone. So here is your chain of survival. So ang chain of survival natin ay nasa dalawa. Itong IHCA, in-hospital cardiac arrest, saka out-of-hospital cardiac arrest. So hindi dito mundo. So ito talaga yung mundo ko kasi my life is outside of the hospital. I'm not the guy who's, with hindi ako yung doktor na makikita nyo sa hospital. I'm not, I don't feel comfortable with, in the hospital. Although nami-miss ko minsan pag pumasok ako sa hospital, lalo na pag toxic. Gusto ko kasi yung toxic. Nami-miss ko yun. So ito kayo sa in-hospital. So ito pa rin, meron tayong early recognition, and prevention. Kasi ang medicine ngayon parang disaster risk reduction. Nag-invest tayo on how we can prevent. So kaya pinag-aralan natin ano yung mga causes ng cardiovascular incident. Nakita nila na there are factors, bakit tumaas. Okay, I'm gonna scare you guys a little bit. Ipunin ko yung namatay sa isama ko na yung galing kami sa kaming Turkey, kaya yung flag ko sa likod, Turkish flag yun. Kasi nung naglindol sa Turkey, ako yung isang doctor doon. There were DOH doctors there, but I'm the one in the rescue field. Isama ko yun, around 50,000. Isama ko yung namatay sa Aleppo, Syria, yung gera. Isama ko Marawi. Isama ko ngayon Ukraine. Hindi kayang tumbasan ang namatay sa 2 days. O sige, partida 2 days na. Kasi unfair naman. Masyadong marami na yung kamatayan doon na binigkas ko. So sa 2 days, 3 days na lang. 3 days, hindi kayang tumbasan. Sa length of time na namatay yon, tapatan lang kita ng 3 days na namatay sa cardiovascular incident. Okay? So dumadami. And the ugly thing about it, that you have to take it seriously, guys, those who are listening to me. Pabata ng pabata. Okay? Yan. Kaya ako minsan pag nag-open ako social media, nagugulat na ako yung mga kaedad ko. Ngayon ka lang umaga, obituary na naman. Parang laging may namamatay because of that. Anyhow, ang dahilan ay, tingnan muna natin. Ang kadahilanan, meron tayong non-modifiable factors. Ano yun? Wala na akong magawa. Pag sinabing non-modifiable, wala akong magawa. It's beyond my control. Number 1, age. EDAD, edad. Kapag katulad kong tumatanda na, talagang medyo hindi na kasing tikas ng bata ka. Yung blood vessels mo, lalo na pareho sa akin na pangit yung diet, medyo magkakaproblema tayo. Pangalawa, lahi, hereditary. Siyempre, pag nasa lahi mo, kahit diabetes mo lang, not directly related to cardiovascular, pero contributory, ayun na. Okay? Next is gender. Nakita nila ang male, mas mataas magkaroon ng MI kaysa sa babae. Because I attribute it sa, although not in the medical book, but I read it somewhere sa anthropology na ang hormone ng lalaki is testosterone. It's a warring hormone. War. So yung katawan subject to stress because of that. Kaya, yan wala akong magawa. Dito tayo papasok sa modifiable factors. Kaya nating baguhin. Number 1, hypertension. O di pababain natin. Hyperglycemia. Nung nag-COVID ako po ang fit po talaga ako. Kasi, my kind of job and yung, siyempre, kahit papano, hindi na ako ganong nag-aakyat ng mga matataas na bundok, the likes of Everest. Pero extreme yung, yung physical configuration mo. So, nung na-COVID ako, hindi ko matanggap na humina talaga ako. So, malakas akong tao. Tapos, nung after COVID, daming lumilitaw na minsan may surges ako, nag-hyperglycemia. Tapos, nagno-normal naman. Grabe nagawa ng COVID sa katawan ko, sinira niya yung brain ko, lungs, and liver. Although yung liver ko na ayos, tapos nagpa-check ulit ako, medyo tumaas yung liver enzymes, konti. So, na-freak out na naman ako. Anyway, I'm more suffering from depression of getting those little sparks of abnormalities. Freak out ako sa ganun kasi nasanay ako na ang katawan ko ay malakas. Pero tinanggap ko na. So, ibig sabihin, mas palapit siguro ako sa kamatayan. Kaya, yun, mataas sugar, tapos hypercholesterolemia, di pababain natin, depende anong tumataas doon. Pwede tayo mag-statin, kung mataas yung mga or statin or fibrates ka. So smoking, naku, Diyos mio. Although ako wala akong bisyo, I don't drink, I don't smoke really. Kung as in, kahit juice nga, hindi ako, maasim tiyan ko. Pero minsan papasaway ako ng juice sa pero talagang nag-reflux ako. Smoking, obesity. So we have to really trim down. Sedentary lifestyle. O mag-start tayo exercise. Ako tamad na rin ako. Although may bike ako, saka I'm used to running around. Nag-exercise na ako. Minsan pag nagtuturo sa sundalo ng combat medicine, pag takbo din ako. Other than that, nakatamad din kasi siyempre, katulad dito, I'm discussing with you, wala akong exercise. Tapos yung life ko, karamihan medyo hirap pag hindi ako mabigyan ng time. Pero that's not an excuse. So those things we can modify. We have to strictly, with or without inspiration, gawin sana. Kasi or else statistics ang kinalabasan natin ito. Kaya yung early recognition and prevention, dyan tayo nag-invest. Kung palakihin ko ang chain of survival, ang investment ng medical science ay nandyan. Tandaan niyo, dyan nag-invest. Kasi ang dictum ng medicine, an ounce of prevention is better than a pound of cure. Doon pa rin tayo. Then we have activation of emergency response. Baka kasi nabasa niyo activate EMS. Hindi na natin ginagamit yung EMS or emergency medical services kasi hindi lahat ay merong EMS program. Sa Pilipinas, marami tayong EMTs, marami advocates of EMS katulad na ako, pero walang batas. As in, walang solidong batas. Labo-labo. Dito ako nakakita na ang EMT, ang sweldo ay traffic aid enforcer. Hindi ko naman binababa ang traffic aid enforcer, but EMTs are, you're riding in a helicopter or ambulance, mataas ang risk mo. And then high quality CPR, push hard, push fast, no? Yun pa rin yung patakaran. No interruption in compression, adequate recoil. Sa bago, no, sa 2020, push hard, push fast with adequate recoil. Pangalawa, no interruption. Pangatlo, shifting of the compressor every 2 minutes. Then defibrillation. One of the greatest inventions of man is a defibrillator. Tataas talaga. Ilang beses ako witness niyan. Because I have my own defibrillator. Sa pangbahay, at pag merong event, dinadala ko siya. So doon mo makita na grabe, mas mabilis bumuhay ng tao may defibrillator kaysa sa plain CPR. Then post ACLS care, and then dinagdag lately is recovery. Para siyang after we admit the patient and we bring the patient back to his family, kailangan ang family and community must be cooperative also to the condition of the patient. So ito medyo malaking component to, no? Kasi ito yung dudugtong naman sa harap, babalik na naman yung chain of survival mo, babalik naman yan. It's like a wheel, babalik siya. So preventive ka na naman. Ang recovery ay preventive for the second episode ng attack as much as possible sana. So PSG yan, primary support group, palakasin. I-explain sa family at sa community, which is ang ating bansa ay hindi friendly. Ibig sabihin, kunwari na stroke. Saka nakakita dito na may yung mga bawal pala sabihin PWD. Kailangan daw kompleto. Person with disability, bawal sabihin ng PWD. O yan tandaan niyo yan. So yung person with disability lane, yung sidewalks natin, hindi pabor sa kanila. Ang pagkakaiba lang, diferensya lang dito sa out of hospital, ang nadagdag lang itong ambulance. Pwedeng air, land, sea. Basta nadagdag siya. At ang nawala sa kanya is prevention. Of course, I cannot prevent something na hindi ko naman alam. Nasa streets lang. Hindi ko naman kilala yung tao, pinick up lang kasi may nangyari sa kanya. You don't know what's the background. Na naman. Yun. Ito yung pediatric BLS, halos pareho, except ang pagkakaiba, pagdating dito sa out of hospital care para sa pedia, andyan pa rin si prevention. Uy, bakit sa adult wala? Iba po yung ating konteksto when it comes to bata. Kailangan, masakit, kahit ako, experience ko yan. Between an adult and a child na hawakan ng kamay ko, kunwari namatay sila, mas lumalamat yung bata sa akin. Pag pumipikit yung mata ko, mas nakikita ko yung mga mukha ng bata na hindi ko na-save kaysa sa mukha ng adult. Kasi at the end of the day, nakakalimutan ko lang yun. Numero lang yun. No? That's the ugly thing sa life namin sa field na nakikita namin. Para yun lang. Now, the usual rundown is always the scene assessment. Okay? Then you assess responsiveness. Tuturuan ko kayo anong pag-assess responsiveness. Tama, although sa BLS ngayon, hindi pa ito naturo, pero unahan ko na kayo. Sa assess responsiveness, ang ginagawa po natin ay ito yung tao sa video. Tatalikod sa inyo, so trapezius fins po. Trapezius muscle. Pagtapik, hello, sir or ma'am. Trapezius fins po yan, ipipins mo po yan to check the pain appreciation of the person or the pain sensation. Bawal po tayo external rub kasi bawal na po sa American Heart Association 2015 pa yata yun. Bawal po. Sa atin, yung to elicit pain is trapezius fins. Hindi po halata yan kahit kunan nyo sa camera. Kung gawin nyo sa sarili ninyo, wala pong dating. Pero pag may ibang gagawa or igagawin mo sa iba, makikita mo, ngingiwi yung mukha sa sakit. Sama po yun. Now, if I will use the word cold blue, Baka nalito kayo, ano yung cold flu? So, sa pinanggalingan kong hospital, we use the word cold flu for cardiac arrest. So, baka lang minsan baka mabanggit ko cold flu team. Yan po yung mga cardiac arrest team. Any cardiac emergency, cold flu team. Kung meron kang ibang pangalan, wala namang batas talaga dito na ito yung pangalan, pero most hospitals yan talaga. Nasa inyo yan. I hope you will not misunderstand me if I say cold flu. Pag narinigan niyo ako ng cold flu, ibig sabihin, it's the cardiac team. Okay? Cardiac arrest team. Ngayon, before CPR daw, kailangan may cover muna ang mouth and nose ng patient, whether with a non-rebreather mask or a plain mask, no? Surgical mask. What happens when you are undergoing cardiac arrest? Meaning there's no hemodynamics, there's no blood which is being pushed around the body, particularly to the brain. So, mamamatay yung brain mo kasi sensitive talaga si hypoxia. Yung heart mo maapektuhan. Kaya 0 to 1 minute, ventricular fibrillation pa yan hanggang mawawala na. Tapos pag lampas ng 1 minute, no? Pababain ko lang to kasi ito nang ginawa to hindi to pang tropical country, iba sa tropical country. Hindi 10 minutes talaga, 8 minutes sa atin, 7 to 8 minutes time. So within 3 minutes, brain damage not likely pa. Pag 3 to 5 minutes, brain damage possible. From 5 to 8 minutes, brain damage very likely. Beyond 8 minutes, ang hirap buhayin. O sabihin na lang natin 10, sabi dyan. Pero mas mabilis mag-deteriorate ang kapag mainit. Now here, in this picture, as you can see, ang isang tao, walang ginawa sa kanya, nag-ventricular fibrillation siya or yung arresting rhythm mo, namatay. Dito naman, pangalawa, arresting rhythm out of nowhere, may nung nag-defibrillate, meron daw percentage. Ito naman, may CPR pero late yung defibrillation, sabi nila 8%. Dito yung medyo pagbabago konti. Lukso na ako dito sa ibaba. Pag na-perform mo lahat yan, umakyat actually yan ng 80%. On a certain age bracket. Kasi that's not really followed. A certain age bracket. Now, what is the due procedure? Yung tinatawag nating interim guidelines of American Heart Association of 2022. So yung interim guidelines, kung ikaw ay member ng cold flu team, huwag kang rumisponde na wala kang level 3, level 4. Okay? Yan, magkalinawan tayo. Level 3, level 4. Ibig sabihin, N95 dapat. At hindi na tayo ideal 6. Although ideal 6 for ACLS, nililimit na ang personnel. And kung pwede, kung social, kung pwede sana ang compression ay hindi na tao. Kung hindi, mechanical CPR, yung pneumatic na siya nagsi-CPR. Although ako, hindi ako comfortable to. No? And then, you have to consider that everyone is COVID positive. So, the first C in the 10 C's. No? Now, before, ang inuuna natin ay compression. Medyo nagbago ngayon. Ang tinitingnan natin is compression pa rin naman by virtue of reviving the patient. Pero ang inuuna natin is anything. Can you hear me? Hello? Unstable yung internet ko. Can you still hear me? Hey, are you okay?
Yes po.
Narinig pa ba ako?
Yes po.
Am I okay?
Yes, sir.
Wala akong kausap.
Yes, sir.
Yes po, naririnig po.
Ma'am Joy?
Okay po, okay
Yes,
po.
Doc.
Malinaw, Doc, malinaw, Doc. Meron, Doc. Yes, Doc. Yes po.
Okay.
Yes po.
Now, dahil COVID ngayon, alam mo, nung time na nagsa-search siya sa 2020, pag sinabi kasi ng ano yun, American Heart Association 2020 standard, wala talaga ni-mentions COVID ng panahon na yun kasi nang ginawa yun, mga 2018, 2019, tapos pin-print out for 2020. Pero yung kanilang pinag-usapan, kaya walang COVID. So nag-interim guidelines sila 2022 because of the 2020 heightened COVID cases, no? Kaya makikita mo rito, grabe pa, no? Use HEPA filter, then intubate early kung ACLS to, maano yung makikita nyo sa ACLS. Tapos McBent kagad, no? Engage the intubator. Ang intubator ay yung nag-intubate, no? Yung ating intensivist. Tapos pag sinabing first pass success, yung unang intubate, pag intubate mo, yun, first pass tawag ko doon, no? First pass success. Dati, hinto. Nung panahon ko pa, hinto, intubate. Tapos merong panahon na tuloy-tuloy lang yung compression, intubate kasi walang no interruption. Nakikita naman yung airway kahit tuloy-tuloy intubation. Then ngayon, hinto na naman. At ang ini-encourage ay video laryngoscopy. Nasira yung hiniram, hindi na rin ibalik. No? Naka-video. And then, kailangan yung mga bag valve mask. Kalimutan kong bumili. Yung bagong bag valve mask na mayroong HEPA filter sa dulo. So, yan yung mga pagbabago ngayon. Okay. Anyway, most of these are ACLS programs sa ACLS plan. So, ito rin yun, no? Kailangan PPE and the issue here is there must be an air corridor. So, depende sa formation ng mga beds ninyo, may air corridor kung saan dumadaan yung hangin. Merong inlet, merong outlet. Gagawa kayo kasi actually, modesty aside, nung nagkagulo-gulo pa sa COVID, sinuggest ko rin ventilation. Tapos, alam mo naman, among doctors, pag medyo consultant, siga na, no? So, ako po ay na-train sa military medicine. The civilian doctor and the military doctor, magkaiba po ang mindset niya. Ang civilian doctor, they look at the virus as simply the virus that needs to be treated. Sa military doctors, iba po sa amin. We look at the virus as something to be treated, but we look at it as something to be weaponized. So kung gawin ko siyang weapon, meron dapat akong treatment on the other hand. Kaya kaya medyo may pagkakaiba ng paningin sa virus. Okay, don't misinterpret me on this line na ang COVID is bioengineered. I leave that to you. So, yung way of eradicating it, meron kaming programs of protecting ourselves. Isa doon is with corridor. Tumataas kilay sa akin, even DOH, kasi ang sasabihin sa akin, are you, yung mga infectious disease ka ba? Gaganunin ka agad, no? Yung isa pa, yung mga nasa DOH nagtatrabaho, parang tataasan ka kaagad ng kilay. Sabi ko, nang inintroduce namin sa office namin yung ganong program. So we were way ahead. Nung nag-lockdown ng Pilipinas, unang nag-lockdown yung company namin. We call it the war doctrine. Sagad sa langit yun. Tapos, when everyone was washing their hands, we have work from home structure. Kaya magpasalamat ako sa Diyos, but this is not to insult anyone. Hanggang ngayon po, nagre-recession po ang Pilipinas. Lots of countries, when I was in Turkey, they are undergoing recession also. Kami po sa pinagtrabahoan ko sa Energy Development Corporation, wala po kaming naranasan na. Hindi kami naalisan ng tao at wala kaming recession. Why? Kasi ganun kami ka-ready. Because when my boss asked me, ang sabi ko lang, war doctrine tayo, sir, sagad sa langit ang preparation. Nahirapan kayo maghanap ng N95? Meron kaming 8 crates of N95. Meron kami bago nagkaroon ng shortage. So we will not be accused of, yung grabe memory. Of course, nangyari yung aming preparation way back before. Kasi marami kaming protective equipment dahil pumupunta kami sa Africa for geothermal sources at yung Africa is known for Ebola. Kaya ni-ready lang namin yun. Tapos nung nag-COVID, hindi kami hirap. So, pati yung ventilation, sinunod na yung mga open the window konti, pasok yung hangin. Pinako po nila ako sa cruise nang sinadjust ko. So, aawain pa ako ng mga consultants here and there. Tapos yun din pala susundin. Doon ako na iinis at nasasaktan. Susundin nyo rin pala eh. Pero babanatan nyo muna. Yan ang medyo problem sa Pilipinas. We don't know how to take care of people. Di ko sinabing magaling ako. Nagkataon lang, yung aking discipline, yung aking specialty ay medyo kakaiba. Medyo mingling kami on mga weaponized resources. So we look at it differently. Kaya kung papansinin nyo, marami akong mga gas mask. Paligid dito. Ay ano, nasa harap. Ayan, puro gas mask. CBA, meron ako ka-doktor-doktor ko tao, may gano'n. Kasi ito yung life na pinasok ko. The world we look at the world as a harsh, violent field. Anyone can throw CBRN, chemical, biological, radiological, nuclear entities. No? So, yun ang paringin namin. Kaya when the COVID came in, hindi medyo nahirapan kami ipaintindi. Yung world outside lang, medyo, although we got experts from PGH and UH, but we have our own internal dynamics. Now, itong nakita niyo sa slide ko, ito po yung mga dinagdag nila. So I will not run them one by one. So these are all simply, kailangan may HEPA filter. The huge one and the little ones. Ang little ones, HEPA filter, doon mismo sa
Ako seminar. Para schema.
Tapos, minimize closed circuit disconnection, yung closed ventilation circuit disconnection, para less touch tayo. Tapos, paano tayo mag-commit to ethical and evidence-based termination of resuscitation policies. Maituturo ko ito pag ACLS na. Hindi ko pwede maituro sa BLS. Kasi dito sa end of resus, no, sa termination of resus, ang ginagamit talaga ideally ng AHA bago mag-declare patay ng tao is a capnometer. Hindi katulad sa atin, mata-mata tayo baga titingnan kung nag-dilate ang mata magko-constrict. Ideally, no, because we should be practicing evidence-based medicine. Dapat doon tayo sa AHA kasi researching bodies. Okay? So this is the new program. So kung makikita natin sa program na to, so dito ako mag-emphasize. Okay, ano ko lang ha, palakihin ko tong isang area na to kasi ito yung nadagdag. Okay. Palakihin ko lang. Ito yung nadagdag sa gilid. Kung hindi.
Ay, loko.
Sa buong basic life support, ito ang binago nila. Obligatory, kung makikita niyo yung cursor ko, don't PPE. Okay? Limit personnel. Dati wala ito. No? Sa interim guidelines of 2022, baka hindi pa naituro to. Alam ko, malakas loob ko, alam ko hindi pa naituturo sa Pilipinas. Interim guidelines, don't PPE, limited person. Pagdating dito, bawal na po yung mga tinuturo na yung mga mouth-to-mouth, what no? So dito, kailangan BBM. Kahit sa out of hospital, BBM with tight seal. Okay? So, i-commit mo ang bag valve mask una bago ka mag-compress sa tuman. I-demo ko yun mamaya para hindi tayo magkalituhan. Sa in-hospital, huwag na huwag mag-compress na walang bag valve mask nakalagay sa bibig at ilong. Or walang nakalagay na non-rebreather mask kung wala kang bag valve mask. Or walang nakalagay na mask kung wala ka sa dalawa. So no CPR when there's no barrier. Yan lang yung emphasis. Yan. Okay? So balik ulit tayo. Balikin ko ulit. Okay, so ito yung bago niya. And then, nagdoon ka ng PPE, and then you check patient's responsiveness, and then you call for help, check if there is 10 seconds pa rin, check if there is pulse, kasi healthcare provider tayo. Although ngayon, sa non-healthcare provider, tinuturo na rin ang pulse check. O, nagugulat kayo, no? Meron mga pagbabago po ang even first aid ngayon. Bakit kayo nagbago ng napakalalim or napakataas na leap? Kasi nakita nila noong COVID, nung nag-lockdown lahat, ang tao pwede pala turuan na maging a little doctor for himself and his family. Pwede pala. So why don't you not just put limits on the capability of man? Totoo nga pala yung kasabihan, austerity is the father of invention and innovation. Nag-innovate talaga ang tao. Austerity. There are two fathers of invention. War and austerity sa kawalan. Gera is the father also of invention. Tanong. Wala pala. Okay. So, ito naman sa pediatric, halos ganun din. No? Except, yung ating, kung kailangan tayo mag-defibrillate, medyo nag-adjust lang tayo ng juice. Sinama ko lang din dito. Kasi pag sa bagong program, laging may pedya. No? So, ang pedya natin is 8 years below. 8 years up is adult. Yan ang demarcation. Sir, kung arresting ang patient, paano ko malalaman kung 8 years up siya o 8 years below? Paningin na lang po yun. Kung sa paningin mo, pediatric talaga siya, pediatric program. Kung adult, the adult program. Ganun lang, para hindi kayo nag-aaway na, hindi, pedya yan, 8 years below yan. No, hindi ganun. Sa paningin na lang. Sa disaster management, ganun din, 8 years din. Para malaman natin, ang adult which we will employ start, 8 years up. Pag pedia, we employ jump start, 8 years below. So, yan. Okay? Ito yung luma. Pinapakitaan ko lang ng luma. Wala yung emphasis sa don PPE. So, dito lang sa wala siya yung katulad ngayon, dinagdag to. Grabe emphasis dito para hindi lumipad yung mga aerosolized entities. Okay. So this is the usual BLS package for adult and pedia. So i-demo ko to mamaya sa demo time, no? I leave the reading to you. So demo para makita nyo ano ang tamang forma, paano mag-demo, paano mag-CPR sa drowning. Ayan. Kung makalimutan ko sa drowning, ipaalala niyo. Tapos recovery position, paano kinakonduct ang recovery position sa usual at saka sa drowning. At saka sa anything na kung ang pasyente ay may tendency sumuka at the patient is so weak na pag sumuka na kasi ang pasyente, conscious na yan. Pero depende sa form suka, naiangat ba at na pipihit ang ulo o hindi. Or siya ba ay nakalock sa X-collar or C-collar na hindi niya mapihit ang ulo tapos susuka siya? Tipong ganon. So we have those kind of consideration. Ito yung not so distant past. Ito yung sila. Pero ito bala bago nag-COVID. Yan na. Bago nag-COVID. Ito yung not so distant past. Halos pareho lang. Okay? Ang nagbabago lang dito is the speed of the compression. 120 kasi tayo ngayon eh. Dati 100, ngayon 120. This is also like a table on how you perform it, no, for different brackets of population. Okay. Ang pagkakaiba lang natin ay child and infant here sa Activate 911. Kasi pag witness collapse, iwanan mo yung victim and then call for 911. Pag unwitness, perform 1 round bago ka tumawag ng help. But I will not let you just, do it kasi sa Pilipinas, wala po tayong good Samaritan law. Kaya medyo case-to-case basis ako dito. Although hindi to problema ng doctors and nurses kasi meron tayong PRC. Pag tanungin tayo may PRC, pangalawa may batas sa revised penal code. No? Ipapakita ko sa inyo mamaya ang revised penal code. Kailangan, although wala pa naman ako nakita sa news na nagkaka-issue, lalo na sa pre-hospital care. But we have to be worried because marami ng Pilipinong nanonood kasama mga lawyers doon ng mga Grey's Anatomy, nakakakuha na ng idea. Ganito pala yun. Pag naka-take off dito ang legal med, ang mga lawyers who's gonna chase EMTs, no, yung mga paramedics, tapos mga doctors, nako, malaking pera yan. No? Kung i-charge ka with negligence, patay. Kaya minsan kailangan balikan natin yung ethics. Tapos yung if there's a breach of contract. Ito naman yung luma. Okay? Halos ganun din. Halos walang pinagbabago. Now, ito yung usual 1 rescuer versus single rescuer to 2 rescuers. Although ito ay mainly pre-hospital in context, tsaka hindi siya COVID related. So, ide-demo ko mamaya pang COVID talaga na in-hospital. Noong 2020, dinagdag kaagad to. Hindi na isama sa libro. Hinabol nila sa pre-hospital care. Anong ibig sabihin sa pre-hospital care? Bago mag-compress, kailangan naka-cover mo na ang mouth and nose of the patient using surgical mask. Ngayon, may nakita ako. Hindi pala nakita. May narinig ako, nag-attend ako, American Heart Instructor. Using mask sa patient bago mag-CPR. Tapos ang ginawa sa mask, binaliktad. Wala ni isang doktor nagtanong. Dahil hindi naman ako direct student niya, ayoko magtanong. Ang problem doon is hindi naintindihan ang mask. Kahit ngayon, maraming doctors and nurses nagkakamali sa mask pa lang. Doon ako nakakita ng mga doctor or nurses na nagdadalawang surgical mask. Naku, Diyos mio. Wala pong kasayang-science yun. Bakit? Hindi yun ang first intention ginawa sa kanya eh. Tingnan niyo ako ha. Mask. Okay. Okay, magalit ha. Ako hindi nagsasalita in behalf of me. And I'm not opinion. Dito tayo sa evidence-based. Particularly air and liquid under pressure without the influence of temperature. Okay? I know you love physics. Pag huminga kayo, saan dadaan ang hangin? Doon sa corridor of least resistance. Halimbawa, kunwari ang paghinga ko ay ilong bibig. mas maraming dadaan sa bibig kasi mas malaki kaysa sa ilong. Ang ilong dadaan sa turbinates, marami siyang iklikot kaysa dito halos diretso sa airway. Okay? So doon siya dadaan. Kung talagang buka and hihinga lang ako without the intention na hihinga ako sa ilong. Okay. Ngayon naglagay ka ng mask. Ang area of least resistance mo, is through the mask. Kasi tatlo ang layer ng mask eh. The outside repellent layer, which is color blue. The inner absorbent layer, which is color white. And the middle filter. Aerosolized, aerosolized material. So may matatrap siya. Okay. Ngayon, saan ang least resistance? Hindi naman lahat ng mask ay pareho ang size. May nga mask pag malapad yung mukha mo, then maliit ang mask. Pag maliit ang mukha mo, pati mata mo na mask. Saan ang area of least resistance? Ituro ko sa inyo ha. Ito, pag naglagay mask, ito. Gilid. Maraming doktor or nurse, ini-X nila to. Nag-flare ang side, area of least resistance. Pag huminga ako, papasok doon. Hindi na dumaan sa filter. Pangalawa, dito sa gilid, area of least resistance to. Pwedeng pumasok. Here comes the double mask. Tinaasan mo ang resistance ng dalawa. Saan ang tendency pag hiningal ka? Ang papasok, dito, kasi yun yung area of least resistance. Mag-aral tayo ng physics, guys, para maintindihan natin if we are really safe or not. Hindi dahil sabi nila. Kung hindi sabi ni Ganong, sabi ng physics, sabi ni Snell ng anatomy. You know why we fail? Because we forgot the basics in life. Kahit gano'n na tayo kagaling, pag wala tayong basic, sablay tayo. Meron pa. Naglagay na ng mask, naglagay pa ng N95. Ako, Diyos mio. Di naglagay ka ngayon ng breach of seal. S-E-A-L. Pakiramdam mo lang yon. Akala mo lang. Pero lumulusot doon sa area kung saan lumalabas yung mask mo. Error na naman yun. Now, if you don't agree with me, go in-depth study. In-depth lang kayo. Basa lang kayo. Don't listen to me. I don't want you to believe me. Find it. But please, when you read it, read physics. Ha? Kasi kung gusto niyo magaling tayo sa mundo, maintindihan natin yung mundo, isa sa dapat magaling tayo physics. Maintindihan yung mundo. Kahit anong subject pag-usapan, numbers will never lie. Okay? Dapat ganoon tayo sa new normal. Kailangan mas magaling tayo. Hindi lang yung magaling tayo sa pagiging doktor. Pwede magaling tayo sa arts, philosophy, sports, faith, science. No, para tayong dapat parang si Leonardo da Vinci. Para mas maintindihan natin. Kasi VUCA world na tayo ngayon eh. VUCA. No? Very volatile, uncertain, complex, ambiguous world na. So, kailangan ngayon, meron pa tayong kinakatakutang gera ng China and Taiwan. Ako, Diyos mio. 72.86% ang tendency. Kinumpute namin ng actuarial mathematician. We had a international disaster conference in Bali. Kinumpute po yun. Kinumpute ang China. Ang China will rule the world for more than 100 years. And then, kinumpute the likelihood of war, 72.86. In my language, that's high. So I really don't like it. I'm the guy who saw war, and I don't like war. Sometimes you get excited with war just because you're watching movies. I was in war. I saw gunfight. You will never like it. It's crazy. Now, ang mas mailagay natin ay hindi, depende to sa inyo, unless kasi kayo, kung hindi ka naman kayo advanced hospital, may kunwari, nasa malayo tayo, walang non-orbital mask, lagay niyo yung mask. When you don the mask, bago kayo mag-CPR, ang blue outside po. Para yung aerosol, contaminate. Bakit? Kasi repellent, pag bawat push niya, saan? Hindi ma-absorb. Ilalabas doon sa gilid. O di, na-inhale. Kung ako yung nag-resource sa pasyente, ma-inhale ko. Okay, so ito yon for child and infant. Now, if you look here, since 2010 po, hindi talaga ako advocate ng ABC, airway breathing circulation. Talagang circulation talaga ako una. Tapos, ito lang yung ginagamit kong chart. I'm not really fond of AHA noon. Badger County ako and Arizona system, all compression. AHA adapted it like later na like between 2010 and 2015. Pero nauna na si Badger County at saka si Arizona on all compression. So bakit? Pag nag-compress ako at napakagandang compression ko, kung titingnan nyo lang I want you to look at me right now in the video. Okay? So in the video, tingnan nyo ako. Pag na-collapse yung lungs, labas yung hangin. Pag nag-recoil yung the lungs does not recoil. What recoils is the thoracic cage. The lungs follow suit because of the negative pressure in the pleura. So boom! Pag recoil niya, kusa pumapasok si hangin without you doing it. So collapse, recoil, collapse, recoil, collapse, recoil, collapse, recoil na lang. Collapse, recoil, collapse, recoil, collapse. Hangin pumapasok. On the alveolus, which is the functional unit, ay napalibutan ng tawag nito, ng capillaries. Tumatakbo yung blood sa capillaries, nag-absorb ng carbon dioxide at nagbibigay ng oxygen. Sa anong paraan? Can someone tell me? Okay, I know no one's gonna answer. Sa tinatawag nating diffusion mechanics. Tandaan nyo ang ating alveolus, ang nakaline po dyan ay simple squamous. Squamous are flat cells. Napaka-sensitive po. Kaya pag nag-yosi kayo, mabilis po sirain ang squamous cell. Kasi manipis lang siya. Mabilis magbiyahe si oxygen across. So si oxygen in high percentage nandoon sa intra-alveolar kasi galing sa environment. Ilang oxygen galing sa environment? Ilang percent? Nako, nurses, doctors should know that. Kung allowed lang mag-mouth to mouth, although allowed ang mouth to mouth kapag ang nag-arrest ay bata at kamag-anak mo, or kapatid mo, pwede mouth to mouth. Kasi magkasama kayo sa bahay, okay lang. Kasi karamihang arrest ng bata ay respiratory. Yan yung mga medyo variations na. How many percentage oxygen I'm inhaling right now? May sumagot.
Wait.
16. Hindi po Okay guys Total tayo lang naman dito. Don't be offended. May nagsagot pang 40. Si Lily, sabi niya 21. Tama ko yun. But the question is for grade 1 up to grade 5. My question for nurses and doctors, if there are doctors here, is what law in physics am I trying to point here? Or the total gas law, what law? 21. Sabi ng law. Anong law? Huwag tayo magsabing 21. Kaninong law? Or to make it short, total gas law. Kung hindi kayo nakakaintindi total gas law, the partial pressure of nitrogen plus the partial pressure of oxygen plus the partial pressure of other inert gases corresponding to 100%, which is at 760 millimeters of mercury, sea level. No, that's not hemodynamics. Ang hemodynamics is distribution of blood by the pressure exerted by the stroke volume of the heart. Bawat buga niya, yung hemodynamics. Kung okay ang hemodynamics, ibig sabihin okay ang heart. And also, the dilation and the constriction of the vessels involved. Yan ang principle ng hemodynamics. Para maintindihan natin, after pag na-resus natin ang pasyente, okay ba ang hemodynamics? Because if the vessels in the periphery are super dilated, you will have poor hemodynamics pointing towards the brain. Mga ganyan, no, principle. Yan ang hemodynamics natin. And the heart cannot pump because the heart has a heart block, a second degree type 2 or a complete heart block. Dalton's law, I love it. Woohoo! Galing. Dalton's law, yeah. So, yan lang. Hindi. I love it. Ngayon, habang nagre-recoil, pumapasok po yung hangin. Pagpasok ng hangin doon sa alveolar level, doon po nagpapalitan. Ito yung kamay ko, tingnan niyo ako sa napaligiran po ng capillary. Tingnan niyo ang capillary, ang napaligiran. So kailangan, habang nagsisipiyar ako, tumatakbo po yung dugo. Habang tumatakbo ang dugo, dumadaan sa alveolus. Yung oxygen na 21%, sabi ni Rosalind Ruth. Sabi ni Rose, or what? Ruth. Sabi ni Ruth, Dalton's law. So nandun si oxygen, 21. Ito si alveolus. So tumatakbo ganon. Ito ay ta-transfer doon sa capillary by virtue of diffusion. To be precise, it's called passive diffusion. It's the movement of the particles from an area of higher concentration to an area of lower concentration. Ganon din si carbon dioxide dito. Movement of solute. Passing through a permeable membrane, permeable to that solute. Or a semi-permeable membrane. Or I think it's a permeable. So without you thinking about it, it's a passive process. Ibig sabihin, no energy requirement. You don't even have to think about it. It happens. Okay? So palit siya. Kaya, kung titingnan nyo ang aking slide dito, bawat hinto mo, bagsak yan. Wala oxygenation sa brain. Bagsak, wala oxygenation sa brain. When I reach 140 to 160 millimeters of mercury, napakaganda oxygenation sa brain using 21. Huminto ako, nagbigay ako ng hangin. 1, 2, meron ba pumasok na hangin sa capillary? Halos wala. Bakit? Hindi siya tumatakbo eh. Ang requirement para pumasok ang oxygen, kailangan ang blood tumatakbo. Hindi naman nagsi-CPR. Kaya hindi talaga ako advocate. Hindi ko sinabi magaling ako. Binasa ko lang yung Guyton. Guyton is one of the major authors ng physiology, lalo na pag nag-medicine. Doon sa area ng yung chemistry, yung parang physics and chemistry of respiration. Kung na maalala yun, parang naalala ko. So many years ago. Yan. So, dito, ito yung mga nangyayari. Humihinto ka lang, pag nagbigay ka ng hangin, pwede. Bakit pag 2 rescuers, pwede? Yeah. Okay, ang requirement, hihinto ka, after 30 compression, bigay ka ng 2 breathing, there are 2 requirements. Number 1, dalawa kayo. Pag nag-isa ka, wag. All compression ka lang, dalawa kayo. Pangalawa, kailangan ang bag valve mask mo ay nakakabit, BVM ha, yung tinatawag yung AmbuBag, brand name po yon. Ang tawag po dyan, BMV or BVM, bag mask valve or bag mask. Bag valve mask. Woo! Hirap ng English. Okay, so yan. Kailangan nakahook into 15 liters of oxygen. Ang inyong flow rate sa ospital, only 10. Dumadaan pa sa humidifier. Hindi po yan ang emergency oxygen. Ang emergency oxygen ay hindi dumadaan sa humidifier. Tandaan niyo. What you have is medical oxygen. So, dalawang klaseng oxygen. Parehong 100% ang binibigay, pero dumadaan sa humidifier sa medical. Doon tayo sa emergency oxygen na hindi dumadaan. Kailangan ang flow rate mo ay umaabot ng 15 liters. Yan po ang emergency line. Ha? Dito nakakita ng iilan na nagsi-CPR. 1, ang ginagamit ay nasal cannula. Ako, Diyos mio. Tapos, 4 liters lang. Pag nakuhaan kayo ng video at nailagay sa internet, pagtatawanan na naman tayo ng mundo. Ang liit na naman ang tingin sa Pilipinas. Alam mo bakit? Alam niyo bakit maliit tingin sa Pilipino? Hindi dahil hindi nila kasalanan yun. Hindi kasalanan ng leon na kainin ka kahit pinakain mo siya. Hindi niya kasalanan kasi program siya doon eh. Hindi kasalanan nung nagmamaliit kahit pa sabihin hindi ka maka-Diyos kasi minamaliit mo ako. I'm the little brown man. No way. I work sa abroad. I saw how they discriminate. And I took it like, oh, these people, they're already like that. They have perhaps in them a Anglo-Saxon DNA. They will always discriminate and wage war against me. So ano ako? Magiging tupa lang ba ako, sheep? Or will I convert myself into a porcupine or a sheepdog? Para kahit paano lumalaban ako. So kung gusto nyo lumaban, academically or scientifically, kailangan sakto doon kayo sa science. Hindi dahil yung walang pera. Sige, pag bumulagta yung nanay niyo sa harap ko, sasabihin ko, sige, ibigay ko lang 50% kasi walang pera. That's not who we are. Doon tayo sa EBM, evidence-based medicine, at doon sa tama. Ethically, legally, scientifically. Yan ha. Hindi dahil walang pera. Walang pera, ito lang eh. Gawan mo ng paraan. Hindi pwede gano'n. Now, sa choking, okay, I will just do a demo on this. No? Para mas maintindihan ninyo, i-ano ko lang, I will. Kasi kung sige ako lecture na hindi nyo nakikita, baka hindi nyo ganong ma-internalize eh. Tapos ipapakita ko yung difference ng American Red Cross sa American Heart Association. Okay. Pati sa infant. Now, I go into naloxone. There are two kinds of brand names ng naloxone. Naloxone is the generic. The brand name, yung lang ginagamit ko is Narcan. I have not tried Cloxado, I have to be honest with you. Lalo na intranasal. Ang intranasal meron ako, Narcan. Pero wala ng laman, hindi ko alam saan nalagay kasi magulong-gulong tong kwarto ko. Matagal ko nang hindi nakita yun. Atomizer tawag ko doon eh. Although hindi sila gumagamit ng atomizer kasi pag isirit mo, sobrang fine yung aerosol niya na is atomized. In English, is so atomized. It's called atomizer. Okay, so si Narcan, ang available niya, dalawa, 2 mg saka 4 mg. Si intranasal Cloxado is 8 mg. No? Mas malakas siyempre. Ito, ganito kasi, ganito ang principle. Once you have opioid overdose, no, you will have arrhythmia. Si upper to eh. No amount of CPR and defibrillation, mahirap po talagang buhayin hanggang umiikot ang opioid sa katawan. It's a centrally acting drug. So, dalawa, it's either during arrest, binibigay mo to, sa isang positively identified na OD, ng opium, or sa papunta pa lang doon, may tumawag, tapos na-respondihan mo. Pero kayo, pag nag-responde kayo, at i-reverse nyo ng Narcan, huwag kayo mag-reverse ng Narcan na walang pulis kasama. Kasi pag tinanggal niyo yung trip niya sa buhay, kunwari hindi pa siya arresting, tapos tinanggal mo yung trip niya, pahirapan kumuha siya ng opioid, saksakin ka niya, no? Kasi heaven and earth, na nabangang siya dyan, or na high siya, tapos ni-reverse mo, bad trip yun. So ideally, dapat may police. And although it's not really so much of a problem into sa bansa natin kasi tayo, nakakatawa yung ating drugs. Shabu. Shabu is a poor man's drug. No? Kawawa talaga Pilipinas. Pati man lang sa drugs, low class. No? Methamphetamine is a poor man's amphetamine. Although ito, ang ano nito, your morphine is opioid derivative of morphine. So pag mag-overdose ako, naloxone din yung binibigay. So I have morphine in me for MI and for, although hindi na siya ganong pain, pero for so many years na-enjoy ko siya para sa trauma, lalo na sa military medicine, na-enjoy ko si morphine. So, emergency treatment for OD, opioid OD. Magkakaroon ka, bagsak ang respiration nito. Tapos CNS depression din. And you cannot reverse the arrhythmia. So ayan, atomizer. Kaya siya tinawag atomizer kasi sobrang liit ng mist. Atomized in English. Atom. Okay. Now, if you want to repeat those, kung nasa pre-hospital ka, you can call your, pwede kang humingi ng online medical control, OMLC, OLMC, online medical control, tawagan ka. Unless meron kayong offline medical control, meron kayong libreta, okay, pag hindi gumana, magbigay pa ako ng next dose. Yan. So ayan, ganyan pagsuksok. I hope you understand the drawing. Para ipatama natin sa turbinates, kasi ang turbinates mag-absorb and it goes directly to the brain to reverse the CNS effect like CNS depression. Okay? So ito yung ating rundown. Pag walang response, you can do additional doses, interval of 2 to 3 minutes. Now, I'll give you the thing that I made sa tinatawag na out of hospital kasi baka pag uwi ninyo, nakakita kayo ng pasyente, meron pa akong ginawang 10C, 10 commandments. 10C na. Ibig sabihin, hindi naman ako institution pero gumawa ako. Kailan ko ito gumawa? 2020. Okay. So, new normal style of doing all-hand CPR for adult and child patient out of hospital setting. 10C. Sa Philippine Heart Center, Philippine Heart Association, 5C sila. Hindi ko sinabing magaling ako kasi 10C, no? Nilatag ko lang talaga lahat para wala kayong mamiss sa 10C. Okay, number 1C. Consider everyone to be COVID case. Lalo ngayon, tumataas na ulit ang surge. Lahat ng pumapasok sa inyo, i-consider nyo muna. 2. At usually, hindi naman ni RT-PCR. Inaano nyo lang, antigen test. Nako, saan ka nakakita? Pumasok kong Malacanang, yung antigen test, nandito lang sa bungad ng ilong ko, wala din sa ayos. So, minsan, wala na parang compliance na lang na ewan. Number 2. Check-in, kung if you want 12 pa, check-in. Ang word yung check-in ay ginagamit sa ICS, Incident Command System. Pag ikaw gusto mong tumulong, mag-check-in ka. Hindi ka pwedeng lumukso sa pasyente na wala kang abiso. So, to satisfy my C, allow me to use the word check-in. So, check-in by introducing yourself to the crowd by standard relatives and signify you can help. No? Next. Sa salitang Tagalog, baka po makatulong ako kasi wala nga tayong good Samaritan law unless you are doctor or nurse, may PRC. Kaya ang word, baka po makatulong ako. Yan yung ethically sound. It sounds more rational. Next is case-to-case basis, assuming maraming crowd control kasi baka doon tayo magkaroon ng super spreading event. No, palayuin nyo. Susunod naman yan Ang pinaka-way na command maganda na maintindihan nila. Yes. Bigyan niyo ako ng hangin. Although, hindi totoo yun. Pero, yun na yung way. 2 things. Super spreading event, pangalawa, baka yung backpack mo nilagay mo sa gilid, baka manakaw yon. Nangyari na po sa akin yan sa Ortigas. Ang nanakaw sa akin, napakagandang mug ng, ewan ko, hindi na gumagawa ang Starbucks ng ganun. Very sturdy, na may carabiner handle siya. Wala na, hinahanap ko talaga. Napakaganda. Nilagay ko lang kasi nag-Starbucks ako, mayroong nabangga sa harap ko. Di rumisponde ako, kasama yung backpack ko. Kasi ako araw-araw, may dala ko talaga akong backpack. Yung backpack ko kompleto. Wherever I go, even social function. Kaya ako laging nasisita. Kasi sini-inspect talaga backpack ko. Hindi mo ako mapapahiwalay sa backpack. Yung backpack ko kompleto. No? Napakawalang silbi kong doktor na wala akong gamit. Doktor ka, kahit gano'ng kagaling, nagkaroon ng tension pneumothorax yung pasyente, kahit gano'n ka kagaling, kahit pa ikaw ang pinakamataas IQ at wala kang pwedeng gawin kung wala kang gamit. Unless you're good in improvising. Nakahanap ka ng needle for whatever it is. Ako, meron akong ARS needle for tension pneumothorax. So lamang ako kasi may gamit ako sa backpack. So that's the point. So sa crowd control, ilayo mo. Layo mo sila. Sir, pasuyin na lang sa traffic. Ganun. Next, check hazard. Anong dahilan bakit bumagsak ang taa? Kung yan ay na-electrocute, baka nandyan lang sa paligid. Baka ikaw yung pangalawang ma-electrocute. Kung yan ay nabaril, baka ang shooter nandyan sa paligid. Parang ganun lang. Okay. Next, number 5. Check for responsiveness. So top, ang COVID to COVID ay left to left, right to right. Hindi na dalawa. Kasi pag dalawa ko, pag pre-hospital care, malapit ang ilong ko sa ilong niya. So gilid to gilid, tapik. Tapos trapezius pinch. Pag walang respond ni number 6, call for help. Yan. So pag tumawag ng help, okay, turuan ko kayo paano tumawag ng help. Kahit doctor, nurse kayo, pag mali kayo tumawag ng help, wala sa ayos. Sir, pasuyo po, ambulansya at tanod. Balikan niyo po ako. Bakit tanod? Para ma-endorse mo yung pasyente. Kasi hindi lahat ng barangay ay may hospital. Kaya isama mo yung tanod sa pangangailangan. Sir, pasuyo po ako dito. Ambulansya at tanod. And when you command slow. Hindi yung, sir, pasuyo, ganun, wala maintindihan. Sir, pasuyo po ako, tanod. Pwedeng habang nag-check ka, sine-check mo yung pulse. Pwedeng ganun, kung marunong ka. Okay? So, yun yung overlap. Check for pulse. No? Habang tumatawag ng help. Number 7, bago mag-start ng CPR, cover the mask. Cover the mask with, cover the face with mask, no? Covering the mouth and nose. Yan. Tapos, kung wala namang cervical involvement, kung nandito ako sa side na to, ilayo mo siya. Para yung buga ng hangin, palayo sa'yo. Then, 8, you can start CPR. All compression lang. Ang bilis ay 120 per minute. Ganito ang 120 per minute. Oh. Yan ang 120. Then, if may AED, sinuwerte kayo, connect to AED with no interruption. Tapos, sabihin na natin good news, na-revive ninyo. The number 10 is case evacuation. Yung word na case evacuation ay military term. Ang case evacuation ay kinarga mo yung sundalo sa isang sasakyan na hindi intended for patient. Helicopter man yan or what. Pag kinarga mo sa helicopter na medevac or ambulansya, ang tawag doon tactical evacuation. So to satisfy my C, ginamit ko yung word na case evacuation para masatisfy yung C. Bakit ko ginawa yung case evacuation? Kasi naranasan ko po itong picture na to. Ako po ito, nasa gilid. Alas 3 po ng umaga, na-crash po sa motor yan. Tinawag po ako, tinakbo ko, medyo kalayuan din. Kilala ko ng barangay na ano. So, nirespondihan ko, naglagay ako ng X-collar, nilinisan ko yung sugat, this and that. Alas 3, meron pang pulis 2021 yata to or 2022, nakalimutan ko anong year. May pulis. Walang ambulansya kasi lahat dedicated sa COVID. So I was forced to commandeer a pick up, nilagay sa likod. The sad story, the good story, okay naman ang pasyente. The sad story, yung sarili kong stretcher, hindi na naibalik sa akin. Laging sad story ako pag nasa field. Laging nawawalan ako ng gamit. Hindi bumabalik. Hinihingi, karamihan hinihingi. Sir, wala po kaming ganito o luma na yung ganito namin. Sir, sa amin na lang to. Ala ka naman makahindi ka. Tatawag sa iyo Red Cross, LGU, wala. Sige na lang. So ako bili na naman ng bago. Awas ng pera. No? Grabe. Pero anyway, di ko naman, I never dreamt of being a hero or having a good points in heaven. Ginawa ko lang yon because simply, God gave me a talent to do that. Okay. Now, let's go into BLS of addressing. Ito yung i-emphasize ng BLS stroke. Inuunahan ko na. Baka sa near future, i-emphasize ng BLS stroke. Duda ko lang to. Hindi ko sinabi na ito. Pero sa consensus, nakita ko nagsasalita na sila sa mga stroke sa field. Bago ma-heart attack, tinutugunan ng stroke. Okay. Ang sinusunod natin sa stroke ay Cincinnati Pre-Hospital Care. Ano yung Cincinnati Pre-Hospital Care? Pre-Hospital Scale. Okay? Yan po yung FAST, F-A-S-T. Nag-revise po, hindi na lang si Cincinnati, inad ang BE. Okay? So ito ay adjusted, no? Halo na Cincinnati. So B is tatlo. Brain fog, sudden to ha, and or lahat to ha, hindi lahat to makikita mo sa stroke. Sudden, merong brain fog, or merong behavioral change na parang na-engot, tinag-uusap mo, parang wala lang. So, sabihin natin behavioral change. Sudden loss of balance. Okay? So, tatlong B. I, blurring of vision. F, facial asymmetry. And or arm and leg weakness on one side, hemiparesis, and or slurring of speech. Please, the only BLS you can do is bring that to the hospital right away. Okay, kailangan mahabol natin kasi may time frame tayo, mga door-to-needle approaches. Time frame. Para lahat yan, according to AHA, makita natin sa CT scan if the patient is okay for thrombolytics na doon. Kasi siya ay bara. Hindi siya sabog. Dalawang klaseng stroke. So paano natin malaman? Within 40 minutes to 45, basta within 45 minutes, nasa bungad ng CT scan yan. Or na CT scan na yan, undergoing CT scan. Yan yung objective natin. Tapos mayroon akong reading at 45 minutes. Grabe no? 10 minutes na sa ER. Another 10 minutes, deck na for CT. 20 na. 20 minutes to 45 minutes, meron na akong result. So less than 12 hours, kailangan meron akong result. Ganun tayo kabilis. Kaya yung time, yung mga door to, may tawag sila dun. Yung para mabigyan natin ng kung ma-action na natin from politics. So yan no. Okay, airway debug namin to. So, ano ang ini-emphasize ng CPR? Quality CPR lang. Tapos control although ACLS na to. Limit the staff. So anong limit ng staff? Airway, electrical, therapy, CPR. Yun lang. Ang tawag dyan, the playing coach trio. Ang playing coach dyan, defibrillator, compression. Kung may pang-apat ka, team leader, pero dapat tatlo lang. Palitan. Kung may pang-apat ka, si team leader, saka si compression nagpalitan. Playing coach. Si defibrillator dyan lang. Pag wala, tatlo lang talaga, si defibrillator saka si compression nagpapalitan yan. Every 2 minutes. Yan yung emphasis ng American Heart. Okay? So ito, bawas. Ito yung ideal. Pero kailangan ngayon, tatlo na lang. Si yellow, which is compression. Si green ba to? Which is electrical therapy, and then si airway. Yun na lang yung tatlo. Yung tatlo na yan, wala na. Kailan tayo into ng CPR? Tandaan niyo lang yung salitang stops. The spontaneous return of breathing and circulation or return of circulation. T, transfer to higher level of care. Halimbawa, ikaw ay ward nurse, may dumating na nurse na taga-ICU, siyempre mas highly trained yun, bigay mo sa kanya. Or EMT ka, dumating yung paramedic, PMT basic ka, dumating paramedic, endorse mo na. Okay. O operator is exhausted, kaya kailangan physically fit ka, pa-CPR ka, pero ikaw unang hinimatay, kahiya-hiya yun. You will be the talk of the town. Kaya sa larangan natin ngayon, mga healthcare providers, nako, kailangan mag-exercise na kayo, mag-push up, para malakas, balik alindog program. Then, P, physician's advice, siyempre, doktor yan. Sa legal med, captain of the ship yan. And then S, scene becomes unsafe. Assuming scene becomes unsafe, ano yun? Nasusunog. Nagsi-CPR ka, nasusunog na. O di, huminto ka, kaladkarin mo na yung pasyente. Kung talagang hindi mo kaya pasyente, iwanan mo na, tumakbo ka na. Ganun talaga yung utilitarian rule yun. Hindi mo pwedeng masave lahat. Ano ang legal basis, particularly sa country, katulad ng you break a rib, no? So, merong Article 12, Paragraph 4, nakuha ko sa Revised Penal Code. Any person who, while performing a lawful act with due care, causes an injury by mere accident without fault or intention of causing it. So, ang kabuuan nito is yung circumstance which exempt you from criminal liability. So, pwede to. Kung may lawyer ka, ito yung ano mo. Basta ang ginawa mo ay within the bounds, no? So, doon sa standard of care, SOC mo. Ito yung what is expected na output mo according to the book and according to training. Tapos meron kang contract, no? Bago ka ma-accuse ng negligence, may violation of 4 yun. Merong injury, merong hindi ka nag-comply sa standard, tapos may breach of duty, mga ganun. So, batteries na yan. So ito, you perform, kailangan dito, lawful act. Ibig sabihin, you work within the bounds of law and ethics. Laging dalawa yan, law and ethics. It can be lawful, but not ethical. It can be ethical, but not lawful. Tatlo pa. It can be scientific, but not ethical. It can be ethical, but not scientific. Ano yun? Or culturally aligned, but not scientific. Halimbawa, nagbigay ako ng dugo sa Jehovah's Witness. Pwede ako kasuhan. Kasi patakaran nila, bawal sila bigyan ng dugo kahit pa nag-bleed to death yan. So, bawal. No? So, binigyan ko, pwede ako makasuhan. Kasi yung way ng right to health nila is the right to deny any services na i-execute ng medical. Kasi paniniwala yun. You have to honor culture. So, unless hindi nyo pinag-usapan with sanity, kailangan kasi, parang ako, ang karapatan ko para makakuha ako ng serbisyo na pang-medical ay pareho sa karapatan ko na ayaw ko. Pero ang isang requirement, I am not injurious, hindi ako napilitan, and I am in my sanity. Baka naman sila ulo ako. No? Yun. So, yun. So, bantayan ninyo na hindi dahil doctor, nurse tayo, larga-larga tayo, particularly CPR. Pero may na-destroy or talagang weekend na kasi steering wheel injury, CPR ka, you commit into CPR because it's the rule of the greatest good. Ang tawag naman dyan, utilitarian rule. Hindi ko nasulat dito. Kasi yun ang greatest good. Kasi pag hindi ako mag-perform ng CPR, mamamatay din siya. So, what is the greatest good? Okay, actually this is for ACLS kasi BLS does not teach you how to look at ventricular fibrillation. So, this is a story of the man, petty officer siya or sargento, kung saan nag-cardiac arrest siya. So, nagtuturo ako sa counter-terrorist unit. CTU. Turo. Biglang may kumatok sa pintuan. Bag. Request permission to enter the room, sir. Napaka-properly, no? Sige, sabi mo, pasok. Pasok siya. Pasok niya, may bit-bit pa siyang arma sa likod. Salot siya. Request permission to make statement, sir. Yeah, go ahead. Emergency na yun, ha? Guys, emergency yun, ha? Ganun siya. Sir, meron pong nag-collapse sa labas, sir. Ganun ba? He does not sound emergency. Ginoon ang kortina. Kita ko mga tao nagtakbuhan. Sabi ko sa mga co-instructors ko, parts, pasuyo nga. Paglabas ko ngayon, pagsilip ko, bulagta yung tao. Laki mama niya. Ang laki niya. Paano kung sabing laki niya? Nakapatong pa siya sa long backboard. By the way, guys, don't call this spine board, ha? Dadalihin kayo ng lawyer kasi pag sinabing spine board, ang isipin dito ay gamit sa spine for spinal movement restriction. So, ang tawag ko dyan, long backboard, para hindi kayo mapaglaro ng lawyer. Saka huwag kayo magsabi na spinal immobilization because sa totoong buhay, you cannot really immobilize the spine. Sa dictionary, according to Webster, ang immobilization is 100% no movement. Hindi po mangyayari yan. Mag-move pa rin yan. So, ang tawag doon, spinal motion restriction intervention. Okay, so, I started CPR. Ako una nag-CPR. Utos ko sa kay ito mga co-instructors ko, nurse EMT, ito EMT, ito combat instructor, ito EMT. Sabi ko, get my AED sa likod ng sasakyan. Nag-CPR ako na hindi na ang tuhod ko ay hindi nakalapat sa ground dahil sobrang laki, layo, ang layo ng chest sa ground. Hindi nakalapat CPR. Pinalitan ako nito. Sa madaling salita, na-defibrillate ko siya, nabuhay siya. Nag-arrest ulit, nag-defibrillate ako twice, nabuhay siya. So, recovery position, may ambulansya, dinala sa ospital. The next episode is, pinailan niya ako ng kaso. Kasi nangitim yung area ng CPR, sa sternum area, nangitim yung defibrillator. Pads, yung doon nalagay yung pads. Bakit? Pangalawa po siyang patient sa pads ko. Nung nagamit ko po isa defibrillator, nabuhay din. Ang tindi pa ng kapit, tinanggal ko yung balay po. Bakit po? Sarili ko pong defibrillator yan. Yung defib pads po, napakamahal. Hindi ko alam magkano ngayon. 8,000 po isa. Kasi yung defib pads ng Zol, merong sensor sa gitna. Habang nag-CPR ka, nagbibigay siya ng command kung ang pag-CPR mo ay mabilis or mabagal. Push faster. Ibig sabihin, bilisan mo. Push harder. Ibig sabihin, lakasan mo yung pag-compress. Ganun po, napakaganda. Tapos kung medyo hindi ka nakakaintindi, mabagal pa rin, push faster. Mabagal ka pa rin, dadagdagan niya, push faster, stupid. No, nakakahiya yun sa maraming tao nakikinig. Wala ganun, baka maniwala naman kayo. Wala ganun. So, sa pangalawa, kung sa US ako, kung nasa US ako ng panahon na yan, at ito nangyari, mapapailan po talaga ako ng kaso. Pero hindi na pusto yung case niya against me. Kasi sabi ng mga estudyante ko sa counter-terrorist unit, sir, pagpailan ka ng kaso, ilubog namin sa dagat. Kinausap naman siya eh. Namatay ka, binuhay ka na yung doctor. Huwag ka na mag-file ng kaso. I don't know what happened with this man. I came to know na deck pala siya for bypass at hindi siya nagpa-bypass, nagpasaway. Kaya, ayan, nagkomplikado. Galing swimming, ng time na pagkatapos swimming, naligo, bumagsak. Ayan, cardiac arrest na. Nakita ko sa screen, ventricular fibrillation. Okay. Yung defibrillator, nakita ko, konti na lang yung aking screen. Bakit? Iniiwan ko sa sasakyan. Kung meron kayong sariling defibrillator, guys, huwag niyong iwan sa sasakyan sa mainit. Sisirain niya ang inyong screen. Buti na lang, merong isang bagong defibrillator. Sabi ko doon, palit naman. Buti, pinalitan, no? Pinalitan naman nung, sabi ko, palitan na lang kasi wala na yung defibrillator. Anyway, our effectivity in doing advanced programs or in saving lives will always start with basic life support. So, hindi ibig sabihin na madali lang yan. Merong nagkakamit ng mali, lalo na sa BBM. Ipapakita ko sa inyo mamaya bakit nagkakamali tayo, lalo na sa bag valve mask operation. Basic life support, no? Even sa colleagues ko, sa doktor, nakakita ko na hindi magaling mag-CPR. No, parang nasanay na kasi ang mga doktor mang-utos sa nurse. Hindi na niya na-perform sarili niya. Hindi katulad sa field ko na ako gumagawa lahat. Ako nagdadayot. Kasi ako lang eh. Sa expedition medicine. No? Tignan niyo itong gamit ko. Puro gamit yan. Pang expedition or what. So, ako lang isa. Ako magtimpla ng drugs ko. Ako magkabit. Ako lahat. As in. Kaya nasanay ako, yung trabaho ng nurse, trabaho ko. Kasi nag-iisa lang. Unless mayroon akong backup, I'm okay. Happy ako. Sa aeroplano, usually dalawa lang kami or tatlo. Happy na ako sa tatlo. But usually sa helicopter, maliit ang aming treatment bay, dalawa lang talaga. Ang pangit doon, pag airway ako, yung kasama ko, siya yung libuter. Marami siyang gagawin. Pag siya yung airway, ako yung maraming gagawin. Ako ang mag-CPR, ako mag-defibrillate, ako mag-IV. Pero sa amin, ang IV ko, dinidikit ko sa ulo. Ang nag-IV ay yung airway guy ko kasi meron akong sariling mandatory ventilator. Hinahanap ko kung saan nakatago. Hindi ko makita yung ating IMV intermittent mandatory ventilator ATV 3000. So with that, ladies and gentlemen, we'll proceed into, unless you have any questions, into practical sessions. I'll give a break, no? Para mag-ayos ako ng mga dummies ko. Pang sa gayon ay i-demo ko. Any question?
Ay, Doc, ask ko lang po.
Ma'am Joy? Hello, Ma'am Joy.
Hello
Yes,
po.
Doc.
Do we have doctors around?
Yes
Sa
po, Doc.
BLS po?
Meron po.
And nurses.
Anybody from WIPAM? Do we have doctors?
Yes, Doc. Meron po.
Hindi pinapansin yung beauty ko.
Doc, pinapansin kita, Doc. Di mo lang po ata naririnig.
Oh. Good. So, I will give you like 15 minutes break
Ay, salamat.
and I'll arrange my staff. Mga things na gagamitin for training. Ang adjustment ko lang, before I give you break, meron ako instruction. Ang adjustment ko, ang nasa manual AED, baka magkamali kayo, lalo na doctor sa kayo yung maglilista anong i-order sa hospital. Baka totally AED talaga yung order ninyo. Huwag naman. Ang AED ay para sa mga outside the hospital. Pang grade 1, tayo po ay manual na mayroong AED override. Gusto ko lang linawin. Baka hindi kasi naintindihan basahin niyo yung manual. A defibrillator with an AED override. No? Manual siya. Napapakitaan ko mamaya kayo ng ganong gamit. So yun na, pag nag-order kayo ng gamit, huwag AED. Kasi yung AED, may mga bagay na hindi tayo sinusunod sa AED. Okay? So ganito yon. Habang nagsi-CPR ka, kasi nauuna si compression bago defibrillation. Si defibrillation darating. Ang unang gagawin mo sa defibrillator, i-on mo siya. Ang defibrillator magsalita. Depende sa klaseng defibrillator, but I'll start with the most generic one. Pag on mo, unit okay. Check responsiveness. Alam nga namang hihinto ka sa pag-CPR para mag-check responsiveness. Nakakasa ka ng CPR. Hindi mo napakinggan si AED. Open patient's bare chest. Alam nga, naka-CPR ka na nga, naka-open na. Okay. Call for help. Ganun, no? Huwag mo nang sundin yon. Ang sundin mo na lang, metronome. Start compression. Pip, 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 pip. Yan ang susundin mo. Ngayon, kung nag-CPR ka dyan na 2 minutes, mag-another 2 minutes ulit. Wala tayong magawa. Saglit ha. Emergency. Philippines families of road victims and survivors. Oh. Ba yan? Anyway, metronome, no? Pip, 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 pip. Sundin mo. After 2 minutes, analyzing, bitaw ka na. Wag na wag kang nakadikit sa patient's body kasi magmamali ang reading ni AED dahil si AED bumabasa ng electricity. Yung heart natin, there are 3 features of the heart. It's a mechanical pump, a chemical pump, and an electrical pump. Doon sa electrical component niya, yun ang bantayan ninyo. Kaya huwag kang dumikit. Shock advice, stand clear. So ngayon, kung may kasama ka, mag-chant ka. 1, I'm clear. Tingnan mo na hindi ka nakatikit sa pasyente. 2, nakatingin sa airway. 2, you're clear. Si airway, ang gagawin airway, patayin ang oxygen. Ibaba ang bagwal mask bago sisigaw ng clear. Pagpatay na oxygen na kasiro, bakit? Kasi pag hindi mo yung ginawa at nag-spark si defibrillator kasi galing sa lunod yung pasyente, hindi mo na linis yung katawan, tuyo. Nag-spark siya kasi electricity yan. Tapos sirit-sirit yung oxygen ko, kaboom tayong lahat. Kaboom! No? Because fire will happen in 3 things. Ano yan? Actually 4 things. Tetrahedron of fire. There must be fuel, oxygen, heat, and chemical reaction. Itong tatlo, interplay to. The absence of one, there's no fire. Okay? Eh ngayon ang oxygen ko, kailan nag-start ang fire? 21 sabi ni Ruth, ang fire mag-start at 16. Ang 16 ay nangyayari pa rin. Ang buga ko ay 16% oxygen to. O bakit hindi carbon dioxide? Yes, may carbon dioxide pero may 16% from ko. O di ba dapat carbon dioxide? Hindi po lahat carbon dioxide. Bakit? Meron po ako tinatawag na anatomical dead space. Yung anatomical dead space ay ang area sa respiratory tract ko na walang exchange of oxygen and carbon dioxide. Like the trachea, the main bronchosses, the main bronchi, not bronchosses. No? Hanggang ang exchange is bronchoalveolar sa alveolus. Beyond that or above that, no exchange. Yun, pag lumabas yun, 21% pa rin. Kaya pag nag-measure tayo ng carbon dioxide and tidal carbon dioxide, at the end of the tidal volume, yung tidal volume, exhale, hinga, exhale, yan po yun. So total lang capacity rin yung nasa gitna, assuming ang tidal volume mo, kasi maliit lang yung baga mo, 450, yun, so yun lang yung tidal volume mo. Assuming normal adult ka, sige, abot ka ng mga 600, Filipino body, yun ang tidal volume. Pero yung unang bungad ng tidal volume mo, karamihan dyan, oxygen by 21 because of the anatomical dead space. You don't understand me, you check your Snells and look for anatomical dead space. Kasi may physiological dead space, that's not my topic. Anatomical dead space. Yung 16% of oxygen, nakaka-generate na rin yun ng fire. Ganyan po kadelikado. The fire is the friend and the fiend of a civilization and man. Gumaan ang trabaho ng tao because of fire, pero mong biruin, worst enemy ng tao yan. The number 1 killer is fire. Mas gusto ko pa sumagupa ng ISIS ng mauti, wag lang yung apoy. Well, tao pa rin yung sasagupain mo, may takot yan. Ang apoy, walang kinikilala yun. Okay? So, walang tanong? Okay, walang tanong. 10:02 in my watch. 10:03. Sige, balik tayo ng 10:18. Okay. Mag-aayos ako ng gamit. See you.
Hello po, good morning po. For your attendance po, kindly send your name po and yung training po enroll nyo sa meeting chat po. Yung name po na isi-send nyo po is yung name po na mag-a-appear sa certificates and IDs nyo po. Mag-send po ako ng example sa meeting chat po. Thank you po.
Okay, everyone is here. Okay, first, let's go into choking. So there are actually three. Choking, number one is main two, partial and total obstruction. Partial obstruction with good air entry, maganda. Hirap siya, medyo hindi ganong hirap rin. Facilitate cupping. Don't slap. Sir, sige, cup po, hinga, slow. Turuan mo siya huminga ng 3 seconds in. 1,000, 2,000, 3,000. Ang cup. Hinga, hinahin. Tapos huwag mag-cup. Ganun lang. Tapos hinga ulit. Cup! Ganun, cup. Tapikin mo lang to facilitate ka pero hindi mo slap kasi sa American Red Cross you have to slap it. Ang AHA bawal mag-slap. Okay? Slow, hinga. Cup! Yan. Poor air entry na, partial choking with poor air entry, pumosisyon ka na sa likod, mag-abdominal thrust ka. So, abdominal thrust, position sa likod ng pasyente, ito yung sepoid process. Huwag nyo nang pansinin itong chest seal na to. Sepoid process, gawa ka ng ganito, pointing towards the scapula of the patient. And then, sir, inhale. Sige. Pag hindi na siya makapag-cooperate, ikaw na bala. 1, 2, 3, until the foreign body is being spitted out. No? So, ganyan, no? Until the foreign body is being spitted out or the patient becomes unconscious. Pero yung paa ay nasa gitna ng paa ng pasyente. Nakatayo ka, nasa gitna. In case the patient falls, tapos hindi ganon, pag sumayaw yung pasyente sa gilid, bagsak kayong dalawa. Nakunan kayo ng video, di kahiya-hiya. In case the patient falls, mag-slide lang siya. Mag-slide lang, pa-slide mo, higa. And you tap, patient, dahil pag call for help na, and you can chest thrust. Ang tawag dito sa lumang panahon ay Heimlich, pero hindi na Heimlich ang tawag ngayon. Heimlich pa rin in honor, no? Pero simply abdominal thrust. Okay. Abdominal thrust. So abdomen. The principle na pinapataas ko yung pressure sa loob ng intra-abdominal pressure to push the intrathoracic pressure. I-push niya para mag-expel. Sa buntis, you don't do like this. Kunwari buntis to, dito ka na sa chest. So hindi na ganito. Kundi ito. Yan. Kasi may dudo dito eh. 1, 2, 3, 4, 5. Yan. 1, 2, 3, 4 until the foreign body is two things will happen. It's either the patient, there is total obstruction at hindi umalis. That's ATLS when you crick. That's not our lesson for today. Although kung mag-undergo kayo ng ATLS, katulad sa amin sa Wilderness Advanced Life Support, we perform crick. So that's totally different. Sa atin lang is BLS and then na-expel. Pag na-expel ang na-dislodge ang foreign body and being spitted out, what do we do with the patient? We advise, no, ang patakaran ngayon, we advise hospitalization. Kasi hindi natin alam anong extent of injury nasa loob. Pwede siyang infection or pwedeng magkaroon ng secondary laryngospasm. Laryngospasm, no, which is some sort of a respiratory arrest. Okay, so yan ha. Tandaan ninyo. Pag sa Bata, same procedure. Okay? No? Same procedure, walang pinagkaiba. Okay? Himlik pa rin. And then, if the child becomes unconscious, then we do CPR. Single hand lang, CPR. The baby, iba. Kalimutan ko kunin baby. Saglit lang. Kung sa baby, na-choke, tingnan mo. Pag nakita mo, sweep. Pag hindi nakita, don't blind sweep. Okay? First, hawakan. Dito hawak o sa leeg. Dito. Itong jaw. Ganun ang hawak. Okay? Dito sa lap. Head down. And then back slap. Ganun. Tatama sa scapula, hindi tatama sa spine. 1, 2, 3, 4, 5. Silip ko nahulog. Dito sa bandang occiput. Lipat. Hawak sa kamay. Yan. Okay? Gawing platform ang thigh. Okay? Dito. Silip. 1, 2, 3, 4, 5. Wala pa rin. Pag nakita mong nandyan, kunin. Okay? Pag nakita mo, biglang umiyak, iside mo, paiyakin mo para lumabas, tapos kunin mo kaagad. Huwag mong kunin pag umiyak na gano'n kasi babalik yan. Kasi pag iyak ka, sabay hinga, balik ulit sa loob. Side. Okay, side. Okay, kuha. Kung hindi, same procedure. Medyo may katagalan. Pag nakita nyo ng perform mabilis, dahil dal to dami to. Pero sa totoong buhay, naranasan ko to. Talaga kasi maraming sabit-sabit. Hindi talaga down. Tapos, 1, 2, 3, 4, 5. Yan. Scooping. Yan. Hawak. Silip. 1, 2, 3, 4, 5. Okay? Until the foreign body is dislodged and expelled. Okay? So, the good thing about conducting first aid here and there is there are successful events na nagawa ng paraan ang choking. No? So, FBAW management. Now, let's go into bagging. When you bag, you have to note na yun. Bagbal mask. Tingnan nyo ako, bagbal mask. Ito yung isang camera. Ako sa So, kunwari, nasa table, ang pasyente kailangan ay naka-hyperextend. Bakit? Pag hindi mo i-hyperextend, tingnan yung bagbal mask, ganito na lang siya kaliit. Tingnan nyo Karamihang mali ay nagbagbal-mas na ganyan lang. Wow, 1,000, 2,000, 3,000, 4,000, 5,000, 1,000, 2,000. Mali po yun. Kailangan i-employ ninyo ang letter C and letter E. Ano ibig sabihin? C sa mask, dito sa ano ng mask, sa port. E dito sa rim of the jaw. Dito. Yan. Kung titingnan nyo to, rim. Huwag dito ha, huwag dito, hindi makahinga yan. Katulad ko, hindi na makahinga. So dito sa gilid, sa jaw. Yan ha. Tingnan nyo. C, para seal. And then E, doon sa rim. Tapos, hyperextend. Kasi pag hindi mo i-hyperextend, pag drive ko, punta sa lungs, punta sa tiyan. Kailangan naka-hyperextend talaga. Kung ako, tingnan nyo ako, pag naka-bagbalmas ako, ganito talaga. Ganyan ang totoong buhay. Kaya bago tayo mag-CPR, kailangan nakakabit siya sa cardiac board, yung standard cardiac board. Ang standard cardiac board ay merong tinatawag na yung hyperextension headrest. Ganito yun. Yan o. Meaning, kung ako yung hihiga, kung titingnan niyo ako higa dyan, ayan. So, hyperextend talaga. Yan ang tama na posisyon. Ang pasyente na ibag-mask. Ganito dapat. Huwag na huwag kayo mag-mask, mag-bagging na ganito. Pupunta sa tiyan yun, kailangan nakaganon. So, okay, ganyan. So, meron siyang hyperextended headrest. Itong depression sa cardiac board. So, ang delay ngayon sa CPR ay dalawa. Ang paglagay ng cardiac board sa pasyente para ma-hyperextend. And then, ang paglagay ng non-rebreather mask. Ang non-rebreather mask ay ganito. May dalawang valve. Pag nag-exhale ako, lumalabas sa valve, pero ang inhale ko wala, kukunin niya dito sa reservoir. Kaya umaabot siya ng mga 90% oxygen. Yung nasal kanila mo, mga 22 lang yan to 24. No? Ito mataas. Sa arresting patient, ito yung nilalagay natin una, tapos nakasirit ang 15 liters per minute. Siyempre, naka-down ng PPE na tayo, no? Kasirit, bago tayo CPR. Ang ingay ng manok ko, wala talaga akong ibang libang. Survival chicken yan eh. Nasa Manila ako, pag bumagsak sa 7.2, may pagkain. So don't start CPR na walang ganito kasi it helps as a cover. This serves as a cover. Okay, so ang delay, paglagay nito. Pero, kunwari, sa inyong hospital, meron kaagad kayong crash cart, merong bagbal mask. So, bago mag-start ng CPR, yung airway mo, naka-position na. 15 liters per minute, then CPR. Yan. Don't start CPR na walang cover. Okay? Yan yung ine-emphasize ng interim guidelines of 2022 American Heart. So, i-practice na po yan dyan. Kasi kahit anong turo ko dito, pag hindi nyo i-practice, liparan nyo yung COVID dyan sa paligid nyo. Tumataas ka naman yun. Nasira na yung ulo eh. Mag-order pa ako ng new dummies. Ngayon, let's go into defibrillation. Dalawa ang defibrillator. Gamit ng pads, katulad nito, uninterrupted. Makita, lagay ko sa kabila para makita pag ibabaw. Uninterrupted, ibig sabihin merong sensor sa gitna, merong sternal na apex, saka interrupted. Ang interrupted ay ito. Yan. Walang in between. Walang in between. Okay? So yan. So this is under AED. Automated External Defibrillator. Dalawang klaseng AED, isang cover operated, yung on and off, pag ganun ang cover, unit okay. Or pindot dito, hindi ko nilagyan ng baterya, masyadong maingay. Unit okay. Check responsiveness or unit okay. Unit okay, apply patch. Ang pinakabagong AED, kung bibili kayo, mayroong pediatric mode. Pag pindot mo sa pediatric mode, shift to pediatric mode. So siya na nag-adjust ng joules. Okay, so yan. Pero sa atin, dahil healthcare professional tayo, ito ang gagamitin natin. Ito, ang ginagamit dito, paddles. Dati paddles, then nauso yung ISO, nag-shift into pads. Ngayon, bumabalik lalabas sa paddles. So, kahit basic life support, okay lang yung paddle sa atin, yun yung adjustment. Kailangan familiar lang kayo sa gamit ninyo, lalo na doctors na medyo hindi nyo sinanay sarili nyo. Nakalagay dito, pacer, monitor, defib. So biphasic siya. Pag sinabing biphasic, i-adjust ko lang ha. Manual defib, pinaka-manual. Okay. So, iakyat ko lang ang kanyang joules. Saglit na may bago ako dito. Yan ko nababasa eh. Click muna ito. Sternum. Saka ko ipakita sa inyo. Hindi kasi sa akin ito. Ayusin ko muna. Ang biphasic, ang maximum joules is 220. Naka-default sa kanya 120. So, naka-AED pads ako. Ang gagawin ko, i-shift ko siya into manual. Okay? Pag nag-manual ako, itataas ko na yung joules. Ayan. So, naka 200 joules ako. So, ngayon, iharap ko lang sa inyo para makita nyo, 200 joules ang biphasic, ang monophasic, 360. So, habang nag-CPR, ang nagsi-CPR nasa kabila, CPR siya. Ilagay ko dito naka-manual. Pag sinabing manual, ang rhythm ay nakikita pag ilagay mo yung paddles. So papakita ko sa inyo na ang paddles mismo ang nakakabasa ng rhythm. So ilagay ko sa sarili ko ha. Sa tao kasi hindi arresting heart eh. Yan. So, kung kunwari arresting heart, mababasa yan. Ngayon, kung ililipat ko, wala na, zero kasi naka lead Roman numeral 1, limb lead 1, limb lead 2, limb lead 3, balik ulit sa paddle. So kailangan naka-paddle siya. So kayo diyan sa hospital or wherever, ipamiliarize yung sarili niyo sa defib. So pag naka-paddle, ilagay ko dito, sa pasyente, apex, at sternum apex, na-detect niya, kunwari, ventricular fibrillation on screen. So, i-charge ko siya. Ang charging, pwedeng dito sa kamay ko. Okay? I-charge ko. O, makita. Kamantagan, 1 line clear. 2 you're clear. Airway, clear. 3 everybody's clear. Clear. So, isa-shock ko siya. Pero syempre, hindi ko siya i-shock kasi hindi ito pang defib, patayin ko lang. Yan. Para mag-default. So, 1 I'm clear, 2 you're clear, 3 I'm clear. Assuming, ang ginamit nyo ay AED, ganun din. Habang nag-CPR ako, paglagay ng AED, no interruption in compression, pag uninterrupted, diretso lang, angat mo lang kamay mo, tuloy. Yan, lagay, tanggal sa ilalim, didikit na yan. Pero kung mabalahi mo ang pasyente mo, bago tanggalin sa ilalim, mag-sheave muna. Tuloy-tuloy yan, 30:2, pag may ambibag, 30. Ambibag, 2. 1, 2, hanggang nakalagay na, siya na magkukuman na yung AED. Okay? So, biglang sasabihin ng AED, ito kasi meron tong automated external, katulad ito, naka-automated to ngayon. Isisit ko lang sa manual. Ang problema, wala siyang pads. Nandito nakakabit yung pads. Hindi kanya. Iba rin yung pads dito. ECG, saglit. Dito ng pads ko. Anyway, kunwari, sabi niya, analyzing, bitaw ka. Shock advice, stand clear. So, nag-charge sa CAD. Ikaw ngayon, mag-charge ka. 1, I'm clear. 2, you're clear. Patay si 15 liters per minute. Tapos si ambibag, ibababa ha. Hindi iangat. Lilipad ang aerosol pag iangat nyo. Bawal ganun. Baba lang. Baba dito. 3, everybody's clear? Clear. Okay, pindot. Shock. Boom. Shock given. Check responsiveness. Check for pulse. Check for pulse. 1,000, 2,000, 3,000, 4,000, 5,000, up to 10. No pulse ako. Siya nadidetect niyan. Continue CPR. CPR ka ulit. Until the whole code blue team arrives at mag-ACLS na tayo. Ibig sabihin, secondary na. Kailan mag-start ang ACLS? Kapag nag-IV ka na, and then, ni-ready mo na yung airway. Kasi ngayon, kakaiba na ang ACLS. Bilis ka ng airway. Hindi katulad noon, after 6 minutes or 8 minutes pa ang airway. Depende. Ngayon, halos unahin na kagad ang airway. I-secure na kagad ang airway. So, ganyan ang ating basic life support. Okay. What if the patient becomes conscious? No? Nabuhay siya. Pag nabuhay na siya, ang gagawin natin, i-recovery position natin. Pag recovery position, ganito lang yan. Taas isang kamay. Taas isang kamay. Taas isang kamay. Itong isang kamay, hawakan dito sa elbow. Lagay dito. Dito dito sa mukha. Dito sa mukha. Tapos itaas yung same side. Yung knee. And then, shift. Ganun. Okay. Kasi wala pa akong advanced airway. We will do this sa seizure or epilepsy and return of spontaneous circulation na wala pang advanced ill. Pag nalunod, paano ang lateral recumbent sa nalunod? Biglang sumuka. Pag suka sa nalunod habang nag-CPR ka, kung nakadamit yan, atakin mo lang yung damit, oh. Pak, ganun gagad, sabay tapik sa likod. Baka mag-aspirate. Okay? That's one. Okay? Dito na side ako. Biglang CPR, biglang gumanon ako. Hata! Side agad. Huwag tagalin. Huwag mag-count ng 4. Hindi na yung 4. 1, 2, 3, 4. Nalanghap ko na yung ano. Tama ba ang Tagalog ko? Langhap? Na ano ba? Hindi higop eh. Na-inhale ko na. Na-inhale ko na yung aking ano. Ingay nito. Na-inhale ko na yung aking aspirate galing sa tiyan. Eh paano kung walang damit? Oh. Ganito. Okay, tingnan niyo ang kamay ko, nagsi-CPR ako. Kamay ng CPR to. Itong isang kamay ko ng pasyente, ilagay mo sa ibabaw, ipalagay mo. Tapos yung isang kamay mo, ano mo, so 3 kamay. Sipin niyo, 3 kamay. Nagkagano. Walang pagkakamali sa compression, tama pa rin. Biglang susuka, yung isang kamay mo, hilain mo lang, nakagano ako. Okay? Ganito yan. Wala kasing kamay ko. CPR ako. Yung kamay ng pasyente, assuming ang kamay niya ito. Yung blue. Patong dyan, patong. Hinawakan ko yung kamay. Sumuka siya. Hilain ko na yung braso niya. Ganoon siya. Tapos sabay tapik. Okay? Okay, nakikita niyo dito sa camera number 2 ko. Kamay ng pasyente. Itong blue. Kaysa ganon, ilagay ko. Walang nagbago. Kahit sumuka niya, walang magbabago. Sumuka siya, very weak siya. Atakin ko lang yon. Paghatak niya, gaganon siya, sabay tapik. Okay? Yan ang drowning. So, wilderness medicine, combined with Utstein style, ginagawa yun. Hindi pa wala pa yan sa Pilipinas, kaya na-shock kayo sa ganong maneuver. Okay? Sa low headroom CPR, ganito ang low headroom CPR. Mababa talaga headroom, walang ano, sa loob ng helicopter. Ang CPR natin, itong radius. Hindi siko, radius. Tingnan niyo ako mag-radius. Compression na, tingnan mo. Yan o, radius o. Yan o. Hindi siko, fully radius, pwede dito. Yan. Pero dito ako, radius. Along the sternal line. Radius. Kung low headroom. Hindi siko radius. Sa ulna ako umawak. Tama ba? Ulnar ba? Tama ako? Ay, hindi. Ulnar. Ulnar pala. Ulnar, hindi. Ulnar line. Radius ako umawak. Radius ako umawak. Kabaliktad ako. Ulnar yung lumalapat. Yan. Okay? So, wala akong na-violate sa putakaran na push hard, push fast at 120 with adequate recoil, no interruption or lessen the interruption, avoid hyperventilation, exchange of compressor every 2 minutes. Yan yung mga highlights ng 2020. Ito no?
May question ako. Proper placement ng pag-CPR sa chest, yung nang naguguluhan ako.
Question, guys? Tapos ko agad, oh. Sa drowning kasi, ini-emphasize, isa sa ini-emphasize kasi is aspiration of vomitus. Proper placement po ng kamay pag mag-apply ng compression po. Salamat. Okay. Sternum. Liwanag.
Amo nang libong ako niya, ipa.
Sternum. Sole of the palm. Doon. Kilikili. Kilikili. Slide to the center. Ito ang tatama. Oh. Yung tinar sa hypotinar. At yun ang straight. Hindi bend. Straight. Okay? So,
Okay,
pwedeng
okay.
isa, pwedeng interlace.
Okay, okay.
Pwedeng ganon, pwedeng isa lang. Walang problema.
Okay,
So,
okay.
Kilikili, interlace. As long ito ay tatama, hindi doon sa ribs, no? Doon sa cartilaginous portion of the ribs. Babalik ka ng cartilage. So, laging sternum. God made the sternum, perhaps, nakita na niya na ang CPR ay i-invento ng tao. So, itong line na to, sa hanggang doon sa soft part. Yung iba, ganun ang pag-measure. Ganun pag-measure kita. Ang pinakamalapit, kilikili. Okay, kilikili, slide, yan, kita. So, that's your proper placement.
Ang anli na nga ni.
Any question? Naintindihan niyo? Nakuha ba? So ito yung line. Yan yung sole. Tinar, hypotinar. Yan yung lalapan. Yan yung lalapan. Kunwari ito, sternum, yan. Yan. Okay? Yan. Okay. Pwedeng angat. Pwedeng interlaced. Pag nasa dodo ng babae, merong tinatawag na style lang to, lalo na sa culturally sensitive area, yung CAMMING, coming. So kung dodo ng babae, manasa ng malaki, pwede kang mag-coming kasi kung nakunan ka ng video, parang tatama pa rin, no? Kahit ganun mo. So ang coming ito, iguhit mo sa sternum. Guhit sa sternum, dito ka humawak. So yan yung mga modified. Yan nyo lang narinig, no?
Magaling sa'yo.
Question? Sabi, walang question. Dapat kasi pag face-to-face tayo, lahat kayo mga pag-CPR. Pero ang gawin nyo na lang, pwede kayo mag-CPR sa live na tao. Pero wag nyo lang iliit. Turuan ko kayo, parang chat tricks. Ganito pa ang chat tricks ng CPR na wag idiin. Tao talaga to live. Ang gawin nyo, iangat nyo lang yung sole. Ganun lang. Para lang maganda ang sayo ng shoulder. Ang sikreto kasi ng CPR is the shoulder. Tingnan yung shoulder ko. Yan ang sikreto. Hindi ganun. Kailangan ng shoulder sumasayaw. Yan. Ang katawan talaga. Hindi yung siko. Siko yan, oh. Shoulder. Yan ang tamang siko.
Okay.
So, push, recoil, push, recoil. Ngayon, gagawin ko, hindi ko i-push for chat tricks. Pero pag nakita sa camera, magandang angle ng camera, akala mo totoo si Pierre. Tinataas ko lang din. Pero tinataas ko yung sole. So, practice mo lang. Para makuha mo lang yung metronome. Yung metronome ka, tit, 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 tit. Yan yung 120. Ganyan kabilis. Anong tanong? Along the way, if you have any question, I'll just answer them. But you will have your exam. Bibigay ni Ma'am Joy. You will be shown a video. Uy, mali pala yun. So we have to be like an open-minded person, an empty vessel when it comes to learning. Kasi medicine is a very dynamic science. What we believe today might be a taboo tomorrow or might not be practiced. And parang lidocaine. Lidocaine ginamit, biglang indeterminate hindi ginamit. Ginaginamit. Aba, biglang ginamit ulit ngayon ang lido. So, gano'n. Gano'n ang medisina, dynamic science. So, any question? Pag-administer ng O2 sa infant ba, 15 liters ba dapat kapag nag-CPR? Lahat po yan 15 liters. Although yung ating ano ng infant, ang problem natin sa infant pag nag-arrest kasi wala tayong non-rebreather sa infant, no? Dapat intubate siya diretso. Kasi ang problema ng infant from bata to infant, airway talaga. Talagang ano, aggressive ka. Pag arresting yun, pwede intubate ka agad. Yun yung adjustment. Makukuha natin siya sa NRP. There's no non-rebreather mask sa infant. CPR ka ng CPR tapos bag-valve mask, ready ka na for uncuffed intubation. Uncuffed na endotracheal intubation. Gamit ka ng Miller. Kaya halos ang BLS mo, hindi mo ganong may enjoy sa infant kasi as much as possible, intubate ka agad. But that's NRP, neonatal resuscitation program. It's a very good question. Sa infant, ang ginagamit namin, hindi na kami nagko-compute, meron kaming crib sheet. Sabihin mo lang yung weight, nandun na lahat, pati timpla ng gamot. So hindi ko na mahanap sa akin nabibili siya sa AHA. Depende sa weight, nandun na lahat, color-coded siya. Anong klaseng gamot, ang gamot, ganito ang dosage, size of ET tube, so depende sa kanyang timbang. Timbang at laki. So sa lahat ng arresting, 15 liters yan para mataas ang oxygen percentage. Dahil sa infant, kung naka-intubate tayo, yung bag valve mask mo nakakamit yun sa 15 liters. Siyempre, mas maliit lang bag valve mask. 15 liters pa rin yun. Wala po tayong AED for baby. No? Meron tayong mga paddles for pedya. Saka, usually, mabilis mag-resolve yung heart nila by mainly CPR. Pero meron tayong infant paddles din talaga. Pag nakita mo nag-DF, meron para siyang pointed na infant. Yan yung mga bago ngayon. But we don't, again, hindi tayo nag-AAED sa kailangan ng ina-AD natin pag pedya is one year up. 1 year below neonate. So hard. But it resolves. You resolve the airway, you resolve the issue. Kasi karamihan yan respiratory. Ang threshold ng bata mataas talaga. Kasi sanay siya sa environment na nasa loob ng womb. Ang oxygenation niya through blood, hindi sa ilong o hindi galing sa nanay. So we will make use of that principle na ang threshold niya kumpara sa adult mataas. Very sensitive siya, pero mataas ang threshold. So when we settle the issue of respiratory, we settle the heart control. Mga data collection nila, lalo na pagpetsa at bata, medyo mahirap para sa adult. Nakumpleto sa adult sa bata. Ang ILCOR hanggang 2020, yung international liaison yung mga areas of controversy sa international guidelines 2000, yung mga unresolved issues at additional research na ginagawa ng paraan ng ILCOR. Yung ILCOR, international liaison siya. Siya yung parang totem pole natin when it comes to basic life support and at ACNS, yung ILCOR.
Tanong ko lang, Doc, ang counting ba, paano bang counting yan?
Ano? Assuming yung pads ninyo walang pang infant, adult dose ka pa rin. Pero yung inyong ganito, tingnan niyo na lang. Ang counting ng compression, wag ako parang 1, 2, 3, 4, 5, phonetic. 1, 0, 1, 2, 3, 4, 5. Tapos ang counting niyo kailangan may inhalation. Ang inhalation niyo count. Kasi pag sige kay count, buga-buga kayo ng hangin, balik kayong mahilo. Kasi lumalabas yung hangin kaysa sa maraming inhale. Parang 1, 2, 8, 9, 1, 0, 7, 8, 9, 2, 0. Ano? So nag-inhale kayo kung mag-count. Kailangan practicein yan. Kasi hindi yung 1, 2, 3, tapos 11, 12, 13. Ang haba na ng ano nyo, yung syllables nyo. Hirap. Mas kulang na ang hangin i-inhale. Lalo na ngayon, 120, madali kayong mahilo. So ang counting ganon, when wala kang kasama, 200 ka, 204, 220, 240 in 2 minutes ka straight. Hinto. Hinga malalim, check for pulse. Huwag ka magbigay ng hangin. CPR ka ulit kung wala ka pang kasama. Pero yung pasyente, naka-non-rebreather breather mask. Wala kang kasama. Straight compression lang. Assuming, saan yung baby? Assuming wala akong AED na pambat baby, pwede yung adult. Ang gawin mo lang sa adult pads mo, harap likod. Kaya maganda yung sternum, yan, likod. Okay, pero masyadong malaki lang to. So there are smaller pads like now. So harap likod lang siya. It serves the purpose, ang AED. Pag nahirapan siya magbasa, shift to manual. Kasi baka nahirapan magbasa. So, lagay mo sa manual na nakapads din, tingnan mo pag tira yung fibrillation makita mo sa bata. Pero same treatment sa adult, pages kabata. Pag fibrillation, defib. So minsan, bagsak ka lang, yung mga nag-doubt, bagsak 200, pwede ka mag-100. 100. Yung mga nag-doubt, pag manual, gina 100 kesa 200. Ang topic nyo, NRP saka pulse. So ibang course yung pulse saka NRP. Kino-compute yun actually. When you doubt, cut 50 sa baby. Okay? Sa bata, cut 20%. Babawasan mo. 20%. So 200. No, 220. So mga 160. Bata, 160 ka. Kung may manual. Yan ang hindi na ibibigay ng AED nyo. Unless yung AED nyo ay may pediatric mode. Siya na magkukompute pala. Again, kung hindi ko na-answer yung full age because it's pulse and NRP, neonatal resuscitation program, meron kaming crib sheet. Hindi ko na mahanap yung crib sheet ko, kaya hindi ko matimpla yung computation ko kasi nandun sa crib sheet. Sa pulse, iba rin, kinocompute din lahat, gamot saka joules. And it's a separate course. Atin tayo, ito, adult lang yung ating, ang ACLS is adult one. Kaya pag, nung naging instructor ako ng American Heart, sa AHA mismo, under Californian Registry, for BLS yun, 4, BLS, so many years ago, more than 10 years. So, BLS, ACLS, Pulse, NRP. Sa Pulse, medyo nahirapan ako kasi magkukompute pa ako. Sa neonate, hindi. Bakit? Meron ng libro. Sabihan nyo lang ako ng weight, height, weight. Naka-color code yan. Nandun na lahat. Hindi na ako nagko-compute. Madaya na. Although sa Badger County, adult dose pa rin kahit sa infant. Mas safe daw yun. Pero may mga conservative na cut 50 sila. May mga bagay na hindi ko nasunod. Halimbawa, nung nasa Everest ako, nag-defibrillate ako ng hypothermia. Nagkaroon siya ng J-wave, Osborne wave, tapos nag-BTAC, pulseless. So 360 yung aking ceiling joules kasi monophasic. Ang monophasic 360 ang ceiling. Biphasic 200. Sa 360 ang ginawa ko 100 joules lang ako for two things. One, fresh aresia baka kumaya. Manipis ang katawan. Pangatlo, mabilis umbos ang baterya. Ang lamig kumakain ng baterya. Kung mataas pa ng joules, baka maubusan ng baterya. Ang hirap mag-charge. Aba, 100 joules, nag-reverse nagbalik sa NSR. Hindi ko naman siya maisulat kasi hindi naman ako institusyon. Pero bumalik. Meron akong reason lang na parang legit na ito pala. Pwede pala. Kung maulit ko yung panahon, ulitin ko siya. Pag wala, itataas ko lang naman yung joules ko. Okay, since it's 11, just write your question for me to answer it later via chat. You will have your exam biphasic 200, monophasic 360. Pero hindi na tayo gumagamit gano'n ng 360 kasi harmful sa heart siya. Harmful. So biphasic na. Ang mga bago ngayon biphasic. You will have your exam and you have a video run. So for those who will be taking BLS only, thank you for being loyal to WePump. We provide quality training. Hindi lang ito, may trauma kami and other things. And we can also offer face-to-face training. So depende sa inyo. You just have to come up with a certain number of population. Si Ma'am joining nyo nakakalam dyan. Yun lang, mas medyo mataas kasi maghakot kami ng gamit papunta sa lugar ninyo. Next is for those who are taking ACLS, see you at 1 o'clock in the afternoon. Nakabukas lang tong laptop ko. I'm in your Zoom. Just in case may tanong kayo, just toss it in chat or you can direct message me. Okay. So thank you very much and I wish you the best in your exam. See you at 1 p.m.
Thank you po, Doc.
Thank you po, Doc.
Nasend ko na po yung link ng exam sa meeting chat po. You can take your exam na po while watching the video po na ipi-play ko po. Thank you po.
What's the address of the emergency?
Address 50 Wheeler Road, Oakdale.
LFA Station 1, Medic 5, possible cardiac arrest. 50 Wheeler Road, across Villard.
And is he breathing?
No, he's not breathing. Please help.
Dispatch LFA engine 105 en route to 50 Wheeler Road.
Copy engine 1 en route to 50 Wheeler. Update on patient, 60-year-old male. Bystander CPR is in progress.
Copy. CPR in progress.
Go ahead and set your phone down, put me on speaker.
Hold on.
Okay, can you hear me?
Yes.
Okay, let's get him flat on his back. I'm going to tell you how to do CPR. Okay, I want you to put one hand on top of the other, right in the center of his chest.
Okay.
We're going to pump the chest hard and fast, at least 2 times per second and 2 inches deep. We're going to do this 600 times or until help can take over.
Okay.
This is the pace that I want you to do. It's 1, 2, 3, 4.
Dispatch. LFA Command 2 en route. I'm mobile and nearby. ETA 1 minute.
Cardiac arrest is the loss of the heart's ability to pump blood through the body. The most dramatic occurrence, sudden cardiac arrest, can happen anywhere with little or no warning. Victims unexpectedly collapse. Breathing stops. Sudden cardiac arrest occurs when the normal electrical impulses in the heart suddenly become disorganized. Normal mechanical contraction of the heart muscle is lost, and a chaotic quivering condition known as ventricular fibrillation can occur. Blood flow to the body, along with the oxygen it carries, abruptly stops. Within minutes, brain cell death starts to occur from the lack of oxygen.
Fire department! In here! We're in here! Hurry!
Okay, let me in here.
Okay, thank you.
Sir, are you okay?
Confirmed cardiac arrest.
Cardiopulmonary resuscitation, or CPR, is the immediate treatment for a suspected cardiac arrest. CPR can restore limited oxygen to the brain and other vital organs through a combination of chest compressions and rescue breaths. However, CPR alone is not enough.
1, 2, 3, 4, 5, 6.
The most
7.
effective way to end fibrillation is defibrillation, using a defibrillator and electrode pads adhered to the chest. A controlled electrical shock is sent through the heart to stop ventricular fibrillation, allowing the heart's normal electrical activity to return and restore the normal pumping action of the heart. Successful defibrillation is highly dependent on how quickly a shock can be delivered. For each minute in cardiac arrest, the chance of surviving goes down by about 10%. After as few as 10 minutes, survival is unlikely. An automated external defibrillator, or AED, is a portable, computerized device that is simple to operate. The use of AEDs by emergency responders and other healthcare personnel allows defibrillation to occur much earlier than before. Turning on an AED is as simple as pushing a power button. Once on, an AED provides voice instructions to guide an operator through its use.
Apply pads to patient's bare chest.
An AED automatically analyzes the heart rhythm to determine if a shock is needed.
Stay clear of patient. Analyzing.
If a shock is advised by the AED,
Shock advised.
Everyone clear?
the operator clears the person and pushes a button to deliver the shock.
Shock delivered. Begin
Immediate
CPR.
high-quality CPR and early defibrillation with an AED can double or even triple the likelihood for survival. Most cardiac arrests occur outside of a hospital. Most of those occur in the home. The chain of survival is often used to describe the best approach for treating cardiac arrest. Each link in the chain is essential for a person to survive. If a single link is weak or missing, The chances for survival are greatly reduced. The greatest chance for survival exists when all the links are strong. The chain of survival for cardiac arrests outside of a hospital consists of 5 interdependent links: early recognition of cardiac arrest and prompt activation of the emergency response protocol for the setting, immediate CPR with high-quality chest compressions, rapid defibrillation or electrical shock to the heart, effective basic and advanced EMS care and transport, and effective post-cardiac arrest care at a hospital. Cardiac arrest inside a hospital usually occurs when a known medical condition worsens. The chain of survival inside a hospital reflects how resuscitation fits into the overall picture of medical care: monitoring, prevention, and treatment of pre-arrest conditions, early recognition of cardiac arrest, and prompt activation of the emergency response protocol for the setting, immediate CPR with high-quality chest compressions, rapid defibrillation or electrical shock to the heart, and effective post-cardiac arrest care.
Engine 2312, dispatch.
Engine 2312.
I have an update on patient condition. Caller reports patient was caught in a fallen tree and submerged for several minutes. The patient is now out of the water, and we're attempting to get bystander CPR initiated now.
Copy, dispatch. Engine 2312, on scene now.
Copy 2312 on scene.
He got caught up on a strainer. I just got him out.
Sir, can you hear me?
Unlike sudden cardiac arrest, in which the heart is the primary problem,
No pulse.
cardiac arrest can also be the end result of a blocked airway or loss of breathing. This is known as secondary cardiac arrest.
Apply pads to patient's bare chest.
Problems such as hazardous breathing conditions in a confined space, drowning, and drug overdoses are all causes of secondary cardiac arrest. With no incoming oxygen, the heart progressively becomes weaker until signs of life become difficult or impossible to assess.
Stay clear of patient. Analyzing. Stay clear of patient. No shock advised. Begin CPR.
Medic 849, engine 2312.
If the heart is simply too weak to create obvious signs of
Confirm
life,
cardiac arrest.
immediate CPR with an emphasis on effective rescue breaths may be the only chance to restore them. The abuse of opioid drugs is a serious and growing health problem. Increasing prescriptions for opioid pain relievers such as hydrocodone and oxycodone have made them more commonly available. The increased availability and use of heroin, a highly addictive opioid, is also contributing to the problem. As a result, overdoses and deaths from prescription opioids and heroin have risen dramatically. Opioids taken in excess can depress and stop breathing. Opioid overdose is a common cause of secondary cardiac arrest. Suspicion of opioid use may present itself through questioning of bystanders or by observation of the person and location in which she was found. Naloxone, also known as Narcan, is a medication that can temporarily reverse the life-threatening effects of opioids. It's easy to administer, either through an auto-injector device or through an aerosol that is sprayed into the nose. Initiate and establish BLS care prior to using naloxone for suspected opioid overdose.
Can you hear me? Hello? Hello?
Command, this is engine 105.
This is command, go ahead.
We have a child in cardiac arrest at our location. We need a medic unit right away.
Copy that.
Children are more likely than adults to experience secondary cardiac arrest due to an airway or breathing problem. When describing age groups in relation to CPR, an infant is younger than 1 year of age. A child is 1 year of age until the onset of puberty. Puberty can be identified by breast development in females and the presence of armpit hair in males. A person is considered an adult after the onset of puberty. The chain of survival for children and infants emphasizes prevention and giving effective rescue breaths as part of CPR. Prevention of airway and breathing emergencies. Early CPR with an emphasis on effective rescue breaths, and if needed, defibrillation with an AED. Prompt activation of the emergency response protocol for the setting. Effective basic and advanced EMS care and transport, and effective post-cardiac arrest care at a hospital. The quality of CPR matters. Higher quality CPR performance is directly related to an improved chance of survival. There are two key elements of high-performance CPR: high-quality CPR skills and a more efficient team approach to resuscitation. CPR skills can vary greatly depending on a person's experience, practice, and physical ability. It is normal for there to be a gap between perfect skills and what you can actually perform. An important goal is to narrow that gap as much as possible. High-quality CPR skills include beginning CPR compressions within 10 seconds of determining cardiac arrest, compressing fast at a rate of 100 to 120 times per minute, compressing hard, at least 2 inches on an adult and at least 1/3 the depth of the chest for children and infants, allowing for complete chest recoil at the top of each compression, minimizing interruptions to compressions, giving effective rescue breaths that create a visible chest rise, and avoiding excessive air on rescue breaths. CPR feedback devices that measure skill performance in real time can be used to optimize CPR. High-quality skills are only part of high-performance CPR. Orchestrating the actions of a resuscitation through a team approach, much like a pit crew in a car race, can significantly improve the care being provided. An effective team approach has clearly defined roles, uses clear and effective communication, allows multiple treatment actions to occur at the same time, maintains high-quality CPR by allowing team members to switch places when tired, and minimizes overall interruption times. The only way to develop a high-performance CPR approach is through ongoing commitment and practice. CPR skills can deteriorate significantly in as little as 3 months. Shorter, more frequent, scenario-based retraining sessions are reasonable for maintaining skills for individuals likely to respond to a cardiac arrest. Emergency situations often present hazards to your safety and health.
He's over there. He was mixing chemicals and fell.
Okay.
Your personal safety is the highest priority, even before the safety of an ill or injured person.
Go and get hazmat on. Tell them we got 1 man down. There's an unknown chemical.
Putting yourself in danger to help someone can make the situation worse. Always pause for a moment before approaching. Look for obvious hazards. Consider the possibility of hidden dangers. If the scene is not safe, do not enter it until hazards have been minimized or eliminated. When caring for someone, you can be exposed to blood or other potentially infectious body fluids. While the risk of contracting a disease is very low, you must take measures to reduce exposure. The most common infection bloodborne diseases and pathogens include hepatitis B, hepatitis C, and HIV, the virus that causes AIDS. Standard precautions is a set of protective practices used when providing care, whether or not an infection is suspected. Personal protective equipment, or PPE, describes protective barriers worn to prevent exposure to infectious diseases. Reducing exposure lowers the chance of infection. Disposable gloves should not be given by emergency response personnel. BLS providers and the locations in which they work vary. So does the way in which they activate a response for higher levels of care. Activation is typically defined by emergency response protocol. A BLS provider or member of a workplace emergency response team may radio a centralized communication person to contact EMS, or the provider may call EMS directly. An EMS provider may request help from advanced care providers or inform other incoming responders about the details of the situation found. Inside a hospital, a floor nurse may call a code to which a resuscitation team with appropriate equipment will respond. To be an effective BLS provider, you must understand your local protocols on how to call for additional help. The quality of CPR skills can be improved during practice with the use of a real-time feedback device that measures things such as compression depth, compression rate, and overall timing. Real-time feedback allows a user to make ongoing adjustments to maintain and reinforce high-quality skills. The Loop learning system is designed for CPR skill practice. The Loop feedback device is placed directly on a mannequin chest. Compressions are done normally on top of the device. A Loop software program allows a user to set up timed sessions in which the Loop system provides real-time visual and recorded measurement of chest compression rate and depth. Compression rate can be easily seen at the top of the screen. Adjust your compression rate to keep it in the green area. Compression depth is measured across the bottom of the screen. Compression spikes that are green indicate a compression that is ideal. Red spikes indicate a compression that is too shallow. Watch your performance in real time on a computer screen and make adjustments as necessary. The Loop software also records your performance and allows for overall review after finishing a session. There are basic CPR skills used to provide the most effective approach to cardiac arrest. These include high-quality chest compressions, high-quality rescue breaths using a CPR mask or bag mask device, use of an automated external defibrillator, and checking for life-threatening emergencies using a BLS assessment. External compression of the chest increases pressure inside the chest and directly compresses the heart, forcing blood to move from the chest to the lungs, heart, brain, and the rest of the body. To perform proper compressions, the person needs to be positioned on his or her back on a flat, firm surface. Kneel close to the side of the person. Place the heel of one hand on the center of the chest on the lower half of the breastbone. Place the heel of your other hand on top of and parallel to the first. Bring your body up and over the chest so your shoulders are directly above your hands. Bending at the waist, use your upper body weight to push straight down to a depth of at least 2 inches. Lift your weight and allow the chest to fully return to its normal position. Move immediately into the downstroke of the next compression. Focus on high-quality techniques. Compress deeply more than 2 inches. It is likely you will not compress deep enough. While injury could occur from deeper compressions, do not let the fear of this affect compression depth. Compress fast, between 100 and 120 times per minute. Do not let a higher compression speed result in a shallower compression depth. Do not lean on the chest between compressions. Blood pressure is created and maintained with ongoing compressions. When compressions stop, pressure is quickly lost and has to be slowly built up again. Allow the chest wall to fully recoil or rebound at the top of each compression. Minimize interruptions when doing compressions. When compressing properly, you may hear and feel changes in the chest wall. This is normal. Forceful external chest compressions may cause chest injury, but are critical if the person is to survive. Reassess your hand positioning and continue compressions. As an alternative approach, you can grasp the wrist of one hand with the other when it is difficult to compress with the heels of both hands. To perform chest compressions on a child, position the child face up on a flat, firm surface. Place the heel of one hand on the lower half of the breastbone, just above the point where the ribs meet. Using upper body weight, compress at least 1/3 the depth of the chest, or about 2 inches. Lift your weight and allow the chest to return to without pausing. Continue into the of 1 decompressions. Press fast and deep and allow the chest to recoil to its normal position at the top of each compression. Compressions on a larger child can be tiring. If needed, use 2 hands to perform compressions. To perform chest compressions on an infant, position the infant face up on a flat, firm surface. Place 2 fingertips on the breastbone just below the nipple line. Compress at least 1/3 the depth of the infant's chest, or about 1 1/2 inches. Allow the chest to return to its normal position. Without pausing, continue into the downstroke of the next compression. Continue compressing at a rate of 100 to 120 compressions per minute. Remember to compress fast and deep and allow the chest to recoil to its normal position at the top of each compression. When doing chest compressions with 2 or more providers, encircle the sides of the chest with your hands and use your thumb tips to compress the lower third of the breastbone. Rescue of your other hand under the bony part of the chin. Apply firm backward pressure on the forehead while lifting the chin upward. This will tilt the head back and move the jaw forward. Maintain the head tilt with your hand on the forehead. Leave the mouth slightly open. Avoid pressing into the soft tissue of the chin with your fingers, as this can also obstruct the airway. Even though the risk is very low, as a BLS provider, use a protective barrier such as a CPR mask when giving rescue breaths to minimize your exposure to infectious disease. Before using a CPR mask, quickly inspect it to make sure the one-way valve is in place. Place the mask flat on the person's face with the top of it over the bridge of the nose. Use your thumb and forefinger to provide uniform pressure around the top of the mask. Use the thumb of your hand lifting the chin to control the bottom. Tilt the head and lift the chin to open the airway. Lift the face up into the mask to create an airtight seal. Blow through the valve opening to deliver breaths. Each breath should be about 1 second in length and have only enough air to create a visible rise of the chest, but no more. Additional air is unnecessary. Remove your mouth and let the person exhale completely after each breath. Take a fresh breath between delivering breaths. If you remove your hands from the head, the airway will close again. It is necessary to open the airway each time you give rescue breaths. Rescue breaths for children and infants are performed in the same manner as for adults. It is recommended to use an appropriately sized pediatric CPR mask. The airway of an infant may become blocked if the head is tilted too far. Position an infant's head in a neutral position, in which the ear openings are level with the infant's shoulders. Special care should be taken not to give too much air in a single breath. Provide only enough air to make the chest visibly rise, but no more. The jaw thrust is a convenient airway technique, especially when working in a team or when using a bag mask device. Position yourself above the head of the person. Place the mask flat on the person's face with the top of it over the bridge of the nose. Place your thumbs and heels of your hands along the sides of the mask to seal the mask against the face. Hook your index fingers under the angles of the jaw just below the ears. Lift and tilt the head backwards. Use counter pressure against the cheeks and displace the jaw and move it upward and into the mask. This will open the airway. Blow through the valve opening to deliver breaths. Each breath should be about 1 second in length and have only enough air to create a visible rise of the chest, but no more. A bag mask device allows rescuers to provide rescue breaths without having to blow into a person's mouth. It can also deliver high concentrations of oxygen when connected to an oxygen delivery system. A bag mask can be used by a single BLS provider, but is best used by 2. From above the head, place the mask flat on the person's face with the top over the bridge of the nose and use the jaw thrust airway technique to establish an open airway. Have a second BLS provider squeeze the bag with both hands to ventilate. Squeeze the bag slowly enough to deliver each breath over 1 second. Make the chest visibly rise, but no more. When using a bag mask as a single provider, position yourself above the person's head. Place the mask flat on the person's face with the top over the bridge of the nose. Use the thumb and index finger of one hand around the valve in a C position to seal the mask against the face. Use your remaining 3 fingers in an E position under the bony part of the chin. Tilt the head back and lift the jaw up and into the mask to open the airway. Use your free hand to squeeze the bag and deliver the rescue breaths. Deliver each breath over 1 second. Make the chest visibly rise, but no more. Bag mask rescue breaths for children or infants are done in the same manner as an adult. It is recommended that an appropriately sized pediatric bag mask be used. When caring for someone who is seriously injured, establishing an open airway is a higher priority than protecting a possible injury to the spine. Without a patent airway, a person will not survive regardless of injury. When the potential for a neck injury exists, a jaw thrust without head tilt can be used to open the airway. Position yourself above the head of the person. Place the mask flat on the person's face with the top of it over the bridge of the nose. Place your thumbs and heels of your hands along the sides of the mask to seal the mask against the face. Hook your index fingers under the angles of the jaw just below the ears. Use counter pressure against the cheeks to displace the jaw and move it upward and into the mask without tilting the head. If you find the jaw thrust without head tilt does not open the airway, use jaw thrust with head tilt or the head tilt chin lift technique instead, even if neck injury is suspected. You must establish an airway for a person to survive.
Mrs. Williamson collapsed in the treatment room. Activate EMS.
Remove clothes from patient's chest. Peel white pads from gray plastic case. Attach pads to bare skin exactly as shown. Stay clear of patient. Analyzing heart rhythm. Shock advised. Stay clear of patient. Press the flashing orange button now. Shock delivered. Begin CPR.
AEDs are designed to be simple to operate. Voice instructions, lights, and screen prompts guide an operator through use. There are many different brands of AEDs, but the same basic steps for operation apply to all. Opening the lid will turn on the power for some AEDs. With others, simply press the power button. This starts voice instructions and readies the device for use.
Apply pads to patient's bare chest.
Pads must be applied to a bare chest. If needed, quickly tear away or use scissors to remove all clothing from the torso. Dry the chest quickly if wet. For a woman, remove the bra to provide better access for pad placement. Locate and pull out the defibrillation pads. The pads have pictures on them to show proper placement. Peel the pads from the backing sheet one at a time and place each as shown in the pictures. Place one pad below the right collarbone above the nipple and beside the breastbone. Make sure it adheres well by pressing it flat. Place the other pad lower on the left side over the ribs and a few inches below the armpit. Again, press firmly. Most AEDs automatically start analyzing once the pads are in place.
Analyzing.
Stop CPR. Movement can interrupt the analysis. Be certain that no one is touching the person. If defibrillation is advised, the AED will begin to charge for shock delivery.
Shock advised. Stay clear of patient. Deliver shock now.
Quickly look to make sure no one, including you, is in contact with the person before delivering the shock. For most AEDs, a button is pressed to deliver the shock.
Delivered.
Once a shock has been delivered, immediately resume CPR, starting with chest compressions. In cases when a shock is not indicated by the AED,
No shock advised.
immediately resume CPR. AEDs are also designed to detect problems during use and guide you through corrective actions.
Press pads firmly to patient's bare skin.
If a troubleshooting message occurs at any time,
Insert connector firmly.
stay calm and follow the AED's voice instructions. Cardiac arrests involving children are likely caused by the initial loss of the airway or breathing. High-quality CPR with effective rescue breaths may be the only treatment required for successful resuscitation. However, conditions can occur for which defibrillation of a child or infant is warranted. The steps for using an AED on a child or infant are similar to an adult. Most AEDs have specially designed pads or mechanisms available that reduce the defibrillation energy to a level more appropriate for a smaller body size. For smaller children and infants, place one pad on the center of the chest just below the collarbones. Attach a second pad on the center of the back between the shoulder blades. Follow the AED's voice instructions to provide the appropriate care. The BLS assessment is a simple way to quickly identify if resuscitation is required. It is the same for all ages and is performed quickly. Before anything else, pause and assess the scene for hazards. Take standard precautions to prevent contact with blood or other potentially infectious materials. If it is safe, check for responsiveness. Tap or squeeze the person's shoulder and ask loudly, "Are you all right?" For an infant, tap the foot. If unresponsive, quickly look for signs of normal breathing. At the same time, check the carotid pulse in the neck. Normal breathing is effortless, quiet, and regular. Weak, irregular gasping, snorting, or gurgling sounds, known as agonal breaths, can occur early in cardiac arrest. These actions provide no usable oxygen. This is not normal breathing. For an adult, check the carotid pulse in the neck. Locate the bony Adam's apple with your fingers, slide them into the groove between the windpipe and the muscle on the side of the neck closest to you. For a child, check the carotid pulse or the femoral pulse in the leg. Place your fingers just below the middle of the crease where the leg and torso meet. For infants, feel the brachial pulse on the inside of the upper arm. Lay your fingers across the arm and compress inward. Take at least 5 but no longer than 10 seconds to assess breathing and pulse. If you are unsure, assume they are absent. If not already being done, tell another person to activate the protocol and get an AED. Relay what you have found so it can be passed on. Your assessment of the person and situation will determine the care you provide. If the person is breathing normally and uninjured, place her in a side-lying recovery position. Place the arm nearest you up alongside the head. Bring the far arm across the chest and place the back of the hand against the cheek. Grasp the far leg just above the knee and pull it up so the foot is flat on the ground. Grasping the shoulder and hip, roll the person toward you in a single motion, keeping the head, shoulders, and body from twisting. Make sure the head ends up resting on the extended arm. Roll far enough for the face to be angled towards the ground. Make sure there is no pressure on the chest that might restrict breathing. The recovery position helps protect the airway by using gravity to drain fluids from the mouth and keep the tongue from blocking the airway. Frequently assess and monitor the person's breathing. The condition can quickly become worse and require additional care. If the person is not breathing or only gasping, but definitely has a pulse, he is in respiratory arrest. The indicated care is rescue breathing, which is ongoing rescue breaths provided without chest compressions. If the person is not breathing or only gasping and does not have a pulse, he is in cardiac arrest. The indicated care is CPR, a repeating combination of chest compressions and rescue breaths. Always perform a BLS assessment to quickly determine the need for CPR. Ensure the scene is safe. Assess responsiveness. Assess for breathing and pulse. Activate the emergency response protocol for your setting and get an AED.
Heather? Heather, breathe! Heather! Heather, breathe, please!
What's going on here?
I think she overdosed. She took something new.
Okay, let me check. Ma'am, can you hear me? Ma'am, can you hear me?
A person in respiratory arrest has stopped breathing but still has a beating heart.
Dispatch P37, can you advise EMS? This is a possible overdose. She's not breathing but has a carotid pulse. I'm gonna start rescue breathing.
Copy P37. Possible overdose. Rescue breathing in progress.
Without immediate intervention, respiratory arrest can quickly progress to cardiac arrest.
James, I've got my naloxone kit.
Great, go ahead and give it. I'm gonna keep giving rescue breaths.
Okay, James, I'm ready.
Okay, after my next breath.
Before anything else, pause and assess the scene for hazards. If it is safe, quickly assess for responsiveness. If unresponsive, quickly check for signs of normal breathing. At the same time, check for a pulse. Take no longer than 10 seconds to assess. This person is unresponsive, not breathing, and has an obvious pulse. Have someone activate your emergency response protocol and get an AED if one is available. Establish an airway and give a rescue breath. Continue to provide one high-quality rescue breath every 5 to 6 seconds, or about 10 to 12 breaths per minute. Reassess the pulse about every 2 minutes. Take no longer than 10 seconds to do so. If the pulse is absent and tissue signs indicate poor perfusion, or you are unsure, perform CPR starting with compressions. If an opioid overdose is suspected, consider the use of naloxone, as indicated by your local protocols. The rate of rescue breaths when performing rescue breathing for children and infants is 1 breath every 3 to 5 seconds, or about 12 to 20 breaths per minute. When monitoring the pulse of an infant, check for the brachial pulse in the arm. Add compressions and perform CPR on a child or infant if the pulse rate is 60 beats per minute or fewer, and it appears the heart is too weak to adequately move blood forward. Signs of poor blood perfusion include pale, mottled, or bluish skin color, weak pulse, and cool extremity temperature.
Let me take over for you.
How long has he been down?
Just a few minutes.
Sir, are you all right? One, two, three, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21.
Stay clear of patient. Analyzing. Shock advised.
Everybody clear?
Clear.
Stay clear of patient. Deliver shock now. Shock delivered.
1, 2, 3.
Immediate high-quality CPR and defibrillation with an AED can double or even triple the chance for survival from sudden cardiac arrest. Before anything else, pause and assess the scene for hazards. If it is safe, quickly assess for responsiveness. If unresponsive, quickly check for signs of normal breathing. At the same time, check for a pulse. Take no longer than 10 seconds to check. This person is unresponsive, not breathing, and has no pulse. Have someone activate your emergency response protocol and get an AED if one is available. Begin high-quality CPR immediately, starting with compressions. Compress at a rate between 100 and 120 times per minute. After 30 compressions, give 2 rescue breaths. Establish an airway first and give only enough air to see the chest rise but no more. Do this quickly in less than 10 seconds. Return to compressions and perform ongoing cycles of 30 compressions and 2 rescue breaths. Compress hard and fast and allow the chest to fully recoil to its normal position after each compression. Use the AED immediately when it arrives. Turn on the AED and adhere the defibrillation pads to the bare chest. Allow the AED to analyze the heart.
Analyzing.
If a shock is advised,
Shock advised. Stay clear
make
of
sure you are
patient.
not touching the person before delivering the
Deliver
shock.
shock now. Shock delivered.
Immediately after a shock is delivered, resume CPR, starting with compressions. Voice instructions and additional analysis by the AED will guide you through further care. Don't stop until the person shows signs of life, another BLS provider takes over, or you are too exhausted to continue.
Hold up, stop CPR. He's responding.
If a person begins to breathe, moves, or respond, stop CPR and place the person in the recovery position. Leave the AED turned on and the pads attached in case cardiac arrest reoccurs. In cases where a shock is not indicated by the AED,
No shock advised.
immediately resume CPR. Continue to follow the AED's instructions. Compression-only CPR is being widely promoted to people who are not trained in CPR in order to encourage and increase the chance for bystander care. Simple instructions in compression-only CPR are being shared through things such as social media and public service announcements. EMS dispatchers are also providing compression-only instructions during emergency calls. However, compression-only CPR is a limited approach to treating cardiac arrest. At some point, rescue breaths are essential for all cardiac arrests, especially for secondary cardiac arrest. As a trained BLS provider, perform both compressions and breaths during CPR. Most arrests involving children are secondary to the initial loss of an airway or breathing. Immediate CPR with an emphasis on effective rescue breaths may provide the only chance for survival. Before anything else, pause and assess the scene for hazards. If it is safe, quickly assess for responsiveness. If unresponsive, quickly check signs for normal breathing. At the same time, check for a pulse. Take no longer than 10 seconds to check. This child is unresponsive, not breathing, and has no pulse. Have someone activate your emergency response protocol and get an AED if one is available. Begin high-quality CPR immediately, starting with compressions. Compress at a rate between 100 and 120 times per minute. After 30 compressions, give 2 rescue breaths. Establish an airway first and give only enough air to see the chest rise, but no more. Do this quickly in less than 10 seconds. Return to compressions and perform ongoing cycles of 30 compressions and 2 rescue breaths. Compress hard and fast and allow the chest to fully recoil to its normal position after each compression. Use an AED immediately if one arrives. Don't stop until the child shows signs of life, another BLS provider takes over, or you are too exhausted to continue. Infant CPR is similar to adult and child CPR. Pause and assess the scene for hazards. If it is safe, quickly assess for responsiveness. If unresponsive, quickly check signs for normal breathing. At the same time, check for a pulse. Take no longer than 10 seconds to check. This infant is unresponsive, not breathing, and has no pulse. Have someone activate your emergency response protocol and get an AED if one is available. Begin high-quality CPR immediately, starting with compressions. Compress at a rate between 100 and 120 times per minute. After 30 compressions, give 2 rescue breaths. Establish an airway first and give only enough air to see the chest rise, but no more. Do this quickly in less than 10 seconds. Return to compressions and perform ongoing cycles of 30 compressions and 2 rescue breaths. Compress hard and fast and allow the chest to fully recoil to its normal position after each compression. Don't stop until the infant shows signs of life, another BLS provider takes over, or you are too exhausted to continue.
And punch it out now, all the way in front. If you want a little bit more intensity, push with the palm. Keep those hands in the water. Now push, push. Lift up those knees, get those shoulders down and back. Let's go. Good job. Take it to the side. Same thing. This is a little bit easier. Palms a little bit harder. Get those knees up. Up and forward. Let's go. Done.
High-performance CPR not only requires high-quality CPR skills, but it also relies on the efficiency of multiple providers working as a team. It is common for multiple providers to respond to a cardiac arrest, but a resuscitation may start with a single provider. Other providers can be integrated as they arrive. When 2 providers are available to perform CPR, one performs chest compressions, while the other gives rescue breaths. For adults, the ratio remains at 30 compressions and 2 rescue breaths. The compressor pauses to allow rescue breaths to be given. Give breaths as quickly as possible to minimize the interruption. High-quality compressions are tiring. If an AED is not attached, switch every 2 minutes at the end of a CPR cycle. Clearly communicate the details of the switch ahead of time to prevent confusion. If a third provider is available, have him or her relieve the compressor while rescue breaths are being given to shorten the interruption. With 2 providers, use a 15:2 ratio of compressions and breaths for a child or infant. When 2 or more BLS providers respond in an emergency, orchestrating actions is necessary for high-performance resuscitation.
Yes. Our lifeguards are responding now.
Stay clear of patient. Analyzing. Stay clear of patient. Shock advised. Stay clear of patient. Deliver shock now. Shock delivered.
It is important to recognize the common roles identified for a team resuscitation and be ready to assume any one of them. The compressor is typically the initial responding provider. A BLS assessment is done and CPR is started, beginning with compressions. When a second person is available, he becomes the ventilator and takes responsibility for maintaining an airway and giving rescue breaths. An AED operator brings and quickly attaches defibrillation pads without interrupting CPR. This person is also responsible for the efficient and safe delivery of defibrillation shocks.
1, 2, 3, 4, 5. Yes, I hear the sirens. Oh, they're here.
Stop CPR. Stay clear of patient. Analyzing. Shock advised. Stay clear of patient. Deliver shock now. Shock delivered.
1, 2, 3, 4, 5, 6, 7, 8, 9.
The team leader takes a general perspective to supervise and improve overall team performance.
What's the story? He was exercising in the water and then he collapsed. How long since you started?
Effective team communication is essential. Speak calmly and in simple terms.
2 to 3 minutes. Was it witness? Yes.
This person is also the main point of internal and external communication. If you are asked to do something, repeat it back to confirm and reinforce the instructions. Other roles may be filled as necessary. A second ventilator to help with the use of bag mask, or a scribe or reporter to document patient information, treatments, and intervention times. In the transition to more advanced care, additional roles for actions such as administering medications may be added. When an AED is attached, plan to relieve the compressor during the time an AED analyzes the heart. This typically occurs every 2 minutes.
Are you guys clear?
After a shock is delivered or no shock is indicated, the new compressor immediately resumes CPR, starting with compressions. After a resuscitation, a facilitated group discussion or debriefing lets team members reflect on the care provided. Debriefing identifies issues with skills, equipment, or established procedures. It also emphasizes and reinforces what was done well. Changes based on debriefing can improve the overall standard of care for future resuscitations. Using realistic, scenario-based practices is an excellent way to prepare for team-based resuscitations. Practice using a team approach. An advanced airway device may be inserted into the throat during a resuscitation to maintain an open airway. When an advanced airway device is in place, the mask from the bag mask is removed and the bag is attached directly to the device to ventilate. As with other approaches to rescue breaths, provide enough air to make the chest visibly rise. Once an advanced airway device is in place, it is no longer necessary to pause compressions to give breaths. Provide continuous compressions at a rate of 100 to 120 per minute. Regardless of age, provide a single breath every 6 seconds or 10 times a minute. Choking can occur when a solid object, such as a piece of food, or a small object enters a narrowed part of the airway and becomes stuck. On inhalation, the object can be drawn tighter into the airway and block air from entering the lungs. A forceful thrust beneath the ribs and up into the diaphragm can pressurize the air in the chest and pop an obstruction out of the airway. Compression of the chest over the breastbone can also create enough pressure to expel an object. To provide the appropriate care, you must first be able to recognize the difference between a mild blockage and a severe blockage. With a mild blockage, a person can speak, cough, or gag. This type of blockage is typically cleared by the affected person naturally through forceful coughing. Allow someone with a mild blockage to try and resolve the problem on his own. Stay close and be ready to take action if things worsen.
Morning, Chrissy. How are you feeling?
Much better, thank you.
Good. You need to get another set of your vital signs after you finish your breakfast.
Sure.
When a severe blockage occurs, a person cannot take in enough air to dislodge the object. Signs of severe obstruction include very little or no air exchange, the lack of sound, and the inability to speak or cough forcefully.
Chrissy? Are you choking? I can help, okay? Stand up. Try and get a breath. Try and get your breath. Let's sit you down here.
Kneel behind someone who is sitting. Reach around and locate the person's navel with your finger. Make a fist with your other hand and place the thumb side against the abdomen just above your finger and below the ribs. Grasp your fist with the other hand. Give a quick inward and upward thrust. Each thrust needs to be given with the intent of expelling the object. Repeat thrusts until the person can breathe normally. If the person becomes unresponsive, carefully lower her to the ground. If not already done, activate the emergency response protocol for the setting. Begin CPR starting with compressions. Look in the mouth for an object after each set of 30 compressions and before giving rescue breaths. Remove any object if seen. Continue care until the person starts to move or another BLS provider takes over. When someone is clearly pregnant or obese, use chest thrusts instead of abdominal thrusts. Position yourself directly behind the person. Reach under the armpits and place the thumb side of your fist on the center of the chest. Grasp your fist with your other hand and thrust straight backward. Try not to put pressure on the ribs. If you are choking and alone, try pressing your abdomen quickly against a rigid surface, such as falling onto the back of a chair. If one is not available, attempt abdominal thrusts on yourself. Young children are particularly at risk for choking because of the small size of their air passages, inexperience with chewing, and a natural tendency to put objects in their mouths. For a choking child, the approach is nearly the same for adults. It might be easier to kneel behind a choking child to deliver thrusts. Use less force on your thrusts. Because infants do not speak, it may be more difficult to recognize choking. A sudden onset differentiates it from other breathing emergencies. Signs include weak, ineffective coughs and the lack of sound even when an infant is clearly attempting to breathe. If you suspect an infant is choking, act quickly. Lay the infant face down over your forearm with legs straddled and with the head lower than the chest. Support the head by holding the jaw. Using the heel of your other hand, give 5 back blows between the shoulder blades. Next, sandwich the infant between your forearms and turn her onto her back with legs and arms straddling your other arm. Place 2 fingers on the breastbone just below the nipple line and give 5 chest thrusts. Repeat back blows and chest thrusts until the infant can breathe normally. If the infant becomes unresponsive, gently place her onto a firm surface. If not already done, have someone activate your emergency response protocol and begin CPR. Look in the mouth for an object after each set of compressions and prior to giving rescue breaths. Remove any object if seen. Abdominal and chest thrusts can cause internal injury. Anyone who has had these maneuvers used on them should be evaluated further to ensure there are no injuries. Opioid overdose can severely reduce or eliminate a person's effort to breathe. Naloxone is a drug that can quickly reverse this effect. The initiation of CPR, activation of your emergency response protocol, and use of an AED should not be delayed to administer naloxone for a suspected opioid overdose. One method of administering naloxone is through a nostril using a pre-filled syringe with an attached mucosal atomizing device. If you have reason to suspect the person's condition is related to an opioid overdose, administer naloxone without interrupting ongoing care. Take both parts of the pre-filled syringe out of the packaging. Remove both caps from the larger hollow tube and the cap from the smaller capsule with the medication. Gently slide the medication capsule into the hollow tube and fully screw the capsule in clockwise. Gripping the plastic wings of the atomizer, fully screw the tip of the hollow tube clockwise onto the atomizer. Insert the white cone tip of the atomizer snugly into a nostril. Give a short, vigorous push on the end of the medication capsule and spray about half of the medication into the nose. Repeat the technique on the other nostril to give the remaining medication. Continue CPR and the use of an AED if one is available. If normal breathing does not return, administer a second dose of naloxone using another pre-filled syringe. Calm and reassure someone who responds. Opioid withdrawal symptoms can occur and be unpleasant. The effect of naloxone is temporary, and breathing may become depressed again. Anyone given naloxone should have continued medical evaluation.
Hello po. You can take your lunch na po. See you at 1 p.m. po. Thank you po.
Okay, good afternoon. So we start. Welcome to the Advanced Cardiovascular Life Support Program of
Yes po,
WIPAM
Doc.
under American Safety and Health Institute. This is the ACLS we conduct here is 2020 with inserts from 2022 interim guidelines. So medyo lamang tayo nasa advanced post tayo ika nga when it comes to the program kasi updated tayo. Now, I'll start with my general slide on ACLS. Before we will discuss stations, no? Pag sinabing stations, yung i-highlight ko sa inyo mamaya, what are the expectations when we take ACLS program. So this is the virtual. Pandemic kasi natuloy-tuloy na lang yung virtual, although we conducted a live and in color ACLS in Catanduanes mismo sa hospital. If you plan to have ACLS in your hospital, kontakin niyo lang si Ma'am Joy ninyo. So kahit saan kayo lupalop sa mundo, pwede tayo magturo. But there are some procedures before natin magawa yon for some safety reasons. Number one, tumataas na naman ang COVID. No? Ngayon, bagong strain. So ACLS, pag nagsulat kayo ng ACLS, advanced hindi yung walang D, advanced cardiovascular, hindi cardiac. The main problem is the vessel, vascular. So advanced cardiovascular life support. For those who are taking ACLS na naka-BLS na, I'm Dr. Ted Esguerra. I specialize in pre-hospital care, in field trauma, in wilderness medicine, combat medicine, and disaster medicine. So, kung magtanong kayo saan yung program na yan, wala yan dito sa Pilipinas. I got it when I was working sa labas. No? So, I'm more of a pre-hospital or EMS doctor. But I handle some positions here medically, as aeromedical director ng INAIC Air Care and as medical director of Project Michelangelo and other international humanitarian organizations. I am also the rescue doctor of the Turkey contingent of the Filipinos that went to Turkey to render post-earthquake assistance. Our objective is to describe ACLS and review the chain of survival, katulad kanina, and we will study ECG, yung mga ACLS ECG, ECG related to ACLS or pathological ECG. And we go into ACLS pharma and stations, advanced airway, cardioversion, transcutaneous pacing, intraosseous. Tapos paano piniperform yung megacode. So like BLS, ACLS is an intervention. No? It is a set of algorithm on how you will intervene to an arresting heart or a stroke or a ACS, like a myocardial infarction, or when you have a patient who has tachyarrhythmia, okay, bradyarrhythmia, and we settle the reversible H and T's. I will discuss what's H and T, letter H and letter T, no? Yung mga reversible factors sa ACLS. And it talks about using machines like defibrillator, cardioverter, transcutaneous pacer. So meron tayong mga sessions. And the requirement is you must be trained. No? Parang kayo, pag na-train, nabigyan kayo ng certificate, then you will be invited in the code blue team. No? If you have a code blue team. I don't know what you call it in your hospital. So it's the team that responds to a cardiac emergency sa inyong hospital anywhere doon. Tapos pag meron, kunwari, arresting heart somewhere in mail ward, takbo kayo doon, kahit saan lupalop ka sa ospital, pag code blue team ka, re-responde ka doon. The scope is 2020 protocol with interim guidelines of 2022. Mag-ECG reading tayo, which is a separate slide. Then we go into pharmacology, airway, IO. Hindi na ako magtuturo ng IV. Lahat familiar sa IV. Ang ituturo ko, intraosseous. Then we go into defibrillators, cardioversion, end-tidal carbon dioxide, tapos spacing, and then how do we do the megacode. Hypothermia, ituturo ko rin. Tapos a lecture on ACS and CVA but not in-depth kasi under sila sa, kinukuha din sila ng advanced medical life support. Although sa atin, meron siyang topic sa ACLS handbook. But more on interventional tayo, yung mga initial drugs na ibibigay natin. Pero pag nasolve ng CCO, bibitawan na natin yan kasi that's advanced medical life support. ACLS is the cornerstone of all advanced life support. Pag magaling ka sa ACLS, medyo kuhang-kuha mo na yung ibang advanced life support programs. Now, the 10 core ACLS cases, number 1 is respiratory emergency. Tapos ano yung mga cardiac arrest rhythms, no? Yung ventricular fibrillation, pulseless ventricular tachycardia, yung PIA, yung pulseless electrical activity asystole. Tapos yung mga pre-arrest mo, yung brady arrhythmia, yung tachyarrhythmia, tapos ACS, tapos stroke. So ito yung 4 lang na umiikot sa ACLS program. Now we are here in the in-hospital. So dito tayo ngayon papasok. Simula sa BLS primary, tatapusin natin hanggang dito. No? I mean dito. Before we will push through with the program, binabalik ko lang kayo in understanding yung tinatawag na class of recommendation, yung COR. Ito yung meta-analysis ng mga drugs and interventions ginagamit sa ACLS. So pag nagbasa ka ng libro, magugulat ka, halimbawa, performing compression. Ilalagay doon sa compression class 1. Ibig sabihin, benefit is 3 times the risk. So ibibigay talaga natin, recommended talaga yan. Pag sinabing epinephrine, when you give epinephrine, that goes into class 2A. So moderate yun, binibigay pa rin natin, pero 2A siya. Defibrillation is 2A. So lahat ng intervention mo, 2A. Tapos ngayong taon, ngayong 2020, dinagdagan ng LOE or level of evidence. Level A ba siya? Pag sinabi kong level A, siya ba yung highly, yung evidence niya mataas, no? Ang dinaanan ng mga randomized trial, no? Grabe, no? Then we have the level B randomized, no? And then level B na non-randomized, tapos itong LD, limited data tayo. Tapos level C, expert opinion. Halimbawa sa COVID, saan si ivermectin? So maraming nakikipag-away kay ivermectin. And I'm so sad, even doctors are, shouting across the internet the effectivity of ivermectin. Una, hindi po ako naniniwala kung sino sila kasi first and foremost, wala po tayong laboratory to do that. Kaya kung sinong nagmamagaling-magalingan mga doktor at saka mga kongresista, no, our country is really funny. We have lots of clowns. We destroy the essence of science. No? Kailangan po sa gamot, taon po ang binibilang. Magme-meta-analysis ka po. Hindi ka pwedeng hindi ka mag-meta-analysis kasi we will just be people of opinion. Kaya mababa ang tingin sa Pilipino eh. Kasi over the internet, we appear to be geniuses, we don't have gadgets. Totoo yan. Ito to be honest with you. Kahit gaano kagaling na doktor, pag wala kang gamit, may iiwan ka talaga ng doktor na magaling na may gamit. Huwag natin i-excuse yung, magaling ako sa clinical, di ko kailangan gamit. No, that's not the solution. The solution is, magaling akong doktor na marami akong gamit. Malayo ang sisirit mo. Iiwanan ka. Dapat ganun ang ating konsepto because sa larangan ng siyensya ng medisina, we have to have equipment because we are 50-50%. 50-50 ang ating configuration. 50% ang talino ko, ang lakas ko sa pagiging doktor, 50% gamit. Isipin mo ngayon, meron kang patient na nag-stroke. Tapos wala kang kakayanan na mag-therapeutic hypothermia. Tapos ako may gamit. Meron akong ECMO, extracorporeal membrane oxygenation, ikaw wala. Ay talo kita. Mamamatayan ka pa. Ako, buhay. May ECMO ako eh. Yun yung point. We have to be technologically dependent because that's medicine. Iba yung meron kang MRI, may CT scan ka, may contrast study ka. Tingnan mo ngayon ako, meron ako sa ibaba. Meron akong portable ultrasound. See? Kayo, nag-stethoscope kayo, ako in-ultrasound ko. Kung mag-insert ako ng pericardiosynthesis, kuhang-kuha ko. Kesa sa tansya-tansya. Mag-central line, tansya-tansyain ninyo central line ninyo. Ako hindi, kasi may ultrasound ako. So lamang ako, mabilis ang trabaho kasi may ultrasound ako. Nandun sa sala ko, ayaw ko lang iakyat dito. Kasi ang sikip ng lugar. No? So yeah, that's the point. Hindi ko, modesty aside, hindi ko siya binabrag. But that's medicine. The stethoscope of the future is ultrasound. So I have ultrasound downstairs. That's the point there. So we have to have technology. So pag dumaan ka ng ACLS, dadaanan mo to. Kailangan alam mo to. Pag merong gamot or intervention, sinabi ko, kunwari, class 2B siya, it means to say weak ang kanyang recommendation because benefit is only slightly greater than risk. And more so when you have 3, okay? So 3, dalawa ang 3 natin, itong isang 3, saka itong 3 na hindi talaga ibibigay. For example, vasopressin. Yung vasopressin, wala na yun. Ito na yun sa class 3. Nakita, randomized, it does not exceed the efficacy, the effectivity of the epinephrine. Di out na, mahal pa si vasopressin. Parang gano'n. So yan. I will not discuss the abbreviation. Now here's your review tayo. Ito yung luma na BLS. Okay. Ito yung hindi ko ginamit yung bago. So we start with BLS primary. Tapos nag-defibrillate ako. Pag oras nagbigay na ako ng IV at magbibigay na ako ng epinephrine, diyan na magsisimula si ACLS. So ACLS, ladies and gentlemen, of the interim guidelines. So interim pag sinaming interim guidelines ng 2022, ito yung latest. Kung makita ninyo, ano ko lang, okay? So may mga ginagawa iba, para tightly sealed siya, 2 tao. Isang humahawak ng seal, isang nagbabag. Pero level 4 ang kanilang doning. Okay. Ngayon, attach ka agad sa cardiac monitor. Tapos, tingnan nyo rito, prepare to intubate. Wala pang, nagsi-CPR ka pa lang, naglalagay ka pa lang ng AED or ano, prepare to intubate na. So dito, i-discuss ko tong boxes kasi nadagdagan ko. So habang pababa tayo, kunwari sa rhythm check mo, nakita mo flatline. Pag nakakita ka ng flatline, okay, tingnan niyo ako sa ano, tingnan niyo ako sa video. Kunin ko lang yung defib ko. So yun ko siya, monitor. Okay. Nakalagay dito, nakalaki siguro. Nakalagay dito, default 2. Roman numeral 2, 2 guhit 2. Pindutin ko, naging 3. Pindutin ko, naging paddles. Ibig sabihin, yung paddles niya, nakaka-detect yun. Ito. Nakaka-detect to. Okay? Tapos, pindot ko ulit. Limb lead 1. Limb bleed. No? Limb bleed. Kasi dalawa kasi ang ECG leads. Eh. The limb leads and the chest leads. Kaya 12 leads. 6 limb leads, 6 chest leads. Ngayon, kunwari sa lead 2, which is your default, nakakita kayo ng flatline. Pagkita nyo ng flatline, huwag kagad kayo asystole. Lalo na pag nakita kayo ng flatline na malinis, naku, nakadetach yun ha. Ibig sabihin, baka may na-detach na lead. Ang flatline is detached lead yan. Kung wala siyang flatline, detached. Pag nagkirig-kirig yan, ano ba sa Tagalog kirig-kirig? Yung parang artifacts yan, defective leads yun. Or ang pasyente gumagalaw. So, yan yung mga parameters sa cardiac monitor. So, pag nakita ka sa 2 flatline, punta ka sa 3. Kunwari, leads no intact. Flatline pa rin, punta ka sa paddles, lukso ka. Kasi hindi naman nakalagay yung paddles. Pero kung naka-automated mode 2 na nakalagay yung pads, pag pindot mo sa pads, flatline pa rin, pindot ka balik sa 1 flatline, balik ka sa 2 flatline, saka ka mag-declare that the patient has asystole. Huwag kang mag-declare ng asystole using 1 lead. Yan lang yung pagkakaiba sa when you look at dito sa asystole or PEA. I will mention what pagdating na sa issue. Tapos CPR ka kasi dito makikita mo sa box nito, no? Push hard, push fast at 2.4 inches and 120 max 100 to 120. Tapos avoid allow chest recoil, tapos minimize interruption, avoid excessive ventilation, change compressor. Ito yung sinusunod natin. Dito, ang capnography, ma-apply natin to kapag intubated na. Now, balik ulit ako dito sa algorithm. Pause chest compression for intubation. Mabilisan to. Kailangan ready lahat sa gilid ko, which I will do a demo tomorrow. If intubation delayed, pwede kang gumamit ng supraglottic. Papakitaan ko kayo ng supraglottic airway devices. No? And then connect to a ventilator with filter when possible. So kung wala kang mandatory ventilator or any ventilator, pwede ka mag-bag valve mask. Pero pag bumili ka ng bag valve mask, bumili kayo yung merong filter, exhaust niya. Kung hindi, useless din. Ang bago ngayon po, meron siyang parang, yung sa exhaust niya, merong naka-attach doon na mga filter. Mas mahal siya, siyempre, of course. Pero napapalitan po yun. No? Now, autoclave ulit. So yun po yung bago ngayon. Medyo mahal. I think 4 times the regular. No? Then, you run CPR for 2 minutes kasi yun yung running time natin. No? So, by the time, balik ako dito sa itaas, nung nag-rhythm check ako habang nagsi-CPR, kung ang intention natin ay ACLS program, mabilisan, halos kasabay ang intubation saka sa IV line. Kaya pagdating dito, epinephrine, meron ka ng first dose ng epinephrine. Ang gamit nating epinephrine dito, hindi katulad dati 1:10,000. Ngayon, epinephrine na lang. No, dati kasi ang ginagamit namin is emergency is 1:10,000. Yung hindi namin ginagamit is 1:1,000. Ginagamit ng 1:1,000 dilution sa anaphylactic shock, mga ganun. Pag asystole, sirit ka agad. Pag BF, BT, dito pa lang ako nag-IV access. Yan. So tandaan ninyo, sa lumang panahon, nauuna si IV. Ngayon, ang inuuna si intubation. Pero dahil limited tayo tao sa loob, unahin daw muna si intubation bago mag-IV. Pero kung sakto, nasa 4 tayo, no? Nasa 4 tayo na tao, may fluid saka drug guy ka, sabay si intubation sa si IV. Bakit natin isasabay si intubation si IV? Kasi kailangan mabigay natin si epinephrine sa asystole. Kasi pag nagbigay ka ng epinephrine, ang kanyang rhythm, sabihin ko sa Tagalog, parang ipapagaspang mo. Sana makapag-produce ng fibrillation para ma-defibrillate. Kasi mas madali buhay ng tao kapag ang rhythm ay fibrillation, ventricular fibrillation, kesa sa asystole. Pag asystole na yan, pagod na yung heart. Lukso ako dito. Bigay tayo ng defibrillation, drug shock, shock tayo, shock CPR, shock CPR. Pagdating sa IV, drug shock CPR, drug shock CPR. Biphasic is 200. Monophasic is 360. Tapos yung advanced airway natin, i-demo ko na lang, hindi ko na i-discuss to. Mapansin ninyo, halos gamot lang, CPR. Gamot. Pag hindi na natin na nag-reverse sa binigay natin gamot, na exhaust natin ito tingnan yung cursor ko, itong H and T's na settle ko si hypovolemia kunwari, si hypoxia, si acidosis, si hypokalemia, si hyperkalemia, kung ano man yung existing doon at na-settle ko, pero flatline pa rin ako, titingnan ko yung capnometer, pag 10 pa rin or below 10, I have to declare the patient is dead. Okay? Ang capnometer normal is 35 to 45 millimeters of mercury. I will explain it pagdating sa airway. So itong H and T's, ito lang yung nagkukos ng cardiac arrest. Yan ang nire-reverse natin. So yan lang. So hanggang pang 3 beses ko lang mauulit sa epinephrine. CPR lang ako. Kung hindi siya kabol, wala na akong magawa. Pag siya kabol, punta ako dito. Kunwari, return ko siya kabol. Naka-intubate. So pag naka-intubate na, hindi na 30:2. Asynchronous na. 100 to 120 ang compression, ang aking pagbigay ng hangin para hindi ako mag-hyperventilate every 5 to 6 seconds. Bigay ako 1,000, 2,000. Huwag masyadong gigil sa ambiobag na dalawa kasi ang chest ng Pilipino halos 600 ml lang yan sa isang healthy. 600 cc ang healthy lungs. No? Pag sinubra mo gano'n, baka magkaroon tayo baka sumabog yung isang alveolus doon, lalo na pag weak heart yan, magkakaroon tayo ng pneumothorax. Ako, mahirap yun. So, dito, shock ako, no? Sa forma sa Pilipinas, mauna ang shock, intubate. Intubate, tapos shock. Pag intubate nang kusabay sa IV, shock tayo. Bigay ako ng epi. Tapos shock, tuloy-tuloy CPR, bigay ako ng amiodarone 300 or lidocaine 100. Tuloy pa rin. Or pwede ka dito, bigay ka ng epi, tuloy-tuloy ang CPR, shock, bigay ako ng epinephrine, walang problema. Kung gusto mo, epinephrine ka lahat, fine. Kung yun lang yung gamot mo. So, epi ka, epi, pwedeng epi, amio, or epi, lido. Okay? Maganda ang lido pag medyo stubborn, no? Makikita mo, stubborn talaga yung pulseless beta, maganda i-lido yan. So, yan ang kabuunan ng ACLS sa arresting heart. Okay? Question. So, the main 3 drugs muna is epinephrine, 1 mg per ml. Tapos, amiodarone 300. Ang second dose is 150. Lidocaine is 100 milligrams. Kasi 1 to 1.5 milligram per kilogram. Assuming meron akong 70 kilogram, sakto pa rin. Ang preparation niya is 100 milligrams. So, okay lang ibigay lahat. Tapos sila lahat ay meron kang post 20 cc NSS kapag ang IV ko or IV ko nandito. Pero kapag ang IV ko or IO ko nasa tibia IO, hindi pwede 20 cc. 40 to 50 cc of NSS push. I-demo ko yan pagdating natin tomorrow. Because I'll show you intraosseous. Yung pag sinabi intraosseous, yung dinidrill sa buto, no? Kung wala akong makitang line, usually ang ginagawa nila, mabilisan sila nag-IO or nag-jugular. Minsan naka-access ako jugular talaga. Jugular, no? Nag-access ako jugular, okay lang 'yun. Pero iba yung mag-jugular, meron naman akong IO, papakitaan ko kayo ng intraosseous tibial approach na lang. So yan ang ACLS for arresting heart. So ito 'yon, no? So ibaba. Yan. Yung sinabi ko kanina. So if no signs of return of spontaneous circulation, so if go to 10 or 11. Okay? Now, this is the interim guideline. Binanggit ko na to kanina, no? Okay. These are hindi ko na yan babasahin sa inyo. Anyway, can have my slides para makita niyo lang na ano yung pinipilit nila. Yung interim guidelines, Yun yung na-agree pero hindi pa siya kasama sa full manual, in-insert lang. And they will come up with another full-scale ACLS kasama na to. Okay? Ano ang gagawin natin sa prone patients kasi COVID, di ba? Pinapadapa natin. Okay? Prone position without an advanced airway. Attempt to place in the supine position para naman ma-CPR. Simple lang yun. So ito ang whole play of an arresting heart sa ACLS. Yan siya. The whole part of it. But this is the old. Wala dito yung pinipilit nila yung intubation. Okay, ito yung luma. Hindi pa naman luma, ang dinagdag lang nila is early intubation. So, hindi lahat ng ACLS is arresting heart. Pupunta din tayo doon sa mga pre-arrest. Okay? Anyway, sa cardiac arrest mo, goes to 2 to 2.4 inches deep. Tinatanggalin sila yung 2.4 kasi you cannot really ascertain how deep. Tapos 100 to 120, minimize interruption in compression, avoid excessive ventilation, so on and so forth. First 3 drugs is epinephrine, tapos amiodarone. Pwede pag nabuhay na yung pasyente, ROSC na, pwede mo i-drip si lidocaine. O nagamit mo yung tatlo. Okay. Assuming meron akong ROSC, return of spontaneous circulation, alalayan natin pulse and blood pressure, depende kung ano, pwede pa tayo magbigay ng vasopressors. Kailangan yung hemodynamics niya mataas. No? Kung naka-central line tayo, arterial pressure waves with intra-arterial monitoring, kung pwede naman, although hindi na natin ito inaano sa ACLS, kasi sa AMLS na yun. So these are the reversible causes which we will discuss by and by. Okay, so balik tayo sa BLS primary. Shock, CPR, tapos nagbigay na ako ng nag-prepare na ako ng airway pero nakauna si IV, walang problema yon, no? Kasi it's not easy to ano. Ngayon in case hindi successful yung first pass maneuver mo, pwede kang mag-supraglottic. These are some although dapat sa BLS slide no? The AED in the market no. Ngayon, let's go into tachyarrhythmia. Ito yung abnormal heart beat na kung saan lumalampas ang beat niya into 150 up. Minsan mababot ng 180. You don't like the patient to have that kind of heart rate because the patient will have his last 20 minutes of his life. Mapapagod yan because of metabolites, no? Mauubos din yan. Para lang din yung skeletal muscle. Para siyang mauubusan din yan. No? Nagsirit-sirit siya mag-beat. So, for example, may SBT ka, supraventricular tachycardia, pabayaan mo yan. Hindi tatagal ang tao dyan. Max 20 yan, 20 minutes. Papagod siya. Okay? Lalo na pag hindi na-reverse into MSI. So, ano ang ginagawa natin? So, number 1, once the patient comes in with a heart rate like crazy, of assuming 180, or maybe AF with RVR, rapid ventricular response, i-check natin 150 per minute tachy to ano muna to 3 to 4 liters. Tapos start ka na IV. Then hook to monitor, perform ECG, take initial blood count. Yung usual triaging ninyo sa hospital. Titingnan mo ngayon, other than the vital signs, kung merong presence ng HASIA. May presence by hypotension, meaning meron pa siyang BP na below 90. Meron pang acute mental altered mental status. Altered, no? Altered mental status, ibig sabihin, hindi oriented into force spheres, dalawa lang, or somehow responsive only to painful stimuli. Tapos ang kulay ng skin, pallid ang lips to bluish, or kasi may signs of shock, or the relative says, or the patient can still express may nakadagan sa dibdib, or known siya na meron siyang acute heart failure, no? Sinabi niya, recently I was diagnosed a week ago, acute heart failure. So, and or. Pag meron dyan, prepare ninyo ang patient for cardioversion. So, ano ang cardioversion? I-discuss ko yan tomorrow, paano ginagawa ang cardioversion. So, kailangan mong patulugin ako. Ang ginagamit ko is midasulam lang. Pag natulog, isusyak ko yung dibdib, cardiovert. Mas mababa ang joules niya. Yes, so defibrillation. Pero nakasynchronize siya sa R wave of the ECG. And then, sedate, tapos titingnan ko, ilalaro ko, pag nasa gug, minsan nagpa-flatline, tapos biglang mag-NSR. Pag NSR, biglang babalik ulit. Pagbalik niya, huwag mo siyang isyak. Pwede ka magbigay ulit ng adenosine. Kung naka-initial ka ng adenosine 6 mg, pwede ka na mag-12 ngayon. Kung wala kang adenosine, dahil mahal po si adenosine. Tapos nakakainis pagamitin dahil kailangan mabilis mo siyang i-drive. Pag-drive mo ng adenosine, tulakan mo kagad ng NSS, within 3 seconds, nasa heart. Kasi pag bagal-bagal mo siya, pinapatay mo siya ng enzymes ng red blood cell. Mahal na, masalim mo pa ibigay, kailangan naka 3-way stop pa. Pangatlo, mahal na, hindi matagal sa shelf life. Mabilis ang kanyang expiration. Tapos kailangan medyo cool ang environment. Now, hindi ganong maliwanag na araw, hindi siya nasusikatan ng araw. So nakatago. So masalimuot, mahal na high maintenance pala. So kung nakita natin may presence of ASIA, yes, deck for cardioversion. Wala namang hasiya. Walang hypotension and or altered mental status and or size of shock and or ischemic chest discomfort and or acute heart failure. Titingnan natin ano yung QRS, wide or narrow. So, kailan wide ang QRS? Okay, i-discuss ko yan pag ECG natin by and by. Pag wide siya, QRS mo, wide, yes, no? Adenosine pa rin. Dati si adenosine hindi binibigay dyan. Ang binibigay natin amiodarone. O, kita nyo ngayon, dati in the recent past, 2015, amiodarone. Before 2015, amiodarone for narrow and wide. Ngayon, pinalitan na adenosine na naman. No? Yan ang medicine, paling-paling tayo, depende sa mga, sa meta-analysis na ginagawa. Then, assuming narrow QRS siya, then we can ascertain sige, subukan natin mag-vagal maneuver. Pero bago kayo mag-vagal maneuver, guys, yung stethoscope ninyo, kung wala kayong ultrasound, yung stethoscope ninyo, balik ta rin yung gamitin yung bell. Pakinggan nyo muna yung carotid. Huwag kayong mag-vagal maneuver na hindi nyo napakinggan ang carotid kasi baka merong aneurysm dyan at kinalkal nyo yan. Pag sumabog yan, naku, walang magaling na doktor dyan. Okay? So, pakinggan nyo. Ang mapapakinggan nyo sa normal na is parang heart rate. Pag merong aneurysm yan, iba ang sound. Meron siyang awas. Lipat ka sa kabila. Gumaganon. Matakot ka dito. Ibig sabihin, may aneurysm. Dito ka. Dito ka mag-massage. Pakita mo mag-massage, bumabagal ang ECG. It is like diagnostic that the patient has PSVT or paroxysmal supraventricular tachycardia. Yan. Then you can give like a calcium channel blocker like verapamil. Ako, marami ako nabigay na verapamil kaysa sa adenosine kasi although ngayon sa kit ko, ayan, may adenosine ngayon. Pero hindi siya tatagal. Expire na yun ngayong August. Naghahanap na naman ako kung sino mag-donate sa akin. Pero karamihan SBT na treat ko, chemically, kung hindi ko na cardiovert, ay gumagana naman sa verapamil. Yung, if you have heard of si Mr. Lopez, Oscar M. Lopez, siya yung may-ari ng buong Lopez Group, no? Isa sa pinakamayaman sa buong Pilipinas yun. Doktor niya po ako, mahilig yan umakyat sa bundok. Nag-SBT yan, 2021 nag-SBT siya. Sakto ako yung duty, na-reverse ko yung na-reverse ko yung SBT. Ang ginamit ko lang is Verapamil. Wala akong mahanap na adenosine. Dalawa na lang ang gamot ko. Dalawang amiodarone, isang Verapamil. Pag nag-stubborn siya, i-drip ko siya ng amio. Kasi wala na akong choice eh. Bago dalhin sa ospital. Merong sarili kaming parang ICU doon sa bahay niya. So buti nag-reverse na mga katuwa. Verapamil, naka-reverse ako ng... Although marami lang beses ako naka-reverse. Mas marami akong na-reverse ng Verapamil kaysa sa adenosine. I mean, the usage. Adenosine is very good. It's a wonder drug. Believe me. When you give it SBT, tapos pagbigay mo, magpa-flatline. Yung pasyente na nanonood sa'yo, nakatingin lang sa'yo. No, flatline. Flatline siya, maya-maya. Balik na yung rhythm niya. Pwedeng bibilis ulit, or pwedeng balik na. Okay? So, yan po ang ating tachyarrhythmia. The next slide, ayan ang gamot. Kung gusto mo i-defibrillate siya, i-cardioverge siya. Pag narrow regular, you can start even as low as 50 joules, 200 joules. Sabay basic ha. Pag narrow irregular, no, you can do 120 to 200. Usually, ang mga defibrillator na manual, pag i-on mo siya, nag-start talaga siya sa 120 as a default yung joules niya, default niya 120. Pero pag wide regular, 100 ka, wide siya, no? Ibig sabihin, hindi siya supraventricular in origin. Ano na siya? Ventricular in origin na kasi wide. Pero may pulso pa to Hindi to yung pulseless, feedback. Wide siya. You can start at 100 joules. Pag wide irregular, no din. Defibrillate. Adenosine, ang first dose mo is 6 milligrams. Second dose mo is 2 vial na maliliit, 12 yun. Then you can even jack up into giving procainamide. Pero ang procainamide ko, third level yan. So mga second level ko, procainamide ko, third or fourth level yan. Adenosine, tapos amiodarone, 150 ako. Tapos sa talol, 100 milligrams, no? Over 5 minutes. And procainamide. Sakit, pag may procainamide ka, sakit. Parang, wow, gaganon. Alam mo minsan, pag nakita-kita yung mga field hospital, field doctors or mga paramedic, can I see your drug kit? Meron ka mga fentanyl, morphine, tapos hanggang procainamide yung kakayanan mo. Makita nila, wow, talagang sustenance ka. Kasi bago ako nag-procainamide, marami na akong ginawa. Ibig sabihin, pinaghandaan ko yung sustained ang pasyente na sa akin for the next 4 hours, 3 to 4 hours. So yun ang gamot niya. Now, let's go into bradyarrhythmia. Yung bradyarrhythmia, ito naman yung mababa na below 50 ka, pero wendang yung beating niya. Hindi lang siya bradycardia, pero nagka-abnormal beat, most likely because of heart block or AV block. So dumating ang pasyente sa'yo, nang nag-pulse ox ka, hirap basahin, parang mababa ang tapos nahilong-talilong siya. Pinahiga mo, nagbigay ka ng kanula, tapos cardiac monitor, nakita mo, kunwari second degree, type 2, ganun, type 2. Tapos, tingnan mo ngayon kung may hypotension, kunwari BP niya, 95 systolic, so okay lang. Wala namang, slightly may altered mental status, medyo takot ka na, no? Ano kayang gawin ko dito? Merong sides of shock kasi namumutla na yung lips. Tapos, ischemic chest discomfort, sabihin natin, wala. Acute heart failure, wala. Then you can start giving IV. So, IV ka kaagad. Tapos, atropine ka agad ng 1 mg. Dati kasi 0.5. Nung unang panahon na ang atropine pwedeng ibigay sa asystole. Ngayon, hindi na. Ang atropine hindi na pwedeng ibigay sa asystole. Tapos, binibigay natin sa bradyarrhythmia, starting 1 mg na 1 minute. Nasa katulad ko, may dapat pacer ka. I will discuss to you how to do a transcutaneous pacer. Sa ER ka, gusto niyong gamitin yung transvenous pacer niyo, nasa inyo yan, inyong decision yan. Kung meron kayong transvenous pacer. So, you can call cardiologist, no? So, wala tayong halos gawin dito kundi drug tapos pacing. So, habang nagpe-pace ka, kung maganda yung capture, meron tayong mechanical capture, tapos lalo mga pacer ngayon may sensitivity pag nag-pace exactly yung heart on a certain millivoltage, kusang namamatay siya. Kaya napakaganda ng pacer. Itong pacer na ginagamit ko dito, hindi ko alam kung ano. Wala kasi akong pacer line, pero may pacer ko. Return to spontaneous circulation, huwag muna kayo maging masaya. Lalo na kapag ang pasyente ay hindi umaakyat ng 90 systolic. Kulang pa ang hemodynamics. You can have IV bolus or mag-infuse ka ng lidocaine or mag-infuse ka ng any vasopressor. Okay? Kung ang dahilan noon nag-arrest siya STEMI, then cut lab siya. Baka bumalik pa, no? Or nangyari sa akin, MI ako, nagbigay ako ng streptokinase 1.5 million international unit IU, natanggal yung bara, nag-arrest yung pasyente, na-defibrillate ko, bumalik naman kaagad. Wala ko ganong drama except na minonitor ko lang siya kasi wala na nagbumalik kaagad siya. Ang ginawa ko, pag-arrest niya, hindi ako naka-CPR kaagad kasi nasa machine ako. Dinefibrillate ko lang kasi biglang nag-fibrillate ang heart. Nagulantang sa pagtanggal ng bara. Nagulat siya. Nag-fibrillate siya. Dinefibrillate ko. Yun yung medyo violation doon sa chain of survival na ginawa ko. So, depende yan. Sa case-to-case basis kung paano nyo i-perform yung mga algorithm. When you are doing some resus, yan, avoid excessive ventilation, tapos 10 breaths per minute, no, ibig sabihin, 1:6, 1 blow into 6 seconds. Kailangan, kung naka-intubate siya, nasa 35 to 45 millimeters of mercury, yung aking carbon dioxide, to ascertain na buhay ang mga cells ko. So bakit laging naka-emphasize sa 2020 ang capnometer? Kasi diyan mo makikita kung kailangan mo pabuhayin ang tao. What do I mean by capnometer? Tandaan niyo to, ang tao kapag wala nang ang cell pagpatay na, wala na siyang metabolism. Di ba napansin niyo na ang powerhouse ng cell ay mitochondria. Ang kinakain ng mitochondria ay tatlo. Oxygen 21%, water, and then glucose, CHO. So pagdating doon, para doon sa Krebs cycle to produce your adenosine triphosphate for the production of energy. Mag-attach, no, may carboxylation process, mag-attach si carbon doon, element doon sa oxygen, maglalabas siya carbon dioxide. Si water pa rin. Bakit kaya water pa rin? Para magamit natin sa waste elimination. At yung byproduct naman ng glucose will be measured in terms of calorie sa heat, no? So ganun day in, day out. Ngayon, nag-arrest ka, tapos long standing arrest na. Nang na-intubate kita, tapos nag-capnometer ako, 10 pa rin, hindi maangat. Ibig sabihin, yung mga cells ng katawan ko, hindi na siya nagtatrabaho, wala na. Wala nang metabolism. So bakit pa ako mag-waste? No? So I have to terminate kasi wala na siya pag-asa despite ng drug shock. So yun yung parameter. To know that the cells, kasi kailangan magsabi natin, kung patay ng tao, it should be on the cellular level. Hindi yung mata-mata. Sa atin, mata-mata tayo. Sisilipin yung pupils, ilawan, titingnan kung dilated. Pero sa American Association, hindi yan ang recommended. IV bolus ka, no? It's either NSS or LR. Sa isang mabilis na pagbigay ng pinapalamig niya ang tao, no? Parang i-ice kanya. lalo na stroke, yan yung tinatawag na therapeutic hypothermia or yung inducing hypothermia. Naging class 3 siya, kaya hindi na siya ngayon popular sa market, kaya na class 3 siya. You can infuse epinephrine, although I'm not a fan, 2 to 10 microgram per minute. Dopamine, dito ako fan, 5 to 20. So we will discuss about these drugs doon na sa pharmacology. So makikita natin kailan binabagamit si dopamine, si epi, si nor-E. Then we go into stroke. In ACLS, ang stroke management starts with the ambulance. So doon pa lang sa ambulance, sa EMS or Emergency Medical Services, meron ng ginagawa. Bigay ka ng O2, perform ka ng Cincinnati Pre-Hospital Stroke Scale, kuha ka ng glucometer RBS, tapos kuha ka ng history kung kailan nag-start yung yung stroke, panghihina niya, yung kinuha mo dito sa Cincinnati. Tapos you call the target hospital para ma-activate ang stroke team. Okay? Pagdating sa ER, asing sa ER, kakain na siya ng 10 minutes. Yung 10 minutes sa ER, mahuhulog, kukuha siya ng ABC, oxygen, obtain IV access, check glucose ulit, obtain 12 lead, tapos perform neurology until 3 hours. Why do we have to strictly follow the 45 to 1 hour, lalo na 1 hour? Because we want to save the brain. So yan yung essence dito kapag bara. Dito naman, sumabog naman yung vessel. So ito, neurosurgeons dito. No? And then ito yung mga, kung ano ang mga consideration natin gagawin sa kanya. Lahat naman yan, mahulog yan sa ICU. Okay. Now, kapag may ACS naman tayo, acute coronary syndrome, again, sa ambulance, MONA. Ano yung sabihin ng MONA? Morphine, oxygen, nitroglycerin, aspirin. So yung aspirin natin, 3 to 5 ideally, sa pharmacology ito i-discuss natin. So tayo dito sa Pilipinas, wala tayong morphine sa loob ng ambulansya. Unless ako, meron ako morphine dyan. Tapos kitang-kita ko MI. Ayaw ko lang magbigay ng morphine kapag inferior wall makita ko kasi mahirap habulin ang pag-shoot down ng BP. Bagsak talaga BP niya. So pagdating sa ED, pansinin natin, time frame din siya. Within less than 10 minutes, dapat nasa ER. Sa ER, ipe-perform to lahat. It's either dadaan sa ER or diretso sa cath lab. Tingnan natin anong mangyari. ST elevation versus unstable angina or non-ST. Tapos yung low to intermediate risk ACS na hindi natin alam kung meron o wala. Dito tayo sa STEMI. Huwag niyong i-delay ang reperfusion. Ang ating time frame sa tinatawag nating door to needle fibrinolysis dapat masunod dito. Within less than 12 hours from the time of onset of symptoms, yan yung hinihingi ng hospital. Kailangan makuha natin yung reperfusion goals. Okay? Ma-PCI natin siya. Ganun dapat kabilis. Okay? Pero sa kabagalan, dahil Pilipinas, more than 12 hours, dapat marami pa ang ipe-perform natin. Kukuha pa tayo mga drop eye, no? Tapos check for recurrent or persistent ST. Although ginagawa natin, marami pa siyang dadaanan kasi more than 12 hours. We can also start giving medicines katulad ng low molecular weight heparin and so on and so forth. Dito naman sa kabila, puro observation lang. Hanggang mapunta tayo dito sa NSTEMI algorithm. So ano yung emphasis ng 2020? High quality CPR, BLS primary. Tapos kailangan AED, no? Katulad sa picture na to, itong natabunan ng lady na to, nurse to eh. American talaga siya, na nasa nurse, instructor ng AHA, para sa instructorship namin. So, kaya nandiyan siya. Itong iba naman ay para mag-ACLS providers course kami, instructors course na. Now, this is your capnometry. So, ang problema sa Pilipinas, mahirapan tayo kasi mag-cross-matching pa. Hindi katulad sa ibang bansa sa emergency, lalo na sa US, meron silang O negative. O negative can be given to anyone. So, okay yung kung meron O. Usually in the higher echelon of the military, no, sa military medicine. Hypoxia, airway management lang, oxygen ka lang. Acidosis or hydrogen ion. Sa totoong buhay, dati sila nagsosodium bicarb. Class 3 po siya ngayon. Ha? Hindi siya yung mainstay. Ang mainstay natin, pagandahin lang natin ang airway management, tutuwi din ang ating, magre-resolve din ang ating acidosis. Hypoglycemia, we can give D10 or D50-50, sugar. Hypocal, IV magnesium, saka potassium chloride. Pag hyperkalemia, nako marami. No? Calcium gluconate or calcium chloride. Pwedeng sodium bicarb, oxalate, insulin glucose, salbutamol, hemodialysis. Pag-usapan natin sa pagdating sa pharma. Then dito naman T, tension pneumothorax, gagamit ka ng ARS needle, no? Needle decompression, tamponade, mag-pericardiocentesis, i-demo ko lahat yan. Toxins, bigay ka ng antidote. Kung sa ahas, antivenin. The problem with this is mabagal ang production ng antivenin ng RITM. May cause tayo. Thrombosis, kung pulmonary siya, fibrinolysis and embolectomy. Pero pag coronary siya, we can initially start with aspirin and wala pa sa Pilipinas, nitroglycerin. Pero sa atin, ginagamit dito yung mononitrate. So hypoxia, ang goal natin, bigay tayo ng 55 to 60 millimeters, no? Maintain. Depende yan, no? Paano para oxygen limiter, so yun yung kailangan ni natin. Ibigay blood transfusion. Okay? Initially, magbibigay tayo ng NSS kasi ang NSS ay nakapagpaangat din sa mga ng BP. Hydrogen ion, no? We can do ECMO, extracorporeal membrane oxygen. I will discuss electrocardiography on the next slide. And then ECG pagdating natin sa heart block. team dynamics natin, maximum 4. Ito kasi 6. Okay. Airway. Nagko-compress, which is katabi ng IV drugs, no? Para palitan sila. Ito naman electrical therapy. Playing coach. So siya yung nagko-command. So we get rid of this white na coach talaga nasa paano ng pasyente. Tapos itong isa kung anong usually binibigyan natin yung post sa documentation. Pero we don't encourage na mas marami tayo, lalo na pag medyo tight yung chemical. Max talaga natin is 4 lang. Kaya nang buhayin 4 ang isang arresting patient. These are all readable materials. 85 to 90% of arresting patients will show ventricular fibrillation. Treatment line is mechanical fibrillation. Siya, shockable rhythm. Tapos chemical for ventricular fibrillation. Tapos ang MC lang is 20 to 10 below. Paggamit ng BBM, 1 ventilation every 5 seconds. Okay, so yan lang, huwag niyong kalimutan sa highlight. Question, guys. Hirap pagturo ng tanghali. May tanong? Wala. So ECG, we don't treat the machine. We treat the patient. We don't treat the rhythm. Pero with rhythm dependent pa rin tayo. Pag mahina kasi ECG, wala. Goodbye my teacher, goodbye ang ACLS natin. Hindi ka na natin sa ECG. So, ang ECG, ang parang ika nga, is the cornerstone. Okay. Anyway, still 2003, pero wala namang nagbago sa ECG halos. So we should know how to somehow read ECG. So ito yung conduction system. Pero sabi ko sa inyo that the heart is a electrical organ. No? So ang kanyang starting ang iyan yung initiator is SA node. Tapos babiyay sa tingnan yung cursor ko, itong SA node to AV node, meron pong 3 linya diyan. The intrathoracic internodal tract of Bachmann, internodal tract of Turel, and internodal tract of Wenckebach. Bakit siya merong 3 doon? Kasi yan ang bumabiyahe of less than a second, around 0.12 to 0.20 to allow filling of your ventricles. Kaya meron kang spacing. Pagdating sa AV node to bundle of His, baba siya for 15. Pero dito sa left, dalawa siya. Meron siyang anterior fascicle sa posterior fascicle. Because the muscle of the left becoming by virtue of function. Kaya medyo mas marami siyang effort. Kaya baga ang default lead natin is 2 because the 2 is pointing to the apex of the heart. Kasi, kunwari ito, 1, ito yung heart. Left side to 1, 2, dito ABR, dito ABL. So it's like camera side. So si 2 nakalook talaga sa apex, which is mainly ventricular. Tinang siya, meron siyang automaticity, no? Yan yung characteristic ng heart muscle na. So magpa-fire siya ng 60 to 100. Your AV node and bundle of is 40 to 60, and your Purkinje system is 20 to 40. So anong nababasa ng ECG? Siyempre, heart rate, regularity of rhythm or irregularity, yung mga impulse conduction time intervals, tapos yung conduction pathways. Sa isang magaling na mata, nababasa niya kahit hypertrophy, pero hindi ko i-promote dito. Yung ECG originally, may stylus, mainit. Tapos yung paper namin noon, hindi katulad sa inyo ngayon, plate na eh. Sa amin na yun, strip talaga. So dadaan yung mag-move yung ECG, dadaan yung strip. So mahaba yung aming binabasa. Tapos pinuputol na lang per tawag dito, per lead. So, lead 1, 2, 3, ABR, ABL, ABF, B1, B2, B3 hanggang B6. So, pinuputol, nilalagay sa bond paper para mabasa ng exact. Down natin. Okay. Merong big box or big square, tapos small box or small square. Yan. So ito yung small square. So itong paitaas ay napakita ko kanina sa inyo. Yung paitaas na yan, ang kanyang is millivoltage, no? So ang 1 millivoltage ay merong 10 small squares pataas. Equivalent to 1 millivoltage yan. Okay? So dalawang big boxes kasi ang small box 5 pataas, 5 pa horizontal. Pag 5 naman horizontal, is equivalent to 0.04 of a second. So kakain muna siya ng 5, 0.04, 0.04, 0.04, para magkaroon ako ng 1 second. Ibig sabihin, pag tumatakbo yung strip ko, within 1 second, kakain siya ng 5 big boxes or big squares. Okay? So ano tong, tingnan niyo cursor ko. Dito, ito ang tawag nito baseline. Pag meron kang positive deflection, ang positive deflection pataas, ang negative deflection pababa. Pag umakyat katulad nitong P, umakyat. Nakikita niyo ba cursor ko? Yes or no? Cursor ko nakikita o hindi? Tahimik tong klase.
Nakikita po, sir. Nakikita po.
Kita
Yes
po,
po.
sir.
So
Okay
itong
po, okay
cursor
po.
P ko, ang tawag nito waveform. Ngayon meron na naman akong baseline. Ang tawag nito segment. So 1P tapos segment. Meron namang negative deflection which is Q, positive which is R, negative which is S, Then balik sa plateau. Then meron akong tinatawag na repolarization phase, no, kung saan pahinga ang heart. Isoelectric siya dito until panimbago na naman. Blub-blub, blub-blub, blub-blub. Ngayon, between this waveform and this segment, ang tawag nito interval. Halimbawa, PR interval. Si letter P bago si letter P, kasi simula niya, hanggang mag-start si Q, yan po yung PR interval. Baka tanungin ako, bakit tinawag na PR? Sa Q naman siya huminto. Kasi ito po si waveform Q, si R saka si S, ang tawag niyan sa tatlong nagsama-samang waveforms, ang tawag niyan complex. Sa complex nila, the most influential is R, kaya gagamitin natin si R. Ang tawag diyan ay dinosaurian principle. Ano ang dinosaurian principle? Kung sino yung pinakamalaki na fierce, yan yung sundin. Parang dinosaurian po yan. So, tingnan natin gaano kalayo to. Ang PR interval, tingin sa akin ha, it should not exceed 20. Kasi pag lumampas ng 20 yan, first degree heart block yan. Ibig sabihin, ang small squares dito maglalaro into 12 hanggang 5. 12 small squares to 20 small squares. Okay? So, ibig sabihin, ang small squares ko, 3 hanggang 5. Pag QRS naman, ang small squares ko dapat hindi lalampas ng 3. Meaning, hindi lalampas ng 0.12 of a second. Kasi pag lumampas siya, wide QRS na tawag. Nakakasunod pa ba sa ECG? O yung iba, ano na? That's the safest thing, simplest thing I can expound it. Hindi, walang salita. Kaya. Okay, so dito, hindi tayo gano'n sa millivoltage unless ulit. Okay, ulitin ko. Yung ECG machine, dito muna ako sa kabila. Itong course. May strip siya. May big square or big box which has 25 small boxes. Tapos may small box, ito siya. Ito, small box. Ayan. Okay. Horizontally, minimeasure natin yan. Katulad ng big square, minimeasure natin at 0.2 second, 0.20. 0.20, okay? Measure natin. So sa isang segundo, less than of that, sa 0.20, tumakbo yung ECG strip ko. Tumama sa hindi cursor. Stylus. At 0.20 second. Sa isang pitik ng segundo, uubos siya ng 5. Okay, bibilangin ko yung 5 big square. 1, 2, 3, 4, 5. 0.20, 0.40, 0.60, 0.81. So, 1 second, ganyan kabilis siya. Tik, 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 tik. Ganun kabilis. No? Kunwari, tik. Pinabalik-balik ko lang kasi hindi ko pwedeng i-elongate. So, ganun kabilis ang travel niya. Kaya nare-reflect doon ang ECGs according to travel. And that is how ECG works around the world. So, standard niya yan. Ngayon, i-breakdown ko pa yung big square na 0.20 into 5 small squares horizontally. Therefore, si 0.20 divided by 5 is 0.04. 0.04, 0.04, 0.04, 0.04, 0.04 times 5 is 0.2. Okay, tandaan natin. Pero pag nagbasa tayo ng ECG, karamihan ginagamit natin ay small squares. Ngayon, PR interval. Ang saktong PR interval ay dapat 3 small squares to 5 small squares. Pag lumampas ka na dyan, heart block na yon. Yan. Si QRS, dapat 3 small squares lang. Pag lumampas ka dyan, ang tawag doon, wide QRS. So si PR interval, from 3 small squares to 5 small squares. Si QRS complex, maximum 3 small squares lang. Ganun lang ang isipin niyo. Huwag na kayo mag-isip ng iba. Diyan lang naman ako mag-emphasize. Hindi ko na ipapameasure sa inyo gano'ng kataas si ST elevation. Okay? ST elevation is ST elevation on our level sa ACLS. Hindi na tayo pang cardiologist. Ngayon, lukso tayo dito. So, SA node, nag-fire si SA node, primary pacemaker, nagbitaw ka ng first heartbeat, which is the contraction of your auricles or atria. Tapos, may spacing. PR interval mo, simula dito hanggang dito, which is 3 to 4 small square. Pagkatapos niyan, QRS complex na dapat less than 0.12 ang lawak or hindi siya lalampas ng 3 small squares. Pag lumampas, white complex. Then, the repolarization phase, the resting phase of your heart, bago ulit mag-fire si SA node. So how do we look at it? How do we interpret ECG? First is we look at the rate, then we look at the rhythm, then we look at the presence of P wave, meaning sinus rhythm siya, sinus fire siya. And of course, we look at the PRI, and then if the QRS is narrow or complex or parehong forma or magkaibang forma. So let's go to the heart rate. Simple lang po ang heart rate. Tingnan nyo lang aking cursor. Broad marker. Lahat ng ECG may broad mark. After 3 seconds, broad mark. After 3 seconds, broad mark. So ito ay 6 seconds. Kukuha ka lang ng 6 seconds lead. Kasi tig broad mark ay 30. 15. 1, 2, 3, 4, 5, 6, 7, 8, 12, 13, 14, 15. Pag 15 yan, 3 seconds yan. So dalawan yan is 30. 30 big squares. Or 6 seconds. Pag kumuha ka ng 6 seconds, bantayan mo lahat ng R, i-times 10 mo lang. 1, 2, 3, 4, 5, 6, 7, 8. Then that's 80, ladies and gentlemen. Yan yung ating 6-second lead. Ilan ang heart rate nito? Grabe, walang sumasagot. Itong class na to, tahimik eh. May ibang class. Kanya-kanyang culture sa klase, no? Yung ibang klase, grabe, aggressive. Ito naman, puro Charlie Chaplin. Okay? So, paulit lang. Okay, ganito. Kukuha ka ng strip. Ang tawag 6-second strip. Ang 6 second ay kunin nyo lang yung marker o tingnan nyo cursor ko. May makita kayong marker. May makita kayong marker. So 1, 2, 3, 6 seconds po yan. Kasi yung isang broad marker to another marker, 3 seconds po yun. Dagdagan ko lang ng isa, 6 seconds. Ngayon, nag-run ka ng ECG, kunwari lead 2. Within the 6-second lead, bilangin mo lang yung R. I-times 10 mo, yan ang heart rate mo. Hindi tayo nagdi-division method dito. 300, 150, 100. Yan, hindi. 6 second. Para makabasa ng sakto. Kasi pag meron kang irregular rhythm like your atrial fibrillation, hindi nababasa ng division method. So ito, bilangin ko lang 10, di 100. So 100 beats per minute. Naintindihan? Bakit 60? 6 ba? Ayan, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Kung hindi kayo nakakaintindi, i-Chinese ko, si, nang, sa, si, ko, la, si, pe, kau, chap. Yan. Ininsi ko na. Wahid, i-Arabic ko, wahid, it means talata, arba, kamsa. So, times 10 mo, di 100. Okay. So, tapos na tayo sa heart rate, ha? Wala na magtanong sa heart rate. Ang tanong na naman. Okay. So, lukso tayo sa rhythm. Sa rhythm naman, tingnan nyo lang yung layo ng R to R. Okay, tingnan nyo to ha. Itong R dito hanggang R dito. Tingnan nyo ang layo, ikumpara nyo rito. May nagbago ba or equidistant to each other? Pakisagot. Is it equidistant to each other, ang R to R? Pareho ba ang distansya ng R to R? Yes or no? Okay. Galing.
Yes po.
So, hindi kailangan rocket science, ha? Pambihira naman. Tanong ko, napakasimple. Ang tawag dyan, regular rhythm. Kahit taki yan, kahit brady yan, regular rhythm. Ha? Tandaan nyo. Pero, dito medyo may pre-atrial contraction kung lumapit siya, tapos sakto ulit ang bilang, lumapit siya, sakto ulit yung bilang, aba, yan ang tawag na irregular rhythm. Or, meron naman, biglang humaba, merong drop, humaba siya, tapos balik ulit normal, tapos humaba na naman, yan yung irregular rhythm. Okay? So, hindi ko na discuss ang rhythm kasi merong mainly dalawang rhythm. Regular rhythm saka irregular rhythm. Merong irregular rhythm saka merong regularly irregular rhythm. Okay? So may ganon. Now, lukso tayo sa presence of P wave. So pag presence of P wave, kailangan merong P. Halimbawa ito. Ang heart rate nito, heart rate 100. What's the rhythm, regular rhythm? Is there P wave? Ayan o, P, Q, R, S, T. So merong presence, ang tawag nito sinus rhythm. Eh dahil within 100, sakto pa rin ang bilang, normal sinus rhythm. So titinan ko pa PR interval, sakto. Within normal limits, QRS, hindi wide. So that is NSR. So P wave, may makita ba tayong P wave for each QRS? Okay? Then PR interval, yung sinabi ko kanina, 0.12 or 3 small squares hanggang 5 small squares. Lumampas yan, first degree heart block. Pag less than dyan, Wolff Parkinson-White syndrome, early take-off. Huwag natin pag-usapan, si WPW, ayaw ko nang lituhin yung utak niyo. Doon lang ako sa mahaba. Kasi bihira kayo makakita ng Wolff Parkinson-White or ng early take-off. Yung mga early take-off na less than 12, akyat ka agad, walang feeling sa ventricle sakto, yan yung mga may drug addict, no? Or kung anong mga aberrancies sa heart. Usually maganda yan sa WPW. So, sa QRS naman, no more than 3 small squares or 0.12. Pag more than, ang tawag doon, wide QRS. Okay. Ito. Pag nakita ganyan, very sharp, oh, hindi rounded sharp, pero normal ang distance nito. Guys, that is an artifact. May sira ang ECG machine ninyo or yung electrodes niya. Hindi maganda. Nung panahon ko pa, may grounding kami. Mag-ECG ako sa pasyente, merong alligator clip, ididikit ko pa sa bintana na bakal. Sa inyo ngayon, napakaswerte ninyo. Modern. Ay, sorry. Swerte ko pala. Kasi wala kayong naranasan sa naranasan ko. Puro kayo moderno. Hindi nyo naranasan magbasa ng librong sangkatutak kasi wala kaming mga iPad na yun ang basahin. We literally have to carry big bulks of books. I love my generation, sorry to say, because I was there in transition. Hanggang ngayon, books pa rin ako, although meron akong iPad. But I had books. And I'm happy I have books. It defines my library din. Kasi pag sumisilip ako sa bahay, pag nakita ako ng libro sa kasing libro, alam ko kung anong klaseng tao nasa loob ng bahay. Very particular talaga ako sa books. Anyway, let's go into types of rhythms now. Yeah, grounded. Tama. Titingnan natin kung siya ay sinus rhythm or atrial rhythm or ventricular rhythm. Okay, so let's start our ECG proper. There are 4 types of sinus rhythm. normal sinus rhythm, normal sinus arrhythmia, sinus bradycardia, sinus tachycardia. Okay, tingnan natin si normal sinus rhythm at bibilangin natin ilan siya. Okay, tingin. Sagutin niyo ako ha. Ilan ang rate sa 6-second lead? 1, 2, 3, 6 second. Ilan ang rate? Pasagot. $80, 70 to 80. Okay, sige, good. Nakita ko pa yung dulo. So 80, 70, 80, okay. Ano ang rhythm? Regular or irregular? Regular, very good. Ano siya? Sinus rhythm, atrial rhythm? Tingnan natin. Meron bang P-wave? Is there P-wave? Yeah, may P-wave. Very good. No? PR interval. Ilang small squares? Sakto ba? 3 to 5? Ano ang QRS? Wide or narrow? Pag sinabing wide, lampas 3 small squares ang lapad. So narrow. Very good. Therefore, is normal. Dito tayo sa kanila. Good. Ilan ang rate? Balik ulit sa rate. Okay. Ngayon, ano ang rhythm? Regular or irregular? Very good. Ngayon, is there P-wave? Is there P-wave? Yes. Okay. PR interval. Sakto o malawak? O mahaba? Wide. PR interval ha. PR. Letter P hanggang sa R. PR interval. Within 3 to 5 ba? Small squares? Within 3 to 5 small squares? Yes. Normal limits, QRS, narrow. This is what we call sinus tachy. May P-wave pa rin ako ha. Tandaan nyo kasi mamaya makakita na kayo ng wala ng P-wave. Okay. So sinus tachy yan kasi may P-wave pa. Ang maximum na inaabot nito is 140. Pag sinus tachy ka, mahirapan ka na mag 150. 150 may sinus tachy. Pag lumampas na ng 150 yan, hindi na yan magsa-sinus tachy. Okay, next slide. Ngayon, ito sa slide na to, balik ako dito, biglang malayo tong isa, tapos balik ulit siya. Ang tawag doon, sinus arrhythmia. So it's just normal. Lumayo lang siya konti, may delay lang to. Pero hindi siya constant. Tapos normal, regular, biglang lumayo lang konti, tapos equidistant ulit, lumayo konti, equidistant. Usually, nangyari sa mga bata, teenager. Yan. It's just okay. Ang tawag doon, sinus arrhythmia. Now, gagawa na doon na tayo sa rhythm na hindi na galing sa sinoatrial node. Galing na siya sa walls ng atrium or sa internodal tracts, but it's not anymore in the SA node. And we call them atrial dysrhythmia at tatlo meron sila. Atrial flutter, atrial fibrillation, and supraventricular tachycardia. Okay, before I will push through, it's 14:30. I'll give you 7 minutes break. Baka himatay na kayo. Uminom kayo ng tubig. Mahaba-haba pa to. Me? Kasi nagpalit lang ako ng ano, nasira yung internet, nag-mobile hotspot ako.
Yes po, Doc.
Can you hear me?
Yes po.
Yes, Doc.
Okay. Sige, kumain kayo habang nakikinig kasi mahaba yung ano pa natin. So, let's go into atrial flutter. So, ano meron ng atrial flutter? Okay. Question number 1, 6-second lead. 1, 2, 3. Ilan? 1, 2, 3, 4, 5, 6, 7, 8. 80. What is the rhythm? Equidistant to each other, that's regular rhythm. Is there P-wave? Wala pong P-wave, hindi ko alam saan si P-wave dyan. Therefore, wala akong PR interval. Diretso ako sa QRS complex. Ang QRS ko still narrow. Makikita ko ngayon ang pattern, tigta-tatlo na parang lagari. It's called the sawtooth appearance. Typical yan sa atrial flutter. Ang tawag dito 3:1, 3:1, merong 4:1. Okay? Pag nag-2:1 yan, matatakot ka na. Sirit-sirit na yan. Ngayon, is the patient okay? Yeah, still okay. Monitor lang natin. Huwag tayo magkaroon ng emboli. No? So, meron lang tayo. Pwedeng mag-clopidogrel or what. No? Hindi sa doktor. Then, the next is atrial fibrillation. Atrial fibrillation, ang kanyang firing mechanics ay hindi sa SA node katulad ng flutter, except na wherever sa walls ng atria. So, ang daming fire, kirig-kirig siya, fibrillate ang atrium. So, bibilangin ko sa 6-second lead. Tingnan niyo ang kurso ko. 1, 2, 3 seconds, another 3 seconds, 6 seconds. Bibilangin ko 1, 2, 3, 4, 5, 6, 7, 8, 9. That's 90. Regular rhythm ba? Hindi. Maiksi, biglang humaba, biglang mahaba. Maiksi ulit, mahaba. Maiksi, biglang humaba, humaba. Ito, ladies and gentlemen, ang tinatawag na irregular rhythm. The only rhythm on earth na magbibigay siya ng irregular rhythm. Wala nang iba. Kahit hindi mo makikita to, pag irregular rhythm, automatic atrial fibrillation yan. Delikado ba? Hindi pa naman. So, minimaintain natin siya dito, pwedeng aspirin or clopidogrel or what, no? Wag lang siya mag-RVR. Katulad ng atrial flutter, wag lang mag-RVR or rapid ventricular response. Doon, sirit-sirit, magtatake tayo. Yun ang bantayan natin. Ito, patient still okay. Okay? So, tingnan nyo ha. Atrial fibrillation. So, dalawa na ha. Atrial flutter, atrial fibrillation. Lukso tayo sa pangatlo. Ito, medyo the last 20 minutes of the life of the patient. Ang tawag nito SBT. What is the rate? That's more than 180, no less than 180. Equidistant to each other. No P-wave, QRS, narrow. Ito ang supraventricular tachycardia. Kailangan ma-reverse natin to because if not, sirit-sirit lang to, pabayaan natin to, maya-maya mag-arrest na to. Napapagod ang heart dito. Paroxysmal supraventricular tachycardia, atrial tachycardia, supraventricular tachycardia, the same. Okay? Sa context ng ACLS, the same siya. Yan. So, tatlong rhythm ha. Tandaan nyo, ang atrial rhythm, hindi na siya sinus rhythm, atrial flutter, atrial fibrillation, saka PSVT or SVT. Kanina, 4. Normal sinus rhythm, sinus arrhythmia, sinus brady, sinus tachy. Now let's go into ventricular rhythm. So ventricular rhythms, merong arresting rhythm, merong mga extrasystole. So they are PVC, yung mga extrasystole, BTAC, dalawang klaseng BTAC, isang monomorphic BTAC, saka polymorphic. Ang polymorphic BTAC, another name is torsades-de-poix. Tapos ventricular fibrillation, asystole, and pulseless electrical activity. So let's go into PVC. Pwedeng NSR siya, huwag niyong pansinin itong ST depression. Merong monophasic. Monomorphic, isang forma lang, isang form. Okay? So extrasystole, may PVC. Huwag lang siyang sunod-sunod. Tolerable lang siya on certain age. No? Basta from time to time, sumisipot. BTAC is like this. So 6-second lead, more than 150. Usually, minsan, monomorphic siya. Wide QRS na kasi ventricular na eh. Wide QRS na, lampas 3, ano na siya. So monomorphic yan. May pulso pa yan. Maya-maya, pulseless BTAC na yan. Yun na yung arresting heart. Shockable rhythm. Yung BTAC na maraming forma, ang tawag sa kanya is torsades-de-poix. Maliit, lumiit, lumaki, lumiit, yan. May pattern pa. Yan, no? May pattern pa siya, no? Bago maging, ano, yan. No? Ito yung typical torsade. Yan. Ventricular fibrillation, automatically, arresting heart to. So, wala nang sipa yung heart mo. Pwedeng fine, minsan coarse, magiging fine na hanggang mag-asystole na siya. 90+% of arresting heart is ventricular fibrillation. It can be coarse, initially it can be coarse, then fine. Pag matanda ka na, pagod na yung heart mo, minsan fine na yan, hindi na nagko-coarse. Tapos maiksi na lang, papunta na ng asystole. Hello? Sorry. Sorry. So, yan, no? Okay. So, asystole again. Bago kayo mag-test ng asystole, kailangan i-check niyo muna all rhythms. So, all leads pala, all leads. Na, ayan, asystole. Okay, huwag kayo mag-asystole na isang lead lang tinignan. Then, we have pulseless electrical activity. Yung pulseless electrical activity, as long as hindi siya BF, hindi siya BTAC, hindi siya asystole, kunwari meron siyang ganun-ganun lang na rhythm, pero walang pulse, pulseless electrical. Meron siyang electrical activity, pero walang hemodynamics. Okay. Saka hindi siya arresting rhythm. Pag sinabing arresting rhythm, BF, BTAC, asystole. Other than those. Kunwari, sabihin na lang natin, parang kalokohan, NSR, pero walang pulso. Ang tawag doon, pulseless electrical activity. Ang tao dito, nagka-cardiac arrest yan. Okay. Now, let's go into heart block. So there are 4 types of heart block. First degree, second degree when kebab, second degree Mobitz type 2, at saka third degree or complete heart block. Okay, balik ulit tayo sa first question. What is the rhythm? The rate 1, 2, 3, 4, 5, 6, 7. Okay, 70. What is the rhythm? Equidistant to each other, regular rhythm. Is there P wave? Ayan si P wave. Tingnan nyo, P wave, P wave, P wave, P wave. Ayan, no? QRS, narrow. PR interval, ang lampas sa 5. Lampas po sa 5 small squares. Tingnan nyo. Ang tawag po dyan is first degree heart block. Can the patient still play football? Yes, of course. No problema. Observe lang tayo dyan. Okay, naintindihan? Okay, let's go. Let's go into the second part. So, hirap-hirap na. Second degree what is the rate to tapos equidistant ulit? Okay? So, bakit ganon? O sige, saka na natin tingnan. So, irregular rhythm siya. Irregular rhythm. Ngayon, PR interval. Tingnan natin dito. PQRST. O, tingin ha. PQRST. P, aba lumayo. QRST. P, sobrang lumayo na. QRST. P, walang QRST. There is drop. No, it's a drop beat. Balik ulit. PQRST. P, lumayo. Sobrang layo. Biglang drop ulit. So, 1, 2, 3, 3:1. No? 3:1 may drop beat. There is a gradual lengthening of your PR interval until it reaches a drop beat or a sinus fire with no QRS response. Yan. So yan ha. Ang tawag dyan when kibak or Mobitz type 1. Sample. Ito 2:1. Tingnan nyo. PQRST. Lumayo si P. Lumayo. P. Wala. PQRST. P. Lumayo. Wala. QRST. PQRST. PQRST. P drop. So, ang tawag dito 4:1. Is the patient okay? Ladies and gentlemen, it is still okay. Monitor lang, baka mag-progress into type 2. Not really progress, but somehow. Si type 2, ito yung ayaw mo. Ilan ang beat niya? Balik ulit tayo sa rhythm. Sa rate. Dito nagbabrady talaga ang tao dito. 1, 2, 3, 4, 5, 50 na lang. 50 na lang siya. Irregular rhythm. Walang pattern. Ang P2, P2, P, P, P equidistant. May ilang P na walang QRS. Matatakot ka na rito. Itong pasyente na to, if you see this one, please admit. That's the candidate for pacer. Implant niyan, ipipacer na yan. Okay? Pwedeng humaba yung P with no QRS, matataranta na tayo lahat dyan. Ibig sabihin, walang sinisipa ng dugo sa system papunta sa brain and elsewhere. Okay? So, ang tawag dyan, Mobitz type 2. Dyan na magsisimula ang intervention. Admit nyo na kaagad dyan. Dalhin na yan sa CCU, Cardiac Coronary Care Unit. Coronary CCU. Okay. Then, welcome to the complete separation of the church and the state. Hindi nag-uusap. Super brady, pero equidistant. Minsan, narrow QRS. Tingnan nyo si P, ha? Tingnan nyo cursor ko. P, 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 nandito sa P si P. P, 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 P nandito sa QRS. Tapos, dito banda ang P. Si P equidistant, si R equidistant to each other. Si ventricle nagpa-function ng kanyang sarili, si auricle nagpa-function ng kanyang sarili, hindi sila nag-uusap, parang Kongreso, Senado. Biro lang. So, that's a complete heart block, ladies and gentlemen. Please admit right away ASAP because the patient will die. Di pa yan arresting. Another. Tingnan nyo, 1, 2, 3, 4, 5, 6, hindi pa ganong brady. Pero, pansinin si P. P, tingnan nyo ang cursor ko, ha? P, P, P nandito sa QRS, oh. Ulitin ko. Tingnan nyo ang cursor ko para pag nagbigay ko ng exam after this lecture of mine, naintindihan nyo. P, 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 kanya-kanya sila. Si P equidistant to each other, si QRS equidistant to each other. Ito pa malala, super brady na. Super brady na to, guys. 20 to 30 na lang. Nako, mamamatay na tao dito. Tingnan nyo si P. P, 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 equidistant, oh. Equidistant siya, oh. Kanya-kanyang trabaho, si QRS wide na kanya-kanya rin. Okay. So, ito pa, artificial pacemaker. Tandaan nyo, pag nakita kayong ganyan, ibig sabihin, merong pacemaker na naka-embed sa heart niyan. Okay. Now, exam. Mag-exam tayo. Sasagot lang kayo sa chat. Imo-monitor lang ni Ma'am Joy para naman pumasa kayo. Sagot lang kayo para makita. Tapos time frame. Pag sinabi kong stop, wala nang sasagot. Pag may sasagot, pag sinabi kong stop, hindi na pwede yun. Okay? Question. Question. Wala. Walang tanong. Oh. Ibig sabihin, ang gagaling. Okay, tuloy tayo sa exam. Sagot mabilis sa chat. Lilitaw ang mga ninyo kung sino kayo. Titingnan natin. So, i-check kung ilan ang sagot para kung sino ang ilan ang makapasa. Number 1. Oops, nasaan ba yung lecture? Ba't nawala? Oh. Okay. Okay, number 1. Ayan. $1,000. 2,000. At kung sinus rhythm ba yan, atrial rhythm or heart block. Sinus rhythm. No. Wala, sablay. Ay ano, may extra P ako. Paano naging sinus yan? May extra P, oh. May P ako na walang QRS. Paano naging sinus yan? Nako. Tumablay ka agad. Sige, bigyan ko ulit na ano. Isang chance. Another 12 seconds. 1,000, 2,000, 3,000, 4,000. That's not PBC. Ang PBC laging wide QRS. May extra systole siya. I'm not asking for irregular rhythm. I'm asking how do you read the rhythm? Ano siya? Kung heart block yan, anong klaseng heart block? 4,000, 5,000, 6,000, 7,000, 8,000, 9,000, 10,000, 11,000, 12,000. Close. Okay? Ang rhythm na to, tingnan natin. QRST, 1, 2, 3, 4, 5, 60. This is second degree type 2. Tingnan nyo. Wala akong lengthening, slow lengthening. Meron lang siyang drop beat, drop beat, drop beat, drop beat, drop beat. That's a type 2. Second degree heart block, Mobitz type 2. O ito, kadali-dali, nataan sa isang tingin. Brading-brady. Pag nag-second degree kayo, kompletohin nyo. Hindi ma-allow yung second degree lang. Second degree, anong type? Type 1, type 2. O ito, ano to? Close na yan ha. Walang nakasagot sa first ha. $1,000, $2,000, $3,000, $4,000, $6,000, $7,000, $8,000, $9,000, $10,000, $11,000, $12,000. Close! Close, 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 close na, close na. Okay, pakinote kung sino ang nasagot ng tama. Ang tamang sagot dito ay complete heart block or third degree heart block. Very good. Marami nakasagot ha. Okay, next slide. Tingnan ko ano to. Okay. Gets ko na ano yun. Atrial rhythm, sinus rhythm, ventricular rhythm, heart block, kung ano man yan. Okay? 1,000, 2,000, 3,000, 4,000, 5,000, 6,000, 7,000, 8,000, 9,000, 10,000, 11,000, 12,000, 13,000. Close. Grabe, walang nakasagot. That's not SVT. That's not even an atrial tachycardia. Very good. Lily. Close na, close na. Lily, importante, nakuha niya. That's an atrial fibrillation. Okay. Sige. Kumala na si Ma'am Joy niyo. Sila na mag-monitor. Okay, next slide. O yan. 1,000, 2,000, 3,000, 4,000, 5,000, 6,000, 10,000, 8,000, 9,000, 10,000, 1,000, 2,000, 3,000, 5,000, 6,000. Close. SBT na naman. Paano naging SBT? Di ba ang SBT is 180? Up. Paano naging 180 yan? Bilangin ko 1, 2, 3, 4, 5, 6, 7. O 7 na lang. Anong SBT? It's a normal sinus rhythm. Kung kailan normal, hindi nyo alam. NSR yan. Grabe. Next. Ito. Don't mind the ST depression. Hindi ko kayo pinapabasa ng slight ST depression. Ano to? Hindi nga ako naghihingi ng regular rhythm. Ang sinasabi ko, anong klaseng yung standard rhythm na reading? Anong klaseng ECG yan? NSR, sinus brady, sinus tachy, atrial flutter, atrial fibrillation, SVT, first degree heart block, second degree type 1, second degree type 2, third degree, asystole, PIA. Okay. 11,000, 12,000, 13,000, 14,000, 15,000. Close. The right answer there is sinus tachy. Very good. Next slide. Yan. 2 points yan. 2 points pag may makakuha dyan. Pag sinabi kong close, close na, huwag nyo nang ihabol. Close na eh. Ayan. Ano yan? Bitak ha. Ala, bitak lahat. Very sharp oh. Grabe, very sharp talaga oh. Torsan. 8,000, 9,000, 10,000, 11,000, 12,000, 13,000, 14,000, 15,000. Close. Close na. Close, 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 close. Okay. Ang tamang sagot dyan, tingnan nyo to, oh, QRS nyo. Sira yung ECG, grounded yan. Okay. Sige, close na. Next slide. Oh, ito. $1,000, $2,000, $3,000, $4,000, $5,000, $6,000, $8,000, $9,000, $10,000, $11,000, $12,000, $13,000, $14,000, $15,000. Okay, close. Okay, close, 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 close. Close na, close. Bilisan nyo kasi. Para hindi kayo abutan ng close. Atrial flutter, tama yan. Marami nakakuha. Next slide. Oh, ito, ano to? $1,000, $2,000, $3,000, $4,000, $5,000, $6,000, $7,000, $8,000, $9,000, $10,000. 11,000, 12,000, wala nakasagot. 13,000, 14,000, 15,000. Okay. Close. Close na. Okay, it's a pacer or pacemaker or artificial pacemaker. Okay. Next slide. Oh, ito. Okay, kuha ko na. Ano yan? $1,000, $2,000, $3,000, $4,000, $5,000, $6,000, $7,000, $8,000, $9,000. Oh, supraventricular tachycardia. Ang naging, it's not SVT. May P-wave, pangalawa. 180. 180 yun. Wala akong tinuro na atrial body. Ang PVC ko is wide QRS. Why I don't see wide QRS? Okay. 12,000, 13,000, 14,000, 15,000. Close. Wala na ako. That is third degree heart block. Tingnan mo si P, 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 O, P, 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 P. Yan. Third degree heart block. Next slide. 1, 2, 3. Okay. Dali lang nito. $3,000, $4,000, $5,000, $6,000, $7,000, $8,000, 10,000, 11,000, 12,000. Okay, close. Close na, close na. Wala nang sasagot. Okay. NSR. Okay. Next slide. Ito. 1,000, 2,000, 3,000, 4,000, 5,000, 6,000, 7,000. Pag sumagot kayo, kompletohin niyo. Hindi pwedeng normal. Anong normal? Normal karabaw? 6,000, 7,000, 8,000, 9,000, 10,000, 11,000, 12,000. Close. Close na. Close ko na. Yeah, no more. So, NSR yan. Marami na akong tama. Ito. Dali nito. 1,000, 2,000, 3,000, 4,000, 5,000, 6,000, 8,000, 9,000, 10,000, 11,000, 12,000, 14,000, 15,000. Close. Marami talagang sumasagot ng SBT. Yung SBT, narrow complex yun. Narrow complex siya. Oh, nakasagot BTAC. Anong klaseng BTAC? Monomorphic, polymorphic. Okay, ang tamang sagot, polymorphic BTAC or torsa di poa. Okay, may ilang nakasagot. O, bala na si Ma'am Joy mag-monitor. O, ito. Ano yan? Maraming sumasagot yan. BTAC na naman. Ang BTAC, wide QRS yun. Pag ventricular rito yung laging wide. Yan, narrow yan. $8,000, $9,000, $10,000, $11,000, $12,000, $13,000, $14,000, $15,000. Okay, close. Close na. No more. Wala nang habol. So that is PSVT, paroxysmal supraventricular tachycardia or atrial tachycardia. Pero hindi pwedeng atrial fibrillation yan. May sumagot pang fibrillation. Next. O ito. Ito. 1,000, 2,000, 3,000, 4,000, 5,000, 6,000, 7,000, 8,000, 9,000, 10,000, 1,000, 2,000, 3,000, 5,000. Close. Wala. Okay, close na. That is NSR, normal sinusoidal. Next slide. Bonus. $6,000, $7,000, $8,000, $9,000, $10,000, $1,000, $2,000, $3,000, $4,000, $5,000. Close. Close, 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 close. PIA. May sumagot ng PIA. That's not PIA, that's asystole. Next slide. O yan. $1,000, $2,000, $3,000, $4,000, $5,000, $6,000, $8,000, $9,000. Ayan, BTAC. May nagtagot pag third degree heart block. Naku, Diyos mo yan. Kagulo na yan, no? Hindi na nga yung PVC. Ang PVC, extra systole, pa ilan-ilan lang. Naku, walang nakasagot ng tama. Atrial flutter. Ano nang atrial flutter yun? White QRS. That's not grounded. Okay. Sige. Pansinin nyo to. Ito yung pagkatapos ng torsad, pero may ganyan na siya. This is a family of ventricular fibrillation course. Arresting heart na yan. Ayan pala, super irregular. Ang torsad, may mga pattern pa. Tapos pabago-bago, pero may pattern. Ito, wala ng pattern, no? Lawgaw na yan. Ventricular fibrillation na yan. Silili lang na ako, ha. Iyan pa naman ang pinakamadali. Ayan. Okay, next. Ito. Aming sumagot ng ganyan. Pia. With pulse to, ha. Okay. 10,000, 11,000, 12,000, 13,000, 14,000, 15,000. Okay, close. PVC po yan. That's a PVC. Ito yung emphasis natin. Next slide. Ito. Saglit, tingnan ko. Okay. Mahirap to, pero pero nakuha ko ano siya. Nakikita ko yung P-wave. So ano to? Sinus flutter. Walang sinus flutter, ha. Tingnan nyo ang P-wave. May QRS ba kagad o hindi? Hindi eh. Wow, galing. Meron nakakuha. 13,000, 14,000, 15,000, stop. Stop na, stop. Third degree heart block. Ito. 1,000, 2,000, 3,000, 4,000. $10,000, 11,000, 12,000, 13,000, 14,000, 15,000. Okay, 15,000. Stop, 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 stop. That is a sinus tachycardia. Next slide. Naku. Biphasic. Ano yan? Huwag niyo nang pansinin yung sinus brady, yung ine-emphasize lang na rhythm na yan. Kasi yung extrasystole, nagbubuga din yun ng dugo. So kung bibilangin ko siya, kasi bumubuga siya. Okay, monomorphic PVC. Galing ah. Stop. So it's a PVC. Okay. Okay, next. Yan. Ano to? Dalawang sagot dito. Ito. Saka ano to? Itong guhit na straight. Oh. Yung guhit na straight na yan. Nako. Ano yan? Dalawang sagot. Ito at saka ito. So ang expected ko, dalawang sagot, 2 points yan. 1,000, 2,000, 3,000, 4,000, 5,000, 6,000, 9,000, 10,000, 1,000, 2,000, 3,000, 4,000, 5,000, 6,000, 7,000, 20,000, 1,000, 2,000, 3,000, 4,000, 9,000. Okay, stop. Tingnan natin. Grounded. Resting beta. Okay. It's not AFib. That is ventricular fibrillation. Tapos ito, defibrillation. Saglit. Walang nakasagot, ha? Ventricular fibrillation yan. Tapos nag-defibrillate siya. Ay, nako. Baba. O ito. Nako, kaganda. 1,000, 2,000, 3,000, 4,000. Irregular rate yan, no? 6,000, 7,000, 10,000, 1,000, 2,000. Okay. Walang nakasagot. Ang galing. Close, 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 close. Ang sagot nito, atrial fibrillation. Okay. Next slide. Hypervoltage. Pero ano yan? Hypervoltage lang siya. Huwag niyong isiping hyperkalemic yan, ha? Kasi peak T waves naka-hypervoltage. Kasi peak ang T wave. Lampas ang ECG doon sa strip. Peak T waves naka-hypervoltage to. Ano to? Minus the hypervoltage. Ano yan? Nung SNR. Kainan yung SNR. Bilihan ng ano? $7,000, $8,000, $9,000, $10,000, $1,000, $2,000, $3,000, $4,000, $5,000. Close. Okay, ang sagot dito ay NSR. Normal sinus rhythm. Okay, next slide. Ito lang tingnan natin. Dali na to. 1,000, 2,000, 3,000, 4,000, 5,000, 6,000, 8,000, 9,000, 10,000, 1,000, 2,000, 3,000, 4,000, 5,000. Close. Okay, close na. Okay, sagot dyan, PVC. Points. Huwag na nang pansinin tong premature atrial contraction. Ito lang, oh. Ito lang. Other rhythm, huwag na to. Ito siya. Ano yan? 1,000, 2,000, 3,000, 4,000, 5,000, 6,000. Sus. Really? SBT. Parang SBT. First degree. 8,000, 9,000, 10,000, 1,000, 2,000, 3,000, 4,000, 5,000. Close. Okay. Ilan lang nakasagot? Atrial fibrillation po yan. Ito. 1,000, 2,000, 3,000, 4,000, 5,000, 6,000, 7,000, 8,000, 10,000, 1,000, 2,000, 3,000, 4,000, 5,000. Close. Sinus bradycardia. Next slide. 1,000, 2,000, 3,000, 4,000, 5,000. Balikan nyo lang yung rate, rhythm, presence of P wave, PR interval, QRS narrow. Tapos memorize nyo lang yung heart block, kuha nyo na yan. 12,000, 13,000, 14,000, 15,000, close. That's not normal sinus rhythm. Yan po ay sinus tachy. Ito. Okay. Kitang-kita. 1,000, 2,000, kitang-kita kagad. Nakita ko kagad si P-Wave. 1,000, 2,000, 3,000, 4,000, 5,000, 6,000, 7,000, 8,000, 10,000, 1,000, 2,000, 3,000, 4,000. Okay, stop. Layo ng atrial flutter. Layo ng NSR. Okay, stop. First degree AB block. Second degree type 1 pala. Second degree type 1. Tingnan nyo. PQRST. P lumayo na sa QRST. P wala. P drop. PQRST. P lumayo na. P drop. Oh. Second degree type 1 or Wenke back. Next slide. O yan. Ano yan? 1,000, 2,000, 3,000, 4,000, 5,000, 9,000, 10,000, 1,000, 2,000, 3,000. Dapat masagot niya na. Okay, stop. Paano naging ventricular? Paano naging torsad yan? Pambihira naman. Not torsad, people. Okay. Yan ay third degree heart block. Third degree yan. Oh, ito. Last slide. Nako, maraming sablay sa ECG sa inyo. 1,000, 2,000, 3,000, 4,000, 5,000. 1,000, 2,000, 3,000, 4,000, 5,000. Okay, stop. Wow. Stop, stop, stop. Isa lang nakakuha. That's a first degree AB block. QRS, PR interval, more than 5. Okay? O, bahala na si Ma'am Joy mag-compute. Okay, so our next slide, ladies and gentlemen, is about oxygen. No? Para na maintindihan natin paano ang pagbigay natin ng oxygen. And why it's the first drug. So maraming hindi nakakaintindi dito, lalo na sa emergency. Nagsi-CPR, naka-nasal cannula. I don't want you to mind the EDC cylinders kasi trabaho namin to sa pre-hospital care. Merong mga types of oxygen tanks, no? Tapos, para malaman namin ilang minutes, no? Makikita mo LPM. Tapos pag i-LPM namin, ilan ang mauubos niya in time in hours. Okay? Ganyan din to, ganyan din yan. So, it is a medicine. It contains the green gas. The green tank contains 100%. But in Dalton's law, 21% partial pressure. So, kailangan natin siya sa Krebs cycle para mabuhay tayo. We give that to almost all cases, particularly sa ating cardiac arrest, AMI, cardiac failure, shock, respiratory failure. So almost anything, no? Lalo na sa emergency, oxygen talaga yung first drug natin. And the medical oxygen must always be ordered by the doctor. So yan ang mga kailangan natin. Kailangan natin ma-familiarize ano yung first stage gauge or reduction gauge na may flow meter siya. Emergency oxygen, ang flow meter niya, mayroon ng 20 ngayon, up to 15 dapat kasi 15 liters per minute yung emergency flow rate ang ginagamit natin. So ito yung may humidifier. It's either we do it manually or free-flowing or we do it with mech vent, no, pag advanced airway. So again, nasa 15 liters per minute max ang emergency oxygen. So paano ang ating administration? So hindi natin lahat babanggitin to. Sa nasal cannula lang hanggang sa ambubag. Nasal cannula, ang 100% will be reduced to 24 to 44 lang, no? Kasayang. Kasi ang hinihinga mo, may kasamang ambient air. Yung nasa surrounding, kasi nakasuksok lang sa ilong mo. And ang ating delivery flow rate is maximum 6 or else magdadry ang ating nasal mucosa. Pag hindi naman usually pag mga chest pain, ACS, nadadaan pa natin yan sa mga 3 to 4 liters. No? So yan, no? Adult and child, yung ating nasal cannula. So ito yung ating FiO2. Okay? Sa flow rate and FiO2. So pag nag 6 liters, expected may 44. Okay, pero wala na. Ano na yan, magdadry yung mucosa. Kaya ang max natin, ang optimum, is around 4 lang. No? Around 4. Kasi pag iakyat pa natin siya, mag-dry. Although sa 4, mag-start mag-dry na yung mucosa. I will not discuss about advantages and disadvantages. I leave that to you. Now we go into the mask. The simple face mask is called the Hudson mask. Ang kanyang distribution percentage, ang delivery niya is 30 to 40% oxygen. Pwede natin siyang iakyat into 10 liters per minute. Okay? Ideally, it should be given to type 1 respiratory failure na wala siyang hypoxemia. Then we go into another mask which is very expensive. Binibigay natin sa COPD. Calibrated siya, depende sa jet na sinasaksak niya. So pag bilhin mo siya, set na siya. Merong blue jet, kailangan 2 to 4 para makapagbigay ng 24. Pag white jet, 4 to 6 liters para makapagbigay ng 28. Pag yellow jet, yan, 8 to 10. And then ang green ang pinaka grabe, no? Para makapag 60% oxygen. So pag binibili mo siya, set, hindi natin nagagamit sa emergency unless the patient is known COPD, so doon lang siya. Ayan ang forma niya, naka-yellow. So si yellow jet is 35% O2. Yung jet na yan, ito, napapalitan yan. Tanggal lang yan, palitan mo ng green, palitan mo ng blue, palitan mo ng white. Then we go into the non-rebreather mask which we use. Ito emergency, it can jack up to 90 to 92% of oxygen. 15 liters ang flow rate natin. Yung pinakita ko kanina na may dalawang valve left and right. So titingnan natin sa picture. Okay. So si non-rebreather mask, tingnan nyo, meron siyang left and right na exhaust valve. Kumpara sa partial rebreather. We don't use this one. Ito talaga ginagamit natin. Yeah. So bago tayo mag-CPR, kung wala kang bag valve mask, kasama sa non-rebreather. So ayan ang ating mga mask. Hudson mask or simple face mask, non-rebreather mask. Ito lang yung dalawa. Itong Venturi, bihira lang to. Wala nga akong ganito. Sa partial rebreather, I don't use that. So nandito lang ako sa dalawa. CPAP, we don't use that CPAP. No? Although sa pre-hospital care, may mga ventilator kami may CPAP. BPAP, mahirap yan, masalimuot pag sa pre-hospital care. Grabe na. Grabe ang kanyang not commonly used in the field. Okay? Hindi siya, So, ambubag, ito yung reservoir. Pag ikasa mo siya, 15 liters per minute, umaabot siya ng 94% oxygen habang nagre-resuscitate. Okay? So, that's all about oxygenation. Unless you have question, our next topic, para maubos lang to ngayon, is fluid and electrolytes. May question? Fluid and electrolytes, okay? So fluid and electrolytes, I will not discuss the whole part of it kasi gusto ko lang malaman ninyo na why is it that we have to give blood, maintindihan nyo when to give D50 kasi sa hypoglycemia, no, which is part of ACLS, which I will show you in a little while, by and by. We have intracellular compartment which is dominated by your cation potassium. and your intracellular and extracellular, which is subdivided into 3 sa loob ng vessel, intravascular, interstitials in between cells to, and then transcellular, yung mga in between the bones, no. Actually they create some sort of a shock absorbing mechanics, no. Tapos ang extracellular cation, sodium ang predominant. Now, why do we need to know this? Kasi first and foremost, para makuha natin saan pumupunta yung fluid na binibigay natin. Okay? First and foremost, sa lethal physics, pag sinabing osmosis, it's a water potential, movement of water through a selectively permeable membrane from an area of low solute concentration, pupunta siya doon sa area with high solute concentration until itong dalawa ay magmamatch depending on the solute concentration per area. Pero, hindi lang osmosis ang nag-o-occur. Nag-o-occur din sa diffusion. Si diffusion naman is solute potential. Kanina si osmosis is water potential. Si diffusion is solute potential. So ito naman ay yung mga solutes moving from an area of high concentration to an area of concentration until sila ay magkaroon ng state of equilibrium. So no requirement of energy. No? Both can occur at the same time. Yan. Ngayon, ang nagre-require ng energy ay si active transport, which is number 1, sodium-potassium pump, para mag-push pa ng more water and other products sa loob ng cell. Ipupush ka talaga, hindi niya hinihintay na kusa. Dito walang kusa, itutulak ka talaga sa loob. And also, insulin and glucose regulation. Pag nagbigay tayo ng glucose tapos insulin, kakainin, siyempre ang end product, ang end destination ng glucose should go to the cell. Kasi si glucose, nasa loob siya ng, nasa kapagkain mo, kinain mo si pagkain mo, kunwari nag-drink ka ng milk, tulad kanina, nag-drink ako ng milk, pumasok sa intestine, inabsorb sa intestines ko, nandun sa vessels ko. Pagdating sa vessels ko, hindi siya pupunta sa mga muscle cells unless nandun si insulin. So 2 things will happen to insulin. Meron ba akong insulin or walang insulin? Pag walang insulin ako, magkakaroon ako ng hyperglycemia. So bibigyan ako ng exogenous insulin. Pero may insulin ako, may problema. Si insulin ba ay merong siyang paradahan? Pag wala siyang paradahan sa cells, hindi rin manideliver si sugar. So ano mangyari? Iinom ako ng mga the likes of glipizide, glycoside, no? So mga ganon. Mga oral hypoglycemic. So si insulin ay siya yung kotse na magbibitbit ng sugar from the intravascular space to the intracellular space where they are needed. Pero merong condition na kung saan hindi kailangan si insulin. Ano yan? In the state of exercise. Pag nag-exercise ka, ang sugar kusang lumilipat doon sa loob ng cell, intracellular, without the intervention of insulin. Kaya sa mga diabetic, in-encourage silang nag-exercise. Yun. Osmolality talks about pag sa zero masyadong malapot or increase osmol, ibig sabihin luwa-luwa yung tubig. Dahil siguro ang antidiuretic hormone ko ay hindi na sisikret ng maayos. Okay? So walang pang-hold. So diretso ang pag-ihi. Katulad sa condition kapag may diabetes insipidus. Or sumobra ang sodium load or ang sugar load mo. Or sira na ang kidney mo, yung mga urine, yung mga waste products dapat ilabas, hindi mailabas. Pag decrease naman ang lapot sa serum, meron kang symptom or appropriate yung ADH mo, antidiuretic hormone, sumobra naman ang release, no? So masyadong masyadong malabnaw. And of course, if there's renal failure, diuretic use, adrenal insufficiency. Kabaliktaran naman sa urine, ang increasing osmol is SIAD also. Binaliktad mo lang yung sa serum. Not really all parts of it, but most part. Ganon din sa decreased osmol sa urine. Now, what is the role of the ADH? First and foremost, it acts only on water. Siya yung nag-a-analyze kung ano ang hydration status ng katawan mo. Pag kailangan ng maraming tubig na ma-retain, ang katawan mo kusa siya, magre-reabsorb ng tubig sa distal comminuted tubules or uh, or sa collecting duct, no, para mag-reabsorb ng tubig. Now, well, I will not discuss about the fluid sheet that what fluid do we, how do we prescribe it? First and foremost, anong klaseng volume loss? Bakit kailangan natin mag-ano ng fluid? Anong gagawin natin? So, one, you have to classify crystalloids ba ha? No, meaning meron ba siya sugar or salt content na they form crystals, no? Like your saline, yung mga salt solutions mo, at saka sugar, yung dextrose. And colloids mo, it can be blood, it can be protein derivatives, it can be starch, no? I love more starch kasi nagpapataas siya ng BP, pero hindi siya ganong nagre-react sa katawan, hindi katulad ng mga dextra, no, yung mga protein components. May kasabihan sa fluid replacement, replace blood with blood, replace plasma with colloid, and resuscitate with colloid. No? Resuscitate with colloid yung replace blood with blood and replace plasma with colloid. Resuscitate with colloid, ibig sabihin para tumaas ang BP, and replace extracellular fluid depletion with saline. Iyan yung mga interstitial. And rehydrate, pag sinabi kong rehydrate, cellular focus tayo. How do we rehydrate the cell? So we will use dextrose. Ayan, para maintindihan nyo ganun ang format. Sorry, hindi ko pala na-feed kanina. Ngayon, ang ating objective is to create an equilibrium para ang normal functioning sa tao sa loob ay maayos niya, no? Yung homeostasis. Ang katawan natin kumukusa, except lang in times of trouble, pwedeng you had burn or you had kidney problem. Yeah. Now, what are the different kinds of IV solution? Number one, yung pinaka-hypotonic natin, which is water and glucose. Tapos yung isotonic natin, which is crystalloid, and hypertonic natin, which is colloid. And of course, yung whole blood. So ang whole blood marami. PAC-RBC, fresh frozen plasma. So kung anong gusto natin sa whole blood na yun. Sa blood components na yun ng blood products. Pwedeng whole blood siya. No? Now, usually, sa emergency, ang ginagamit natin ay NSS. Ang problema sa NSS, wala siyang, although ngayon, hindi ko pa naisama sa lecture ko, pero hindi pa kasi ako nag-undergo yung mga tinatawag na artificial blood. No? Yung ECMO, naghanap ako, merong lecture ako nakita sa ECMO, yung may artificial blood na yun. I hope I can include it in my future lectures na. It's not really blood coming from human being, but it is synthesized in the laboratory na meron na siyang oxygen. It can carry oxygen. It's like a blood. It functions like a blood. Okay? So, ang karamihan ginagamit natin, it's either LR. Sa American College of Surgeons is LR, pero mainly sa combat medicine is normal saline. Both are okay. So, ito yung mga hypotonic natin. Hindi pwedeng ibigay lang pag meron tayong head injury, one of the H irreversibilities. Kasi ang blood-brain barrier natin, walang discrimination sa oxygen, sa sugar, sa water. Magkakaroon ako ng increased intracranial pressure. Ang whole blood, hindi katulad sa ibang bansa na merong O negative, sa Pilipinas wala. So nang nagtrabaho ako sa abroad, meron talaga akong refrigerator sa loob ng helicopter sa medevac military helicopter sa ambulance. Meron siyang refrigerator na succinylcholine ko andon, yung antivenin, saka yung whole blood O negative. Yung O negative, pag blood loss yan, bigay mo kaagad yun. Hindi wala kailangan ng cross-matching kasi hindi siya magre-react. Kasi wala siyang antibodies to fight back. Wala siyang antigen para ang antibody sa katawan, tirahin siya. Okay? Now let's see what will happen dito. So tingnan nyo ang cursor ko. Ito ay intracellular, ito ay interstitial, ito ay intravascular. Tingnan natin anong mangyari kapag magbigay tayo ng fluid. Okay, number 1. Nagbigay ako ng 2 liters of blood. Anong mangyari? 5 liters of blood. Walang mangyayari. So 3 plus 2, siguro ko grade 1, no? 5. Okay, next. Nagbigay ako ng colloid. Ang colloid ay high saturated na protein. Grabing protein na to. Mag 5 liters siya. Ang problema, because of oncotic pressure, i-absorb niya ang ibang fluid. Akyat pa siya sa 7. Kung gusto mo talaga dramatic yung pagtaas ng BP mo, colloid ka talaga. Yun lang, wala siyang oxygen carrying capacity. Pangalawa, na-starve niya konti ang aking intracellular, na compromise niya. Next. Bigay ko ng saline, 2 liters. Akyat siya ng 5 liters, pero hindi siya doon sa intravascular, kailangan pumunta siya sa interstitial. Pero may naiiwan. Kaya maganda pa rin si saline, no? Kasi mahaba ang shelf life, may naiiwan, nakapagpataas pa rin ng BP. Bigay ako ng dextrose. Tandaan niyo si dextrose, ang unang kailangan ng katawan natin ay sugar. Diretso kaagad siya, papunta sa loob ng cell. Okay? So, punta tayo sa mga tawag nito. Not discuss the water loss because karamihan sa hypovolemia natin ay blood loss. Dito lang tayo sa electrolytes. Sodium natin is a major cation. Pag kumulang tayo, nagpa-hyponat tayo, nagkakaroon tayo ng cramps, no? Yeah. Pag na-hyponat, hindi makaka-function din si potassium kasi kulang si sodium. So, nagbibigay tayo ng exogenous. Okay? Pinapainom natin ng mga matataas na mineralized water or what. Pag hypernatremia naman, because there's deprivation of water, tapos hypertonic tube feedings, lalo na mga geriatric patients natin, although hindi siya pang ACLS. So ito yung mga signs and symptoms niya. Ang treatment is, well, that's not a problem of ACLS. Dito tayo sa potassium kasi ito talaga pang ACLS. Hypokalemia siya, magkakaroon ako ng problem sa heart. No? Tingnan natin, mag-cardiac arrest ako, depressed babagsak yung aking T-wave, no? At mag-arrhythmia ako. So bibigyan ko siya ng sodium chloride, saka ng potassium chloride, no, ganun. Pag hyperkalemia, it's another problem. Magkakaroon ako ng peak T-waves or yan, 10 T-waves tawag dito, peak T-waves. No? Pero marami siyang gamot. 10% calcium chloride or calcium gluconate. 2B kasi ito si sodium bicarb, naging 2B dito. Pero pwede ibigay, no? Kung meron ka, 2B. 50% glucose solution plus, kalimutan ko ilang ano. Doon i-discuss ko yun sa pharma. Kung ilang percentage ng insulin. Tapos kayexalate, parang sa enema. Tapos salbutamol. Kung hindi kaya, pwede ka mag-dialysis. Okay? So yan, no? Mas maraming treatment sa hyper-K. Saan pa ba? Calcium, basahin nyo lang si calcium. Dito ako sa magnesium. Magnesium, pag kumulang si magnesium, naku, Diyos mio, yan ang magkakaroon tayo ng polymorphic beta. So bibigyan natin siya ng sodium magsulfate, which is 1 gram to 2 grams. Okay? So I will stop there kasi yan lang naman yung mga highlights sa ACLS sa mga gamot na yan. Then my next slide is pharma. Any question? Ano yung pharma ko? Saan ba yun? ACLS drugs, ayun. Hindi ko pa naayos tong drugs na to. Sige lang. Ayusin natin. May mga tanong kayo, kung medyo salungat sa inyong hospital protocol, we can raise it here kasi minsan may mga purist talaga na AHA ako na hindi pinapractice sa Pilipinas. Katulad ng yung tama yun? Trinitroglycerin. Okay? GTN or GTN. So 0.4 to 0.5 milligrams dito sa Pilipinas, sublingual sa amin yun. Doon sa labas. Pero dito ang ginagamit niya it's either mononitrate or dinitrate, isordil, mga ganun. So yun lang yung mga differences na i-settle natin. Okay? So objectives natin, nagbigay tayo ng drugs para i-correct natin yung lahat ng binanggit ko na H and T's. Okay? Now, karamihan dito, ibigay natin bolus dose, sakto, ordered by the team leader, mostly physician. Plus 20 cc NSS or ARM, pero 40 cc NSS pag tibial IO. Tapos routes of administration are IV and IO. Hindi na tayo nagbibigay ng intracardiac. Pag nakakita kayo ng intracardiac, nako, wala na talaga yun. Bawal na yun. At hindi na tayo nagbibigay ng gamot endotracheally. Okay, epinephrine ang pinaka-celebrated natin emergency drug. It's a chronotropic drug, no? Hango sa protein tyrosine. Ang trabaho niya, stroke volume pinapataas, BP pinapataas. Pero matindi siya kumain ng i-require niya ang heart muscles to eat more oxygen. Okay? Tapos automaticity pinapataas niya. Kaya kahit mag-flatline ka, binibigyan natin si epinephrine hoping na mag-fibrillate siya. Kasi pag nag-fibrillate si flatline, pwede pa natin ma-defibrillate. Kasi pag nadi-defibrillate mo yung rhythm mo, mas madaling buhayin kesa sa hindi na nagpifibrillate na rhythm. So ang dose natin initially noon is 1:10,000. Ngayon wala na. Bigay na lang natin epi. Pero dati nagwa 1:10,000 kami. Pag meron akong 1:1,000, ang ginagawa ko, kumukuha ako ng 9 cc NSS plus 1 cc, so may 10 cc ako. 10 cc, 1 cc epinephrine, ang itulak ko is 10 cc NSS. Pag drive ko dito, another 10 cc, nandito ang IV ko sa dorsum of the hand. Tama na 'yon. We can also use as a drip. Okay. Now we have an atropine na it blocks the action of acetylcholine at parasympathetic sites in smooth muscle. So binibigay natin ito sa body. In so doing, napapabilis natin yung heart rate. Not in the pathway na kung saan bumabiyahe, nag-a-act yung receptors katulad ng epi. No? So ito iba ang pathway niya. Okay? Tapos symptomatic brady, no? Although sa type 2 second degree or third degree block in a nodal tissue. Pero ito yung initial drug na binibigay natin. Bago tayo mag-escalate into dopamine. Okay? So other than that, atropine binibigay natin sa chemical warfare. So may standard ang atropine, ganun din, no? At saka binibigay natin sa pag na ka ng mga poison, letter C. Poisoning, yung mga fertilizer derivatives. I forgot. Tulungan niyo na lang ako. Grabe, nagja-jam yung ulo ko. Magsul, binibigay natin to sa hypomagnesemia, torsade de pois. Pero ang pangit dito sa Pilipinas, ang magsul natin ay malalaki yung plastic vials, 250 milligram. Ang ibibigay natin minimum is 1 gram. Isipin mo, para maka 1 gram ako, kailangan ko muna merong 4 na magsul na malalaki. Eh kung 2 grams na requirement, kailangan ko merong 8. Ang 8 magsul na preparation, kakain na ng aking drug kit. Yan yung pinakapangit. Ewan ko kung dito yung makagawa ng gamot na maliit lang. Nandun na lahat. Hindi yung parang ating sodium bicarb. Alam mo, ganito kalaki yung sodium bicarb. Ilagay ko sa drug kit ko, nabiak pa, na swimming pool yung drug kit ko. Hindi man lang tayo magagawa ng aboject. Kitaan ko tayo bukas ng aboject. Ando na lahat, no? Hindi yung balik-balik, lalo na epinephrine, tapos made in India, baliin mo, adurog. Very funny. So, yan si Torsad, no? Sodium bicarb, pakitaan ko kayo na halos wala na siyang pagagamitan unless tricyclic ito yung antidepressant overdose, effective pa siya doon. Okay? Bawal na siya sa hypoxic lactic acidosis saka sa prolonged cardiopulmonary arrest. Kasi tulad ng sinabi ko kanina, yung COR, class of recommendation, class 3 na po siya. Ibig sabihin, harmful. Dopamine, derivative also from the tyrosine, protein tyrosine, like your epinephrine. So, precursor of norepinephrine siya, pero bawat level, meron siyang action. Dopamine, Dobu. So, ang standard dose mo is 2 to 5 microgram per kilogram. Microgram per kilogram. So, 2 to 5 dati. 2 to 5, 5 to 10, saka 10 to 20. Pag 1 to 5, pag 1 to 5, tinatawag nilang renal dose. 5 to 10, ang tawag yata noon, cardiac dose. 10 to 20, ang tawag vasopressor dose. Ngayon, wala na pong ganun sa bagong patakaran ng AHA ngayon. Isa na siya, from 5 to 20 microgram per kilogram per minute, pero nakatitrate siya. Depende sa angat ng rhythm ng heart. Amiodarone is an antiarrhythmic drug, no? Ang kanyang preparation is 150. So binibigay natin to initially sa emergency at 300 mg, no? Pero pag pag i-drip natin, ilagay natin sa 20 to 30 ml D5 water. Tapos binibigay din natin sa white complex Taki, 150 mg, no? Ang pangit lang nito, nagpapabagsak ng BP. Lidocaine, dati naging class indeterminate, pinalitan to ng amiodarone. Binalik na naman siya ngayon. Nandun siya noon, winala, binalik. Ganun lang naman ang dynamics ng medical science. So nakitaan nila na si lidocaine ay nagpapadecrease ng automaticity, yung ventricular ectopy. Kaya ginagamit din natin siya even into a drip. Nag-ROSC na ko because of a Taki, bugbog sa tachycardia, tapos na ROSC, nabalik ko. Then I can drip lidocaine. So ang makikita mo ay 100 mg, okay yun, ibigay ang 100 mg. Tapos bolus. Tapos kung gusto mong i-infuse, 1 to 4 mg per minute. Procainamide, mga third level to third tier. No? Ito yung mga binibigay natin sa mga stubborn na mga Taki, no? Yung mga SVT na makulit. Tapos hindi ayaw mo siyang i-cardiovert, you can use procainamide. So 20 mg per minute up to 50 mg per minute. No? Adenosine is our first primary drug in SVT. It's a class 5 antiarrhythmic agent. Ang preparation niya is an amber vial of 6 mg. Ang bolus sa kanya ay as in bolus talaga. Mabilisan, within 3 seconds dapat nasa heart. Pag dito ko binigay, pag sirit yan, siritan mo kagad ng NSS. Therefore, gagamitan mo siya ng 3-way stop cap. So 6 mg, the next dose 12 mg, tapos 12 mg. Ang interval is 2 to 3 minutes. Aspirin, ang available sa atin is, hindi ko alam kung 80 or 160, pero sa labas, may 3 to 5, you have to chew it. Ako, yun ang pinakaaya ko. The most hated drug ko to. Nung panahon maliit pa ako, wala pa kaming paracetamol. Pag may lagnat kami, aspirin. sabihin ko sa'yo, sumusuka. Pag sumuka ako, may lagnat ako, palo ako. Napakapait ng gamot na yun. So itong aspirin, siya pa rin yung mainstay para sa MI. Mamaya i-breakdown natin. Nitroglycerin, ito yung GTM or NTG. No? Meron itong malaking vial, ampule, sobrang laki. Meron din siyang tablet na 0.5 or 0.4 mg. Ito 0.4 mg. Yung mga pwede tayo mag-IV bolus o 25 microgram kung wala kayong sublingual. Morphine, the best. Huwag mo lang siya ibigay sa merong inferior wall MI. Hirap habulin ng hypotension. Nagkaroon ako ng kasong ganyan. Ako, grabe. Grabing bolus ng fluid ko kasi nag-hypo. Na-miss ko yun. Grabe, hypo talaga ako. MI, nag-hypo talaga. So yun yung ko. Pero napakaganda niya kasi pinapakilaman niya pati yung preload. Ang galing ng morphine. Napapabagsak din ng auto requirement, stroke volume mo, yung venous capacitance tinataas niya. Kaya pinapabagsak niya yung cardiac preload. Itong mga antiplatelet agents, 2B, glycoprotein 2B, and 3 agents, hindi ko na pinapakilaman. Although sa ACLS book, meron silang mahaba-haba konting literature just to unpack. Pero hindi na ako umabot kasi by the time ang pasyente nasa ospital na. Ang meron lang ako ay hindi antiplatelet ko, hindi itong mamaya later grabe nag-jam yung utak ko. Meron akong binibigay doon to remove the plate. ACE inhibitors, well, meron ako tabletas lang. Fibrinolytic therapy, yes. Ang meron akong dala is streptokinase 750 IU. Pero ang pinakamaganda dito is alteplase saka anistreptase. Hindi ko alam anong presence ng iba ko dito sa Pilipinas, kung anong ginagamit nyo. Enlighten me kung meron kayong ginagamit ngayon, mas maganda. Pero ako, bakit streptokinase? Kasi hindi siya mahirap alagaan pre-hospital. No? Pero nung nag-remove ako nag-fibrinolytic therapy ako sa sobrang layo ng biyahe ko, nag-arrhythmia yung heart ng pasyente ko. Na-resolve ko naman ayos kasi biglang nagulat yung heart ko, natanggal yung bara. Nagulat. So nag-arrhythmia siya. Buti nahabol ko pa. So streptokinase 1.5 million IU lang yung ginamit. 2 ampere. Kaya pa rin, hindi ako nakagamit using my hand, but another doctor na South African, nag-assist lang ako sa kanya when he gave low molecular weight. Beta blockers, yes, of course. So balik ako dito, pag nagbasa kayo ng ACLS handbook or manual, dadaanan niyo ito lahat. Bawat drugs you mention, first time ma-mention siya, lalagyan siya ng COR and LOE. Okay, how do we settle hypoxia? First and foremost, FiO2 100. Intubate the patient to the most part. Kung kung ACLS yun, intubate. If not, kung hindi naman arresting heart, non-rebreather. If you doubt, non-rebreather at 15 liters per minute. Hypoglycemia is either mag-D10 or mag-D50, malapo. Meron tayong mga tinatawag na itong mga level 1, level 2, level 3. Ayan, classification system niya, no? So, ang ginagawa ko, ina-IV ko lang talaga siya. Kasi ang tagal pag i-IM ko. Tapos mas nasasaktan ng pasyente. Now, if this is not really too low, kaya naman ng IV dextrose na D10, the best treatment for inpatients. Pero siyempre, pag out of hospital ako, gusto ko talaga may drama, D50 ako. Sa out of hospital. Ngayon, hypovolemia, pwedeng crystalloid solution or mayroong blood transfusion. So, depende yan. No? Hypokalemia, potassium chloride, 40 mg, incorporate sa 0.9 NSS 1 liter. By the way, kung hindi ito yung patakaran ninyo, you can correct me, pero lately, ito yung ginagawa namin. So, pinaghalo ko yung ACLS dito sa yung local practice. Sa hyperkalemia, depende kung anong klaseng level. So, meron tayong mga sinusunod dito, yan o. Yan. So ano siya ito? Pag moderate elevation, meaning ang aking blood result is 6 to 7 milliequivalent per liter. Pwede ako magbigay ng sodium bicarb up to 50 mx. Dito naging class 2, naging class 2A yata siya o class 2B. Then, bigay ka ng glucose 50, tapos tulakan mo ng 10 units regular insulin and give IV over, sa IV no, over 15 to 30 minutes. Kaganda ng resulta nito. Tapos nebulize kayo ng albuterol, mga 10 to 20 milligrams every 15 minutes. Makikita nyo, babagsak ang potassium. Pero pag tumaas, more than 7, which is severe, then you can use calcium chloride no, plus sodium bicarb. Pag mild elevation, 5 to 6 lang, 5.5, 6. Well, ako ayaw ko mag-puro. Ang pwede ka magbigay is Kayexalate. Hindi ko alam kung meron kayo dito. It's like, it's a sorbitol either orally or by retention enema. Yeah, no. Then, you can also give 50 gram glucose plus 10 units regular insulin and give IV over 50 minutes. Okay. Give at the same time the 50-50 1 vial per amp plus regular insulin 10 units IV for 3 doses every 2 hours interval. Calcium gluconate 10% 1 amp every, okay, slow IV and salbutamol puff every 4. Dito pa lang maganda na yung drama ng ano mo, potassium. Acidosis 2 mg per kilogram sodium bicarb. Pero ang ginagamit natin is adequate oxygenation lang. That's how to reverse it. Okay, so severe 90 to 80, yan ang dosing considerations ng hypothermia. Balutin mo lang yung tao. Maglagay kayo ng heat packs, tingnan niyo ako. Kilikili, Nate. Huwag sa dibdib kundi sa tiyan, tapos dito banda sa bayag sa baba, no? Sa inguinal ibaba mo. Balutin mo yung pasyente, ang BP mo, itali mo yung i-duct tape mo yung stethoscope. Taglit. Okay? So ngayon, ang stethoscope, i-duct tape dito, nakalabas dito. Ang BP apparatus nakalabas, sa kabila pulse oximeter, hindi yung digital labas dito. Ang lalabas lang sa ulo ang lalabas lang ay mukha ng tao. Hindi pwedeng magbalot kayo sa hypothermia yung extracorporeal rewarming. Ang ulo nakalabas kasi magra-radiate pa rin ang heat dito, pwede siyang maubusan ng heat. So ang hypothermia, meron tayong tinatawag na 4 stages. Kung saan, yan, stage 1, from hanggang 32. 32 to 28, stage 2. Dito, pwede na mag-cardiac arrest dito. 24 to 28, hirap-hirap talaga dito. Tapos ito, wala na pag-asa. 24. Although, habang kung isi-CPR mo siya, wag mong hintuin ng CPR hanggat hindi ka nag-35 degrees up. There's a saying, the person is not dead until he is warm and dead. Yan ang rules sa hypothermia. Medyo kabisado ko to, ladies and gentlemen, kasi ang training ko environmental emergency sa wilderness medicine. No? So medyo iko-correct ko tomorrow kung sino sa inyo sa first aid, iko-correct ko yung mga heat illness management ng maraming mali sa Pilipinas. Hindi ko naman sila sinisisi, nagkataon hindi nila specialty. Kaya pamali-mali. No? Even the way they treat the burn, in a very austere way. Hindi siya maganda. I will not say sorry. No? Kasi minsan tayo mga doktor, mataas din ang pride natin, ayaw nating maturuan. Tapos hindi naman natin linya ang wilderness medicine, wala namang kursong ganito. Hindi natin, pinapabayaan lang natin, thinking na yung ating skill sa IM is enough. No. The wilderness, the medicine out there is crazy. It's 359 degrees ang consideration mo. Hindi ganun kadali ang field. Kailangan saktong gamit, study ng gamit, hindi siya. It's not easy as you describe, as you read it in the book. Kaya hypothermia, madali siya i-manage, pero very sensitive siya. Konting kabog mo, arrhythmia ka agad dyan. In the presence of a J wave or Osborne wave sa ECG. Very prone siya sa arrhythmia, fatal arrhythmia. Kaya may kasabihan, pag sobrang lamig, ang heart ang naapektuhan. Pag sobrang init, ang brain ang naapektuhan. Kaya nagsiseize ang tao sobrang init. Sa wilderness medicine, ang tawag namin doon, cold heart, hot head. Okay, so normally, i-ano lang natin siya, i-rewarm lang. Pwede tayo mag-ECMO, extracorporeal membrane oxygenation. Tapos warm na yung pumapasok doon, no? Kung meron tayong ECMO. Okay, so yan ang ating intervention line. Ito, basahin niyo lang to. Sa 3, nag-ECMO tayo. Okay, toxins, depende sa toxin. Na-overdose ka, benzodiazepine, siyempre flumazenil, no? Cocaine, benzodiazepine, so yan lang, no? So hindi ko na siya per level, no? I mean, read it in toto. Anyway, you can have my slides, no? Ito yung mga gamot. Kasi one of the insults na kaya ka nagka-cardiac arrest is because of the presence of some toxins. Like kanina, nang sinabi ko sa BLS, na overdose ka lang ng opioid, kailangan mo ng Narcan, naloxone, no? Or else, hindi kita kayang i-reverse, no? So ito mga samples lang itong nakalagay dito. I really don't. Itong cardiac tamponade ay i-demo ko. I-demo ko to siya. So tingnan niyo lang ano yung Bextriad, no? Bextriad, alam niyo sa Bextriad for cardiac tamponade because I was able to treat cardiac tamponade in the field 4 times. Lately wala na. Pero when I was still sa abroad, naka 4 times talaga. 3 years, 4 times, napakaswerte ko talaga. Tapos tension pneumothorax, naka 6 times ako. Yan, tension pneumothorax, hindi ko siya i-describe ngayon, i-demo ko siya because I know you can read it, you can watch it in the YouTube, pero ako i-demo ko siya paano gagawin. Kung saan ini-insert, okay? Thrombosis coronary, ito yung mga kung ST elevation MI, yan, no STEMI. Doon kailangan natin yung PCI. Okay? Kung unstable naman, anong kailangan natin? So, usually, muna pa rin sa akin, muna lang naman talaga ako eh. Morphine, oxygen, nitroglycerin, aspirin. So, ito, pag meron tayong STEMI, ito yung face mask. Okay lang yung face mask. 6 to 8 liters. Okay? Tingnan mo FiO2 mo. Or 4 liters by cannula. Tapos 4 tabs aspirin, 80 mg kasi yan yung available sa Pilipinas. Nag-adjust ako sa Pilipinas, guys, ha. So 4 tabs. Kung wala siyang allergy. Kung meron kang morphine, IV ka. Start conservative ka 2, pero okay ka hanggang 4. Increment mo 2 to 8. So every 5 to 15 kung meron kang morphine. Ngayon, pwede ka magbigay ng 4 tabs clopidogrel. Although may mga studies na medyo may effect siya sa Asian population, pero wala pa naman eh. Nagtatanong-tanong ako sa mga IM sa cardio, bigay pa rin. 4 tabs clopi, 1 tab ator. Nagugulat kayo, ator? Yes, 1 tab lang. 80 mg ator, tapos ito ang pinaka-the best. Enoxa pa rin ka. 0.6 cc subcutaneous bigay mo, tapos transport for PCI ka. Okay, bakit naging ganito? Transport for PCI. Ibig sabihin, i-deck mo na siya for PCI. Kung merong yung hospital mo PCI, panalo yan. So, yung sinasabi ko kaninang door to needle, yan. Okay, door to needle or door to balloon. Sorry, door to balloon. Door to balloon from the bahay to the balloon. PCI. Paiksiin natin yan. Okay. Pag pulmonary naman, edema, kailan kami nagkakita ng pulmonary edema? Pulmonary edema, pulmonary thrombosis. Usually, pag meron kang rhabdomyolysis dahil nadaganan sa earthquake, i-expect ko meron yan. So nakaabang kami ng heparin. Hindi ako wala akong warfarin, heparin ako. 80 units per kilogram IV bolus, 10 continuous infusion. So heparin lang yung ginagamit ko. Hindi ko alam kung ano ang patakaran niya sa warfarin, pero the least kasi gamot ang bitbit ako. Ang meron lang ako heparin, pero special siya kasi ang warfarin bawal din mainitan eh. Okay, so merong mga enox na pa rin, pwede ka rin magbigay, no? Enox talaga sikat eh. Tinsa pa rin, alam ko mahal to eh. Okay, itong Arextra, naku po, Diyos mio, napakaganda nito, 5 mg. No? Mahal lang to. So pwede kang mag-Punda Parinux, no? Arextra. Tapos yung mga traumatic brain injury, spinal injury, well, bahala kayo sa in-hospital kung anong style niyo, pwede kayo mag-decompress sa brain kung intracranial pressure. Sa amin, nilalak lang namin ng splint. Tingnan niyo sa video ko ha. Katulad dito. Hindi na kami gumagamit ng C-collar. X-collar dapat. Kung nakatabi niya ang ulo, i-adjust mo lang na natatabi na ano to napapalit. So ito talaga kasi hindi na dadaan, hindi maiipit yung aking jugular vein. Pag naipit yung jugular vein ko, tataas yung intracranial pressure. Kaya ang pinakamaganda ngayon is always the next splint or an X-collar. This is an X-collar. Kaya nag-invento nito, footballer. Kaya maganda siya. Okay. What else? Morphine sulfate, yan. Maulit na lang, no? Ano pa bang meron ako dito? Propionamide. Isoproterenol, yung isoprel. Well, sa mga BP na erratic, no? Tama ba? No. Sa ano? Sorry, mali ako. Sa bradycardia, refractory to atropine yan. Yung isoprel. Although hindi ko maano sa torsad refractory to magnesium sulfate, hindi ko ano unless correct me kung binibigay niya 'to. Mirapabil, ito ang karamihang meron ako kasi pag hindi ko kaya ang adenosine, bera ako. Magsul, propranolol, yan sa BP, ito yung sa BP na. Binibigay din natin to sa RVR, rapid ventricular response ng AFib or ng atrial flutter with rapid ventricular response, AFib with rapid ventricular response as a tertiary level. I mean third level drug. Third level. Okay. Vasopressin, hindi na natin siya binibigay. Nakasabi ng 2020 ACLS guidelines sa medication. Routine use not recommended. Calcium and magnesium, sodium bicarbonate, pati si vasopressin offers no advantage over epinephrine. Ganon din itong si Nor-E naman, si Nor-E binibigay natin to, similar effect. Cardiogenic shock, Nor-E. Pag dopamine, second choice after atropine. So maganda to, no? Good effect. Sa ako, ang dami kong mga good outcome dito. Si dobutamine namin kapag merong CHF with hypotension. Although meron kong Dobu, saka si Nor-E, pero hindi siya sikat katulad sa dopamine. Well, sa ACLS hindi tayo nagda-jokes, hindi tayo nag-digitalize kasi ang CHF is under AMLS, is not ACLS. GTN at 0.4 milligrams of
Hello po, good afternoon po. Tinawagan ko po si Doc Ted. Nakat daw po yung line niya. Bale daw po yung continuation po is tomorrow po ulit, 8 a.m. po. Then yung mga kakapasok lang po for ACLS kaninang 1 p.m. po. Pasend po ako ng attendance niyo po. Yung name po na isi-send niyo is yung name po sa certificates po. Yung mag-a-appear po. Send po ako ng example po. And also yung certificates nyo po, by Monday po namin siya isi-send through email po. Yung mga gusto po mag-avail ng hard copy po, pwede naman po. Bale, 200 pesos po siya, free shipping na po nationwide. Kung gusto niyo po mag-avail ng hard copy po, pwede na po kayo makipag-coordinate sa mga coordinators niyo po. Yung mga nakapag-send na po ng names and wala na pong questions, pwede na po kayo mag-leave po. Tomorrow po yung continuation po, 8 a.m. po ulit. Thank you po.